Thank you for the kind introduction. My name is Sia Fotieno. I come from Kenya. I want us to just go through quickly about the cardiovascular diseases and diabetes mellitus in persons living with HIV in Africa. And so that's the outline. We'll just get a brief background. The phenotypes, a brief about diabetes, the risk factor profiles, and of course, very, very briefly about epidemiology because we don't have a lot of figures, but more so at programmatic level, the implication to care needs, how do we take it forward to program level. So quickly, for those who do diabetes and HIV, there are the overarching objectives of care. And the primary goals of HIV care, usually epidemic control is very, very central, and now we are much more focused on a patient-centered approach so that that patient who has HIV is a true focus, not to spread it and not to die. Then, of course, that same patient you need to eradicate, especially mother to child, new infections, mother to child, and then, of course, adults, very risky contacts, pre-exposure prophylaxis, and then, of course, whoever has HIV, you need to improve the quality of lives. So this has been done successfully, and our patients are living longer, and that has implications. So quickly, we want to stress Asia and the Pacific, and then of course the Eastern and Southern Africa, those orange and those zones. You notice we started off in 2010 in earnest, and we've been coming down on the prevalence of HIV/AIDS, and it is obvious that we are living longer. Our patients are living longer, and that is extremely important. And we are saying that if these efforts continue, then we should be coming down on the prevalence and achieve the targets that have been envisaged. Initial was 90, 90, 90. Prevention, linkage to care and treatment, and suppression. Now you're 95, diagnosed, linked to care, effective in treatment, and sufficiently suppressed. So this is just the burden, and you can see the what we call the population attributable prevalence, and the burden is largely sub-Saharan Africa, and then of course Russia and US, Brazil, and when you come to the disability life adjusted years lost due to HIV, and therefore the implication in terms of cardiovascular morbidities that coexist with HIV, that is a significant burden. The scale up to treatment again, you notice the blue, that is Eastern and Southern Africa. And you can see through external support and local government, country government investments, there has been a significant scale up to that level when data was available, much more, yes. And we are now going to have, I'm trying to build up the burden of the disease amongst us. At WHO level, what are the main causes of mortality globally? the 2000 is unshaded, 2019, and you can see that it's still ischemic heart disease, and same more than 12 years ago, it was still major cause of mortality. And then, of course, stroke. So this is cardiovascular. Then the COPD or respiratory, you can see there is some abating, but basically diabetes is increasing, kidney disease is increasing, and then the cardiovascular. So that's the burden in general for the non-HIV population, and of course, and the HIV population. So you can see it's increasing cardiovascular morbidity in both. So what are the phenotypes of the cardiovascular diseases in HIV that we are talking about? We are talking about HIV-associated atherosclerotic cardiovascular disease, and that is myocardial infarction and stroke, HIV-associated heart failure, and of course the other manifestations of cardiovascular disease, as the peripheral vascular disease, atrial fibrillation, sudden death in HIV, like myocarditis and all that. So those are the phenotypes, and they also tend to occur in a higher, or at a higher prevalence than it is in the general population. And this is a paper by Anup Shah that was evaluating the association between HIV and cardiovascular disease and the burden of HIV thereof. And this is a meta-analysis in that paper, and just shows that HIV enhances cardiovascular disease to more than twice compared to the general population. This slide, I loaded it there just to show us how do you assess HIV associated, or generally, not HIV associated necessarily, but atherosclerotic cardiovascular disease. And you can see CT, PET, ultrasound, flow-mediated endothelial assessment, and all that. You can, the easier ones that we now have is the echocardiography and other forms of cardiac ultrasonography. I want you to envisage the capacity of your centers at primary care to define in detail the cardiovascular disease, its presence or absence. So I've already persuaded you that indeed people living with HIV are at an increased risk of NCDs, non-communicable diseases, and there is an association, maybe in certain individuals, that certain antiretrovirals are a cause, but certainly inflammation is the driving factor. And of course, when the inflammation works together with the traditional risk factors, then the disease process is enhanced. Indeed, you will see what are the drivers. Then, naturally, when your patients live longer, then they develop the diseases they would have, and that wouldn't have been there if they had died earlier for the HIV reasons. So that HIV population, this is South Africa, where that prevalence is still quite high. In that study, hypertension occurred at that rate, over 40%, diabetes, again, 20%, and overweight, you realize, was also about 50%. not much different from the general population, but this for South Africa is very high. I'll just show you shortly the Ugandan version. But the message is hypertension, type 2 diabetes, obesity are quite high in that population. The traditional NCD risk factors that you know that drive cardiovascular disease is what we are talking about. Then, of course, this is now weight gain. And you can see thank you. You can see the strand inhibitors are actually higher on the list, protease inhibitors than of the NNRTIs. And of course, the example of the strand inhibitors are dolutegravir, raltegravir, and EVI. Those are the strand inhibitors that are now in use, very effective in viral suppression, but also very effective in the weight gain. As you notice, the weight gain after 2 years, anything about 5 kilos, 5 years, 6 kilos. But in certain populations, like in South Africa, you can see weight gain in women going up to 40 kilos over that period of time. So age, weight, driving the cardiovascular risk in terms of that survival. So we had published in our own setting about lipodystrophies, and the lipodystrophic situations are also associated with insulin resistance and the risk to diabetes. So this is just to stress the age component, that in the developed world, people now live their fullness of life, and in our sub-Saharan Africa, still shorter than the developed world, but people are living longer. And in summary, that the heart has a positive impact on securing lives. Again, this study, Swiss study, age, as you notice, is a critical factor, and there is more life years added to our patients. And of course, you can see the area under the curve of the cardiovascular risk profiles as estimated from the risk engines, the cardiovascular risk engines that are in use by the normal population. So that is something to remember as part of the evaluation, that you can use the risk engines, but you can also use the diagnostic workup that I showed you earlier. So this again is just stressing that your patients, when they add 5 years older, they enhance their risk. When they are male, that enhances their cardiovascular risk, previous cardiovascular disease, smoking, family history, presence or absence of diabetes, and of course, hypertension. So traditional risk factors interacting with a chronic inflammatory process of HIV to enhance atherosclerotic cardiovascular disease. And our patients actually develop the cardiovascular disease much earlier than anticipated, maybe about 36 to 40 years. And that brings that condition about 10 years earlier. This is Ugandan, telling us about the lipid profile. If you look at the cutoff of less than 1, you can see about 20%, 20-25% total cholesterol. If you take about 4.2 of the ATP3, then you notice about 15 to 20% The bad cholesterol, if you take it at around 2, then you notice about 20 to 25 as well. Triglycerides, less than 1.7, again, about 15 to 20%, and that is a Ugandan study. So this is the same data. You can infer obesity at about 32 to 46%. Then, of course, hypertension at that level. Then the cholesterol that I've talked about. So these are the same, in summary, just to overemphasize that cardiovascular risk is driven by multiple factors in HIV, and HIV, chronic inflammatory, probable role of treatment, and then, of course, living longer to experience all these events. Again, when you look at the chemistry, beyond the chemistry, these are now the issues we are talking about, that we've talked about. Behavior, this is largely diet and physical activity, because the messaging in HIV is different. When you gain weight, you look better. The image is enhanced, yet in usual isolated diabetes or hypertension, we tell you lose weight, physical activity, and many things. So the messaging for public health control or approaches, you realize that we need to harmonize and find a message that resonates with our patients, that keeps them healthy, positive image in terms of outlook, without what I would say reckless eating, because they think when you are well, you must eat and look good. So that is important point of debate that people can talk about later. What about diabetes in isolation? Diabetes is a disease of aging beta cells. Diabetes is a disease of ineffective insulin utilization, and of course the genes. So when you gain weight, you stand a higher risk. You age, you stand a higher risk of diabetes. So then, these are the risk factors of diabetes, the classical one, and then of course, what may be obtaining in HIV. HCV, not very common in Africa, but proven as a pancreatic and liver cell damage. So that enhances its role in, there are certain phenotypes, or genotypes, not phenotypes, genotypes of HCV that are known to cause pancreatitis or diabetes, as it were. Then, of course, the interleukin-6, tumor necrosis factor alpha, and those other inflammatory cytokines. Then the protease inhibitors used to cause lipodystrophy, but the hypertrophic type that enhances the centropetal, as well as the centropetal fat distribution, so that puts people at risk. The D40s used to cause a lot of peripheral hypertrophy and also associated with insulin resistance. So that component interacting with the obesity of diet, the physical inactivity, aging, and dyslipidemia also related to the protease inhibitors, you can see it's a fertile ground for further CVD. Then smoking. Smoking as a habit is a very major driver of cardiovascular disease, and we can't take it for granted. In Africa, it is the stigma associated with just declaring they're a smoker, and patients don't fully acknowledge, but indeed smoking is still occurring, and you can see If you never smoked, life expectancy is good. If you ever smoked, gets better if you stopped, but if you are current, the life expectancy is reduced significantly as a cause of cardiovascular disease. So what are we saying? That HIV is a risk factor for enhanced atherosclerotic cardiovascular disease. It interacts with traditional risk factors. What about the treatment? Maybe not particularly. Abacavir was the one highly accused. Now we have the INSTIs, the strand inhibitors, but we are not too sure because they're not long in the market. Maybe we shall know because the patients live longer. And we have agreed that we can assess the presence or the risk of atherosclerotic cardiovascular disease using the risk engines that we use for the normal populations with up to 85% sensitivity, as you saw from area under the curve. And what about the strategies of control? They are shared, and that has programmatic importance. You can use the Framingham risk score. You can also use the SCORE, the systemic coronary risk estimates, and get the estimates, the risk. But we rarely do that in clinics. Then, of course, now hypertension, where it does exist, you know HIV causes or has higher risk of kidney disease, hypertension the same. Atherosclerotic cardiovascular disease causes stroke, then hypertension is the most sensitive value or level associated risk factors whose level is associated with stroke in a very linear fashion, and it comes down even up to systolic of 110. Then, of course, atrial fib and many other things are higher. So you can see how these issues are shared. So I want to share in a bit of data which was under one of the implementing partners by CDC, the American funding, and this is ICAP. And if you look at your patients in terms of the risk factor, at least one risk factor profile, you are saying as age goes higher, then at least one risk factor presence is rising. And the commonest is hypertension, and then of course dyslipidemia is there. Diabetes will take the prevalence of the normal population, but it will be enhanced by the obesity and the inherent risk factors in that particular patient. So that is important at programmatic level if you want to leverage. So we're just stressing that when you have diabetes, the vascular events, coronary, stroke, peripheral artery disease, cardiac failure, and all events are enhanced. This is the care cascade in Southern Africa. The prevalence, screened, put on treatment, linked to care, put on treatment, and controlled. You can see the hemorrhage of your patients at whatever care. So that means we do very badly at picking people up. We miss about 45%, and then even 60% are not available to us in terms of care, and even when we care for them, not many are controlled. This is hypertension cascade, the same old story. Diabetes care cascade in the US, even when you have resources, prevalent, diagnosed, and linked to care, control, certainly better than ours, but they could do better with their resources. So then the care cascades are prevalent, diagnosed, linked to care, and control. So we are doing very badly the world over in terms of the quality of control. And when you see the last two, it's color coding, but just shows that we are not performing very well. I would have shown you about the targets in HIV. When you say 90, 90, 90, then 95, 95, 95, it just shows diagnosed and linked to care, put on ARV, and then amongst the ARV treated, the last 95 must be in viral suppression. So this is just to tell you how blood pressure control leads to, you can see at 3 years, if you control your pressures very well, there is a split in those who have good control and poor control. And that is important. This is 3 years for non-fatal MI and all that, but stroke, you can see within 1 year, there's a split. And that means your patients benefit much more when you control blood pressure and you prevent stroke significantly. This is now medication. The last of this color, the lightest, means many tablets, and in our patients in the developing countries, you realize that we do very poorly with our patients in terms of controlling hypertension for those who will require lots of medications. And that's just cost affair and the investment that you put into. And this is the same story in different light. So you can see low income, our problem when you have this now diabetes, when our patients require more drugs, we suffer much more. So in this, what they call syndemic of communicable, non-communicable, and of course TB, HIV co-infection, it comes with both economic instability and food insecurity. And then that is now a security issue. And how do we leverage on the lessons learned from HIV, heavily funded with very high targets in terms of diagnosing and enrolling people to linking them to treatment, retention to care, multidisciplinarity of care, monitoring, linkages and referrals, which are actually countrywide, then of course self-management issues and assistance, and the community linkages. We haven't done that for our cardiovascular diseases, and we have health system issues in terms of barriers to care, and that affects, again, the HIV, diabetes, cardiovascular diseases, and those are the areas to address if we are going to control the syndemic, so to speak. And as we say, recall, because there is stigma, in other conditions, there is insurance discrimination of diabetes and hypertension, as well as other chronic conditions, because they are pre-existing. There was serious advocacy regarding HIV until now. In insurance, they tell you we have ring-fenced this cover related to HIV, and sometimes that doesn't benefit from diabetes. Hypertension does not benefit from that. So that requires a policy attention. And there are other more potential barriers to integrated models of care because the HIV is ring-fenced, you don't add any other. And the issues are significant. Then there are also opportunities in HIV programming to improve catchment for hypertension and diabetes. Several of that, but no implementation strategy, as it were. So there are lots of investments in HIV response to care, but leveraging hypertension NCDs is still a problem because the strategy has not been laid, so that anybody who has hypertension, diabetes, goes to another center to receive care, because the resources that have been ring-fenced for HIV have not been made available for that. And I'm asking, would the multi-month dispensing preclude the desired closer monitoring and follow-up of hypertension, diabetes? Because in HIV, the more well you get, the less you come to the center, because we give you a multi-month dispensing. But in diabetes, hypertension, you'll realize that doesn't work out very well. And there is also a resource that is plateauing, and people are getting a bit more fatigued because it is the international donor community. Sorry. So we want to leverage on human resources, a much more patient-centered design, the central service provision that is happening now, then differentiated service delivery, and very critical public-private partnerships. How are people like Merck Foundation coming to enhance that? So there are HIV approaches and NCD approaches that need to merge at certain level of designing models of care so that patients benefit. And then, of course, those are the strategies that you can look at in terms of care designs, the health system redesigns that you require to combat this endemic. So knowledge is the map, wisdom is using it. Thank you.
Thank you very much. Good morning all, and warm regards from Department of Cardiology, Kasturba Hospital, Manipal, Udupi, the temple town of South India, and the university village in South India. For the next few minutes, we will discuss about emergencies in cardiology. I am very sure we all will come across emergencies because, as my previous speakers spoke out, the cardiological emergencies, the number and incidents are on the rise. So we will discuss the topic in this fashion. We'll start with acute MI because this is the most common and highest incidence of cardiovascular disease and emergency that we come across. Then we'll go to the mechanical complications of acute MI, how to recognize them, because these people with mechanical complications are at higher risk of death and morbidity. Then we'll move to the next cardiovascular emergency, acute pulmonary thromboembolism, and then pericardial effusion with tamponade, and some of the emergency arrhythmias that we'll see in the emergency department, and acute pulmonary edema. So we know that cardiac emergencies can't wait, so time is of paramount importance. So what do we do when a patient comes to us with cardiovascular emergency? A focused history is very important, perhaps taking less than 1 minute, because we need to focus on which symptom is the most dominant symptom. Is it chest pain or angina? Then mostly it suggests to acute coronary syndrome or acute MI. Is it dyspnea? Then it probably suggests an emergency like an acute pulmonary edema or a cardiac tamponade. Is it giddiness or syncope, in which case, again, it also means reduced cardiac output or a bradycardia or a low blood pressure scenario. After the quick short history, within 1 minute, with a provisional diagnosis or a differential diagnosis, we move to a focused clinical examination. By focused clinical examination, we mean a quick check on jugular venous pressures, blood pressures, and auscultation of the heart for any prosthetic valve sounds or some scars of surgery or muffled heart sounds, things like that. And once we have a provisional diagnosis or a differential diagnosis, we go to the next step of evaluation, that is ECG. An ECG has to be taken within 5 minutes of reaching the emergency department because time is of paramount importance. And what provisional diagnosis we got from history and clinical examination, we will get from the ECG for confirmation. We do an emergency department quick echocardiography within the next few minutes to confirm your ECG diagnosis and to look for any of the complications that needs special attention in the emergency department. Based on all these first 4 points, we go to the specific treatment, and early initiation of specific treatment is very important to save the life and also to improve the quality of life and prevent the patient from developing morbidity, high morbidity scenario. Let us have a few case examples to discuss the way how we should think forward when we see a patient in the emergency. This first patient was a 65-year-old male with hypertension and diabetes. He comes to the emergency with severe chest pain of 2 hours associated with sweating. So most of the times when chest pain is associated with sweating, it probably means that patient is having an acute MI or acute coronary syndrome. His heart rate was 68, blood pressure 90, which is low normal, and the ECG was as given in the next page. You can see that there is ST elevation in V1, V2, V3, V4, V5, anterior chest leads with ST elevation, and there is an additional problem of a right bundle branch block. So this is a massive MI with an additional conduction system abnormality of right bundle branch block. That means this patient is at high risk for death and severe heart failure if we are not very quick to act. Of course, this is the flow chart that we need to follow. We need to see if the patient at the time of first medical contact to the device, that is putting a stent for MI, removing the block, if it is more than 120 minutes or less than 120 minutes. So if you think that the time taken to revascularize a patient with acute MI is more than 2 hours, we can consider thrombolizing the patient. So thrombolysis may be done using any of the thrombolytic agents, but the most commonly used one is tenecteplase because the chances of dissolving the thrombus and re-establishing the anterior flow in the occluded artery is highest with tenecteplase. If we are in a center where there is capability of undertaking angioplasty within 2 hours, then definitely we can go ahead with what is called primary angioplasty, which is the standard of care for patients with ST elevation MI. So this patient came to emergency. We suspected acute coronary syndrome in the first few seconds of questioning itself, confirmed with ECG. Now we need to do an echocardiography to see the next assessment, next level of assessment for the patient. That means we do left ventricular systolic function assessment, the ejection fraction, to make sure that this patient is when he undergoes angioplasty, what are the support care system we need to take care of so that his procedure is at lesser risk for his life. We also look for complications of acute MI like ventricular septal rupture, which is a dreaded complication, rare but dreaded, in which case the patient will have to be taken to cardiac surgery operation theater rather than done by the cardiologist physician. At times, we also look for a papillary muscle rupture, which can yet another mechanical complication of acute MI, which can cause severe mitral regurgitation, acute pulmonary edema, and cardiogenic shock, causing yet another cardiac surgery emergency situation. Cardiac rupture is yet another dangerous scenario which we need to always assess, where the patient will present with hypotension and pericardial effusion, in which case these patients are at increased risk of sudden death, and that also needs to be kept in mind while we prognosticate. So this patient which I showed you, his treatment of choice in a center where I work, because we have a cardiac catheterization lab where there is a facility to undertake this patient for emergency angioplasty, otherwise called primary angioplasty. So primary PCI, primary percutaneous coronary intervention, is the treatment of choice. And this patient, as per our evaluation, was in cardiogenic shock, blood pressure 90 and dropping, pulmonary edema because of the massive MI and very weak heart. So we put the patient on intra-aortic balloon pump, which is a very easy procedure that we undertake in the cardiology cath lab, wherein through the right femoral artery we put a balloon, and this balloon is connected to a console outside, and we inflate the aortic balloon pump in the diastole, and this augments the cardiac output and the flow to the coronaries. It is much cheaper than the more advanced hemodynamic circulatory support systems like Impella and the ECMO that we use in some scenarios. So this is a simple device which we use in many of the MIs, especially large MIs, as an emergency hemodynamic support system before and during and in the immediate first 1 or 2 days where we undertake primary angioplasty. So we went ahead with primary PCI of this patient. This is the video of the intra-aortic balloon pump. You can see the inflation, deflation of the balloon filled with helium so that it is an inert gas, and this will help the cardiac output. And on the right lower side, you can see the anatomy, where the left anterior descending artery here is occluded 100% immediately after it starts. So we have confirmed the finding that we saw in ECG and in echo. In echo also there was significant hypokinesia of the left anterior descending artery territory, which is the anterior wall and the anterolateral wall. Now we quickly wire the lesion. This is the wire you can see through the guide catheter tip, and then we do a thrombus aspiration, because most of the acute MIs in our part of the world, in India, has large thrombus burden, and we do a thrombus aspiration, and then we do an intravascular ultrasound to confirm the dimension of the vessel and the length of the stent to be put, which is actually the length of the disease involved. And then we choose a stent, and then we pass the stent over the wire and then inflate the balloon, and the stent also gets inflated, stent gets deployed and reestablishes antegrade flow. You can see that before there was only blood flow till here. After implantation of the stent, all the blood flow is re-established, and this is the same angiogram and the flow in a lady. In another view, you can see that the left anterior descending artery blood flow is re-established. So this patient, after the procedure, we shift to ICU, give hemodynamic support for 2 days or 3 days. He becomes more stable, heart failure gets controlled, blood pressure improves, then we take out the aortic balloon pump, and 1 or 2 days of heart failure management, medicines optimization in the ward, and then we send him home. He will be on lifelong therapy for secondary prevention of MI and for heart failure. Yet another case, 65-year-old male, diabetes, hypertension, came with chest pain and sweating, so provisional diagnosis of acute coronary syndrome or acute MI, had 1 episode of giddiness, probably there is hypotension or bradycardia or both, confirmed by examination, heart rate of 40 per minute, blood pressure of 80. And this is the ECG. As we suspected, there is bradycardia, the QRS rate is low. It is about 45, and the P waves are there, but they have no relationship with the QRS. That means the P waves are not followed by the QRS, and at times you can see the P waves march through the QRS complexes, which is confirmation of the diagnosis of complete heart block. We also have ST elevation in lead 2, lead 3, lead AFEF, V1, V2, V3, which means that the patient has complete heart block plus infraposterior MI. We do echocardiography as per protocol. You can see that there is hypokinesia of the infraposterior wall, some left ventricular systolic dysfunction, and significant right ventricular dysfunction. You can see that the free wall of the right ventricle is not moving very well, and that means the hypotension is caused by the right ventricular MI with right ventricular dysfunction. The patient also has moderate MR, IVC is dilated, so we know that we need to be very aggressive with normal saline infusion to manage these patients with hypotension, and temporarily we may give 2 or 4 ampules of atropine to increase the heart rate temporarily till you shift the patient to cardiac cath lab, and then take other steps including temporary pacemaker implantation for improvement in heart rate. So this patient takes into cath lab, we puncture the femoral vein, put a small lead, that's a temporary pacemaker in position, and then we pace at about 80 or 90 beats per minute so that the first problem of heart rate is solved. And then we do an angiogram, coronary angiogram, and you can see that the right coronary artery we see here is totally occluded at the proximal part that we expected as per ECG and echo, because there was occlusion of proximal right coronary artery as evidenced by bradycardia, complete heart block, and ST elevation in 2-3 AVF and the posterior leads. So as per standard of care, we wire the lesion, we do a thrombus aspiration. This is the tip of the thrombus aspiration catheter. We re-establish antegrade flow, do an intravascular ultrasound to see the extent of the disease and the length of the vessel that needs to be revascularized and the diameter of the vessel. Select an appropriate size stent, inflate the balloon. The stent also expands, which is outside the balloon, and then deflate the balloon, take out the balloon, the stent will remain in the wall. And you can see that after implantation, you can see that the previously totally occluded right coronary artery, there is re-establishment of flow, and you can see that such a big right coronary artery occlusion had caused the acute MI. And early in taking the patient early into cath lab and aggressive management is very important to save the life and to prevent late onset of heart failure and other mechanical complications. Yet another variety of patient, 59-year-old male, hypertensive, chest pain. He ignored the chest pain because somebody told him it was gastritis, and 3 days he was at home, and then after 3 days he realized that he's getting worse and worse, so he came to our hospital. 1 day before, that day morning, he was thrombolized in an outside hospital with streptokinase, but even after thrombolysis, the chest pain persisted because late thrombolysis, especially with less efficient drugs like streptokinase, there is reduced chance of re-establishment of flow in the occluded coronary artery. So when the chest pain persisted, he was referred for procedure. He came to us on day 3, and in day 3, this is the ECG. On day 3, you can see that there is ST elevation in 2, 3, AVF, and that means it is an inferior wall MI. Yes. And echo showed there is hypokinesia of the inferior wall, there was moderate LV systolic function, dysfunction, and some MR and mild RV dysfunction and a congested IVC. We did a coronary angiogram for this patient, which showed double vessel disease. So as shown in the previous case, we did a culprit vessel revascularization. In this case, the right coronary artery. On the same day, patient improved clinically, but suddenly after 2 days, patient started to feel breathless, and that is the importance of keeping the patient, especially complicated MI patients, for the first 1 or 2 days in ICU, because they can develop some complications later on. After 2 days, this patient had breathlessness, and when we auscultated, there was a new onset of a pansystolic murmur in the precordium, which suggests that there is either a mitral regurgitation or a ventricular septal defect. So to differentiate, we did an echocardiography, and this is the echocardiogram that showed. You can see that there is a defect here in the interventricular septum, which is bulging out in between, and through this blood was flowing. You can see the color flow in the echocardiography through the defect in the ventricular septum. So this confirms that these late presentation MI, which is very commonly seen in late presentation MIs, there can at times be a mechanical complication of ventricular septal rupture with myocardial dissection, which is actually an absolute emergency. We need to call the cardiac surgeons on an emergency basis and request them if it is possible to undertake an emergency open heart surgery. Otherwise, they are at increased risk of mortality within the first 24 to 48 hours. So our cardiac surgeon came and evaluated this patient, talked to the relatives. The relatives understood the gravity of the scenario, and then they accepted emergency cardiac surgery, of course under very high risk, but there is no choice, because if no surgery, mortality is almost 100%, and with surgery, the mortality comes down to 50–60%. So emergency surgery of ventricular septal repair was done, patch closure was done for this patient, and lucky for him, this patient got stabilized and discharged after 8 days of surgery, but as we know, not all patients are that lucky. This is the echo of the repaired ventricular septal defect. After the surgery, you can see that right now there is no defect and there is no color flow across the interventricular septum, which got repaired. Yet another case, 69-year-old male, hypertensive, presented with chest pain 3 days prior to presentation, diagnosed as inferior wall MI and thrombolized outside with streptokinase. However, the hypertension persisted and patient was referred to us for further management. On examination, heart rate was 90, BP was 90 systolic, and the patient was on noradrenaline at 6 ml per hour for hypertension started from outside. And we did an echocardiography and ECG to confirm what was happening. ECG showed ST elevation again in 2-3 AVF that showed inferior wall MI and tall R in V1, V2, which is actually a reflection of posterior wall MI. And this is the echocardiography. You can see that when we do echo within 3 days of MI, and if there is this pericardial effusion, that is the presence of fluid between the 2 layers of pericardium, then that almost always means that the patient has had a cardiac rupture and sudden death is imminent unless we undertake emergency cardiac surgery. So the dictum: within 3 days of MI, if you see pericardial effusion, always consider that it is a cardiac rupture and a contained cardiac rupture. Very often, patients do not survive. Rarely, patients survive to reach you, and if you can make a quick diagnosis and call the cardiac surgeon, mobilize the cardiac surgery OT within the first few hours, then there is a chance that he may survive. So this patient underwent emergency cardiac surgery. You can see that the ruptured segment, which they did a patch closure so that the patient is hemodynamically stabilized. And then this patient also was lucky enough to survive because of timely intervention by the team of cardiologist and cardiac surgeon. Yet another case, 60-year-old female, hypertension, presented with inferior wall MI, cardiogenic shock, and pulmonary edema. The presence of cardiogenic shock and pulmonary edema is a very bad combination. So these patients are at increased risk of death. So on examination, there was severe florid mitral regurgitation, and you can see that the dangling structure here on different views suggestive of a ruptured papillary muscle head causing severe MR, and it is acute severe MR. So these patients will develop acute pulmonary edema, extremely breathless, and also their BP will be very low because it is acute severe MR. So this patient also, we did angiogram, and because of the mechanical complication of acute severe MR, this patient was sent for cardiac surgeon, and he was stabilized initially with IABP before the cardiac surgery and ventilator support, and for angiogram followed by cardiac surgery was done, and mitral valve replacement was done, and you can see the cardiac surgeon excising the ruptured cardiac papillary muscle tissue and then repairing at times replacing the mitral valve. So from the acute coronary syndromes and acute MI, we move to yet another cardiac emergency. This is a 49-year-old female with left ankle fracture 15 days back. So this patient is not moving around at all. Suddenly they present with acute onset breathlessness and some giddiness on the day of presentation. So comes to emergency here, the heart rate is 110, the blood pressure is below 80, so there is significant hypotension, and despite the inotropic treatment, the BP is not improving, the oxygen saturation is not good, it's only 78% on room air. The ECG is done, and that shows right axis deviation and right ventricular hypertrophy. You can see here there is sinus tachycardia, and also there is a right axis deviation. AVF is positive, lead 1 is negative, so right axis deviation. There is incomplete right bundle branch block, and there is some T inversion in V1, V2, V3, which is suggestive of an RV strain pattern. And also we also have what is classically called the S1, S wave in lead 1, Q3, small q in lead 3, and T3, T inversion in lead 3. So the S1, Q3, T3, classically called the S1, Q3, T3 pattern of pulmonary embolism, and which is confirmed by echocardiography. Here you can see that the left atrium and the left ventricle are almost normal, but the right atrium and right ventricle are extremely dilated. So it's right ventricular dysfunction, which suggests that the patient has had massive pulmonary embolism. So massive pulmonary embolism is always a cardiac emergency, and the patient is at increased risk of death. This short axis view of the right ventricular outflow tract, you can see that there is a thrombus material at the bifurcation of the pulmonary artery. That is reason for such low blood pressure and very low saturation. So we offer thrombolysis for this patient as the first option. Patients with hypotension, extreme hypoxia, and thrombus in right ventricle or right ventricular dysfunction, we always give them a choice of thrombolytic therapy with a explained risk of 1% of intracerebral bleed. Very often it is best choice possible to prevent death, but at times it is there are contraindications for thrombolysis. So once you see a patient with acute pulmonary embolism, it is important that you risk stratify them by a clinical evaluation to assess the anatomic extent of pulmonary embolism, assessment of RV function, and biomarker like troponin T and NT-proBNP. And then you divide these patients into a low-risk patient or a high-risk patient. Patients who are at low risk, those without RV dysfunction, those whose troponin is not raised, those whose blood pressure is not having any hypotension, no significant diminution of oxygen saturation below 90. These kind of people can be managed by anticoagulation alone. But then the high-risk group with hypotension, hypoxia, raised troponin levels, and right ventricular dysfunction, they will need either thrombolysis, and or if they are at increased risk of thrombolysis, they may need a combination of mechanical embolectomy plus an anticoagulation. And this is a case which we did, and we had to do a mechanical thrombectomy because this patient had contraindication for thrombolysis. You can see that we take a catheter from the inferior vena cava through the RA-RV into the pulmonary artery, and we inject contrast. You can see that this haziness inside is actually please press next, is inside, is actually thrombus in the pulmonary artery. Here also you can see the white clot in pulmonary artery. it was there on both sides, so we took a catheter, and then you can see that we did a mechanical thrombectomy with this wire, and the wire will break or fragment the thrombus that is occluding the pulmonary arteries, and then later on through this catheter we aspirate the thrombus, and we see the patient's condition improving. This is done on both sides. This is done on both sides, and you can see that this thrombus was fragmented, and then we aspirated the thrombus. This is the thrombus that got aspirated on the mechanical thrombectomy device, and the patient's saturation and blood pressure improved right on table from 85% to 97%, and blood pressure from 80 to 120. After 2 days, the patient was discharged quite stable. This is yet another case, 56-year-old presented with breathlessness. Patient felt that he was comfortable on sitting up and bending forward, which means that it is most likely pericardial related problem. However, he kept on telling that he cannot lie down flat. He had a history of lung malignancy in the past. This was his ECG. You can see there is some amount of tachycardia, but what is most striking in this is the alternating beats are tall and short, which means electrical alternates, which can be seen in a swinging heart, which is seen as in pericardial effusion, large pericardial effusion and tamponade. So we confirm the diagnosis by echocardiography. You can see the swinging heart with large amount of fluid in the pericardial sac. So this needs to be aspirated, otherwise the patient will not improve at all. So we do an emergency pericardiocentesis, some below the sternum, either under echo guidance or under fluoroscopic guidance, and aspirate the fluid and keep a pigtail there. And once the fluid is completely aspirated over 24 to 48 hours, we remove the pigtail and there is relief of symptoms. Yet another case, syncope and shortness of breath. This is the ECG. You can see that on first look, it is almost like normal. And there is here complete heart block on ECG, where the P waves are seen marching through the QRS complex, and at times it can happen there can be intermittent complete heart block. So this patient needs an emergency treatment in terms of temporary pacemaker initially, followed by a permanent pacemaker. Yet another patient, 70-year-old female presented with chest pain for 12 hours duration. You can see there is ST elevation in V2, V3, V4, V5, V6, which is suggestive of an anterior wall amide. There is frequent VPCs happening. And suddenly, while the patient was on table undertaking the ECG, an R on T phenomenon happens and the patient develops a VT. So we know that the algorithm for cardiac arrest, patient with VT or VFib needs emergency cardioversion, and if till the defibrillator is available, we can give cardiopulmonary resuscitation and give adrenaline if there is no QRS complexes, and if there is a QRS complex and showing VT or VFib, we need to shock and follow the advanced cardiac life support protocol. Thank you very much, and these are some of the emergencies you will come across in your everyday practice, and I'm very sure that all of you will see these patients more often than not, and please be mentally prepared to save the life of the patients you come across. Thank you very much.
Thank you so much. Quite intimidating to follow my great professors here. And I think I like the discussions around cardiac emergencies. And we must agree that most of us are still quite far from achieving that kind of technology. So I'm hoping to convince you that we should probably focus on prevention as a continent so that we can reduce these cases, because they say even if our countries will achieve the Abuja Declaration of 15% of the budgets towards health, we will still not be able to treat the rising burden of cardiovascular diseases. So I think our solution might be on prevention. I think for most of us, preventive cardiology is a new field in Africa. When we look at cardiology, we straightly go to the treatment side. But I think even in the West, there's a field, established field of preventive cardiology. And that's what we are trying to grow in Kenya, is practitioners who will focus on prevention of cardiovascular diseases. And we're happy to have at least more than 10 of us who have been trained. So I'll be looking at obesity and heart disease in Africa. That's the outline of my presentation. So just a bit about Kenya Cardiac Society. We are a professional society, and our membership is not just cardiologists. We have all the cadres, from cardiologists right to the nurses and the other health practitioners, because we recognize that for CVDs to be managed, we need all the practitioners so that we cover the entire health system right to the primary healthcare level. And what we do is capacity building, that's just the objectives, awareness and advocacy, and we also do research to ensure we have data. So just starting on obesity, these are the kind of messages I want to pass across. It's a growing burden. I think we all know that in all the continents. It's a complex social and environmental disease. So it's not just a health problem, but if you look at obesity, the determinants cut across outside actually the health sector. The health sector comes in to collect the damage that has been caused. We don't have enough focus on obesity and NCDs in Africa. And therefore, we'll need to have context-specific solutions. So the solutions for Africa, I think, are going to be specific to what is available and the challenges and the determinants that we have. We need to focus on prevention. That's my key message, or rather one of my key messages. Political goodwill is critical. I think our first presenter talked about HIV. HIV was very heavily funded. I don't think we're going to get that kind of funding coming to NCDs. Therefore, we need our own leaders to be convinced that they need to invest in NCDs. So that's what I'm calling political goodwill. So we'll have to generate data and work together to convince our own leaders that they must invest in CVDs and addressing NCDs. I will need to work with other sectors, so not just the health sectors. Health sector, we need to bring in Ministry of Agriculture, Ministry of Education, because it's really a cross-cutting problem. And of course, we need data. So for us to convince our leaders that we need more resources, we need to show the burden. And right now, many of us don't have the data to show the kind of burden, so that's important. So the burden of obesity in Africa, as I said, we are transitioning from a starving continent to overweight. Just focusing on the prevalence in adults, it ranges from 13 to 31%. This is in Kenya, about a third of Kenyans are obese and overweight. Children, it's about 5 to 16%, but more importantly, by end of next year, it's projected that 1 in 5 adults and 1 in 10 children will be obese, and that's really a big concern. And of course, obesity results in CVDs, diabetes, musculoskeletal disorders, cancer, and many other problems. And among children, there is higher chance of premature death and disability. Yeah, so that's just showing the prevalence of obesity globally. You can see it's at 13%, but this is a bit outdated. But also you can see there is a higher prevalence among females. Next slide. And this one I just put here also to emphasize that, and I'll be talking about this, in Africa, females have more than double the prevalence of obesity compared to males. So why do we have a rising burden? I think most of us know this. We are going through a nutrition transition where we are changing our foods more to fast foods because of urbanization. So we are moving away from the traditional foods we normally previously consumed, and we are becoming more sedentary. So we are changing our diet and then becoming more sedentary. I think most of our countries have the motorbikes, which now ferry people even 1 kilometer, nobody wants to walk, the lifts and all that. Then of course we have the environmental factors, and then we have more, even important in Africa, socio-cultural and socio-economic factors, which I'll be talking about. So in Africa, I would highlight, we have some unique determinants like socio-cultural factors, which I'll be talking about, issues of gender, socio-economic factors, urbanization, issues of maternal factors, also common in Africa. So maternal, I'm talking about things like, because we already have a high prevalence of obesity, when these people become pregnant, their children are actually, when the children are born, they are more likely to be overweight. If you gain a lot of weight during pregnancy, your child is also likely to be overweight, issues of gestational diabetes. And then there is the other issue of body image, which Professor alluded here. So socioeconomically, there are two sides of the coin. So the wealthier you become, of course, you're now consuming, there's that, prestige of eating in the fast food joints, the KFC and all those popular places. So we are eating more unhealthy diets, but also we are finding that eating healthy is expensive. I think in many countries, including Kenya, you find vegetables and fruits are quite expensive. So you find what is affordable tends to be high carbohydrate diets. That's what the poor tend to be able to afford. And I would say that especially in our country and many other African countries, our diets are really very rich in carbohydrates, and that's how our plate looks like normally. Half of it must be a carbohydrate, and then the rest is distributed accordingly. So we really, these are the kind of things we need to change. And then we look at socio-cultural factors. So in Africa, obesity is a sign of good health, affluence, and beauty. You can see a quote here: if you're too thin, it means your husband is not taking care of you and you're unhappy. And the ladies here will agree that, myself included, when I went to my in-laws, they would really be complaining and saying, you need to eat more. And my father-in-law would actually give me a list of foods I should eat to add weight. So I think those are the things we'll have to address. HIV was mentioned. When you have HIV, you tend to run away from being thin because you feel people will question. And then for women, I think I talked about for women, they say there are of course hormonal and endocrine factors, eating practices in the childbearing age, when you're pregnant, when you're breastfeeding, there's tendency to eat for two. We may, more sedentary jobs, societal expectations, I think I've talked about that. And for those of us from West Africa, I understand there's a community where they are fattened, they're taken for fattening. Before marriage, yes, and they are locked up and they are given fattening food so that by the time you get married, you're ready for childbearing and the rest. I think it's in Nigeria. My colleagues from Nigeria can attest. So this is just to bring the aspects together. So we have issues of globalization, urbanization, aging, increased income, education, housing. So these are social determinants. They lead to the behavioral risk factors: unhealthy diet, tobacco use, physical inactivity, harmful use of alcohol. These now bring about the metabolic risk factors, where you have high blood pressure, obesity, blood lipids, and then you have the cardiovascular disease and other NCDs. So the cascade is really similar for all the NCDs. So now moving to cardiovascular diseases, what people call heart diseases, although cardiovascular is really the broad umbrella. We are seeing in Africa, actually hypertension is the main risk factor. And I'd really like to emphasize that. But of course, we have other risk factors: obesity, diabetes, dyslipidemia, smoking, unhealthy diet, and alcohol intake. And it is said, WHO has said that African region has the highest prevalence of hypertension at 27%. And as my professor said, CVDs in Africa affects mostly younger and more productive. So we're going to get the younger, more productive being affected. And of course, that will affect the economy. So this is a burden of hypertension. You can see Africa, they are also moving along with the other continents in terms of higher burden. Next. Coming to the economic burden, this is just comparing actually CVDs and other things like cancer, respiratory, diabetes. You can see it has the highest economic burden, and this is low and middle income countries. So what is available for us in terms of addressing NCDs? So in 2013, heads of state came together under the United Nations and came up with a global action plan. And basically, we were urged to raise the priority of NCDs, strengthen local capacity to address NCDs. As we said, we cannot sit and wait for some global fund initiative for NCDs. We'll have to see how we can be the ones to drive this agenda. We need to bring other sectors. We need to reduce, of course, the risk factors. We need to strengthen the health systems under the umbrella of UHC. We need to do research, and we need to monitor the progress. And these are the targets we were given. I'm not sure if many of us know how our countries are performing. We are to reduce tobacco use and this is in another 3 years. We were supposed to have reduced tobacco use by 30%, to increase or to reduce physical inactivity by 10%, to reduce blood pressure by 25%, to halt the rise of diabetes and obesity, basically make sure we don't have any increase. Harmful use of alcohol reduced by 10%, reduce salt intake by 30%, increase access to essential medicines, 80%, and also 50% of those eligible are taking drug therapy. So these are our targets. I think maybe we should really see whether we are able even to track some of this data. Do we have data to track some of these trends? Those are the questions we should be asking ourselves. And also the WHO came up with proposals, which I'm happy about because they really focus on prevention. And for tobacco use is to really come up with tax increases. I think many of our countries are doing this. Put warnings on the tobacco packets. And I must say that, at least in Kenya, we've done a lot. I think I only smell cigarette smoke when I travel. Whenever I travel, including here, first thing you reach the airport is cigarette smoke. But in Kenya, I rarely actually smell any cigarette, and my Kenyan colleagues can attest. So these are things which are actually doable. We are not doing very well in terms of alcohol use. We have a lot of advertisements, but we're being urged to ban alcohol advertising totally, so that to reduce the risk, restrict access, tax increase, and then there is the issue of unhealthy diet and physical activity. Most African countries are not doing well here. We're supposed to reduce salt intake in food, and this should be through educating the public, but also regulating the food that is available in the supermarkets. Do we have policies to ensure people know how much salt is in the food, or that the salt is actually being regulated? Then replace trans fats. Trans fats is kind of a bad fat. In many countries has been actually eliminated completely, but in most of African countries, we don't even have food labels to be able to know if that is in our foods. And of course, public awareness through mass media. And for CVDs, counseling. So basically, we are supposed to be finding those at high risk. So be able to identify those at high risk and give them preventive medicines and treatment of heart attacks. My colleagues talked about that. Of course, for cancer, we have those. So these are really population-level interventions that have been recommended. So some countries, I'll talk about Kenya, and many other countries domesticated that strategy. So we came up with our own strategies. So of course, we have global strategies, but we have to really see what can work in Kenya. So we came up with a local strategy. We have what we call National Interagency Coordinating Committee. This committee brings all the sectors together, because we need to bring Ministry of Education, Ministry of Agriculture, Ministry of Infrastructure, because all these people are going to work together to see how to reduce the risk factors. So this strategy came up with a mechanism to bring all these people together to talk on one table. We've developed guidelines. I'll be showing the one we have for cardiovascular disease, but now we have guidelines which cascade down to the community level. We have strengthened the health system, and we are doing a lot of advocacy, as I said, to improve, to convince our leaders that they need to invest in NCDs. So at the health system level, we need to do awareness creation. I think I talked about that. We need to change our system to focus on healthcare. So I think for NCDs, we cannot sit and wait for strokes and MIs, because we will not be able to manage that. So how can we change the health system to be able to identify the risk factors and educate people to prevent NCDs? We need to define, so basically anyone visiting any level of hospital should be able to get a basic package of CVD care. And for us, our priority is hypertension, diabetes at the bare minimum. Every primary health center should be able to identify and manage these patients. And we are trying to make sure we train down to the nurse and the clinical officers to be able to manage these conditions. Capacity building, and this is really where we appreciate Merck Foundation for partnering with us to be able to train our health providers. But now what we are doing is, we are physicians, we are doctors. What we are doing now is, this training we have received, we are now breaking it down and sharing it with other cadres so that they're able to deliver this care, because we'll not be able to be enough doctors and physicians to train, or to provide this care. So what we do in our guidelines is, now we have broken down whatever we have been trained to be able to deliver it to different cadres. We are trying to decentralize care, like similar what HIV did. We are trying to ensure there is access to essential CVD prevention and care medicines. And as I said, we are focusing on diabetes and hypertension as the main drivers, improving data management and participating in global initiatives. Next. This is one of the initiatives that I want all of us, if you're not already participating, to join. It's what they call May Measurement Month. Every year in the month of May, we bring together volunteers in Kenya. I'll talk about Kenya. So it's a global initiative happening in 100 countries. So what happens, each country mobilizes volunteers. So these are just different organizations, volunteers, and they come together and screen as many people for hypertension throughout the country. So we've been doing this since 2017. So every year we screen 10 to 20,000 Kenyans and educate them on hypertension. So this we do every month. So there are resources available from International Society of Hypertension. They have posters, they have flyers, they have campaign materials. We bring together, it's purely voluntary and funded by local organizations. We do not rely on any donors or anything. We just mobilize people who have interest in hypertension, and we're able to screen people every year. So I'd urge all of us, those who are not participating, to join in this campaign. Next. World Heart Day, we take advantage of such global days to raise awareness. Next. I just want to highlight what Rwanda is doing. I think we all know this initiative. So these are really simple, customized local initiatives which are feasible. But as I said, what is required is political goodwill. So you can see here, it's actually driven by the head of state. And every month, 2 days a month, they set a day to just block the cars out and have people do physical activity. So these are kind of initiatives we need to really think about. Next. Of course, we cannot run away from empowering our patients so that they can take control of their care. Next. What are the gaps that remain? I think I've talked about most of these. Awareness remains a gap. Funding, we cannot rely on donors. Competing demands from infectious. Yes, I think I've talked about this. I will not belabor. Continue. So what are the recommendations as I finish? We need population-wide intervention. So as much as we are doing the patient-level care, we really need to also focus on the population-wide interventions. We need policies to regulate sugar, salt, trans fats. We need the other fiscal policies. We need to tax tobacco, alcohol, which is already happening, but we need to now tax sugar-sweetened beverages, like what South Africa has done. We need school policies. For example, school meals. Most of us, even the meals that are served in school, some tend to be not the best for our children, so we need to school policies. We need to control advertisement, and we need infrastructure to support physical activity. So this is what I think many of us know about the success of South Africa. I think it's the only African country which managed to put this in place. And you can see that since the tax was implemented, South Africans are buying 25% less sugary drinks. And of course, this was not easy. There is usually a lot of industry interference, but you need a lot of political goodwill. You need data, as I said, because you'll be really trying to convince the economists and all that they need to tax this. And so I think we need to be as aggressive as this to be able to address the risk factors. Next. Health system, I think I've talked most of these, and as I said, capacity building, I want to approach the Merck Foundation. Yes, we need to do treatment guidelines, task sharing, and then we also need to see how the care can be affordable. Next. So in Kenya, we've come up with treatment guidelines for cardiovascular diseases, and I want to say that after we were trained in preventive cardiovascular medicine, those of us who are trained, actually, this guideline was launched in 2018. What we did is now we are revising it, and we are really increasing the focus on prevention and risk factor management. So previously, we did not have any information on dyslipidemia management. There was CVD prevention, but we are really now trying to focus it to make sure it's really coming out prominently. And there's also the big gap of cardiac rehabilitation, which in many countries is not there. Yeah, so this is, actually, this is my conclusion. Thank you so much.
Lillian, thank you for such a well-structured presentation. My question is biased, of course, towards home. When you do the yearly service of BP assessment, are you finding an increase in the trend of the numbers of people with blood pressure? As in, what is the difference between last year and now, or since you started?
The prevalence we have been getting actually is quite similar to what we got when we did the STEP survey in 2015, which was one in 4 Kenyans, about 24% prevalence. So we are getting similar sort of, but I would not call MMM a prevalence study because we don't really have a representative sample. It's quite biased sometimes depending on where we screen. But I would say the figure ranges, but it's still within what we got when we did the STEP survey of about 24%.
Okay. Any last question? Or maybe I should ask this to you, Lillian. Has the sugar tax in South Africa had any tangible benefits as far as disease is concerned? I know they are buying less sugar, but is there any evidence for less mortality, less cardiovascular diseases? Any such evidence?
Honestly, I haven't checked, but I think that's a good point because yes, they showed that the sugar intake has decreased, but definitely, I'm not sure. I need to check if there are any studies that have looked at the long-term outcomes.
Okay, yeah. Maybe if there are any, Dr. Jenga, you had a comment?
So it's fairly recent, so we definitely have to wait for the long-term 5-year data to see. But it's a fairly recent intervention, probably around 2019. I think we'll have to wait and see what the long-term outcome is in those specific diseases, diabetes, hypertension, and hardened cardiovascular endpoints.
Thank you very much. And I'm going to be talking about long COVID and the heart. So this is going to be the outline of the presentation. Can we move to the next slide, please? We are just going to look at what is the effect of COVID on the heart and the long COVID, what if impact is it having on cardiovascular disease care as well. So COVID primarily is pulmonary disease, respiratory disease. Most people who get COVID tend to recover within a month. Most people develop mild infections and do not last for long. But a few people, especially adults, elderly people, and those who have comorbidities tend to develop severe infections. Can we move to the next slide, please? Current evidence is showing that about 10 to 20% of people who develop COVID tend to have what we are now terming as long COVID syndrome or long COVID condition with various names. So this is a typical progression of people who develop the acute COVID condition. Usually the early infection phase is characterized by viral infiltration and replication, which is usually associated with predominant lymphocytopenia. The second phase usually is the pulmonary phase, which is characterized by the respiratory compromise and abnormal chest X-ray and imaging findings. For some people who develop severe infection, they progress to the third stage of the disease, which is characterized by severe hyperinflammation and release of a lot of cytokines, inflammatory cytokines, which is driven by the body's immune system, and that is associated with systemic inflammation and other organ involvement, which includes the heart and other organs that are important as well. So this was a study that was done in 2020 looking at the inflammatory cytokines that are associated with COVID condition, acute COVID. And they realized that for those who survived, there was higher elevations of inflammatory cytokines compared to those lower secretion of inflammatory cytokines compared to those who succumbed to the COVID infection. And this was also associated with elevations of cardiac biomarkers like the cardiac troponin and other cardiac biomarkers were also highly elevated in people who died from COVID compared to those who survived the condition. We know the way the SARS-CoV-2 virus interacts with the heart is through the angiotensin-converting enzyme 2, the ACE2 receptor, which is initially created a lot of panic as a result of ACE link it to the ACE enzyme, but finally we got to know that indeed the ACE inhibitors do not have any effect on the ACE2 receptor. The coronavirus has these spike proteins that bind to the ACE2 receptor, and that is their infiltration into the cell and replication, and that finally leads to a lot of damage to the cell itself and also replication of several virus particles as well. The balance between ACE and ACE2 is very important for good cardiovascular health. Usually the ACE, that is angiotensin converting enzyme, converts angiotensin 1 to angiotensin 2, which through its binding to AT1 receptor leads to a lot of maladaptive changes in the cardiovascular system, including the pro-inflammatory actions, oxidative stress, fibrosis, hypertrophy, and other maladaptive changes. This is counterbalanced by the action of the ACE2. ACE2 breaks down the angiotensin 2 to angiotensin 1,7 and angiotensin 1 to angiotensin 1,9, and these have counter-regulatory effect on the activity of the angiotensin 2. So they are more anti-inflammatory, antioxidant, anti-fibrotic, anti-proliferative, and anti-hypertrophy. So there is need for a good balance between these two systems to ensure good cardiovascular health. What happens in COVID is that there's dysregulation of this fine balance, and that tends to lead to cardiovascular diseases. So in effect, when somebody develops COVID, acute COVID, for instance, the cardiovascular injury is as a result of one, direct viral invasion of the cardiomyocytes, and that will cause cardiotoxicity or injury to the myocardium, or indirect effects. And these indirect effects may be as a result of the hyperinflammation that leads to cytokine storm and damage to not just the cardiomyocyte but also the vasculature, which will lead to inflammation, damage to the vascular cell, or sometimes because of the higher inflammation, it will lead to destabilization of atherosclerotic plaques that may eventually lead to acute thrombotic events and acute coronary syndrome. Additionally, because of the pulmonary damage, there is hypoxic-mediated injury to the cardiovascular system. We have also noticed people tend to have disseminated intravascular coagulopathy, and that may be associated with increased incidence of pulmonary embolism, DVT, and others, which may also increase cardiovascular burden for people with acute COVID disease. So we tend to see higher incidence of acute coronary syndromes, arrhythmias, myocarditis, venous thromboembolism, heart failure, and cardiogenic shock in people who have acute COVID condition. And in addition to this, because of its interaction with comorbid conditions like hypertension, people who already have coronary artery disease, diabetes, these conditions may be even higher. In addition, you also have, initially when COVID began, we were treating or managing some of the patients with drugs that could be pro-arrhythmic, like erythromycin, like hydroxychloroquine or hydroxychloroquine. All these drugs could also be pro-arrhythmic and therefore lead to higher cardiovascular conditions in these patients. So when we say long COVID or long COVID condition, what does it mean? It is basically a constellation of long-term symptoms that develop in people who sort of recover from their initial COVID infection. So people tend to get acute COVID condition, lasts for about a month or so, they recover, and within 3 months or so, they start having these conditions, and this has been variously termed as long COVID condition or other terms. The most common presentations or symptoms are fatigue, difficulty in breathing, sometimes chest discomfort, or it may also be associated with cognitive dysfunction. So various authors have referred to it variously. The most preferred one, I think, is from the WHO, and they refer to it as post-COVID condition or post-COVID-19 condition. Others have had several other names for this same condition, but they refer to the same condition. In a large study that was done in the United Kingdom, looking at the odds of developing post-COVID, long COVID after infection with Omicron versus Delta variants of the COVID-19, what they realized is that people who had Omicron infection had a lower likelihood of developing long COVID compared to those who had Delta infection. Next slide, please. And this was true whether you were young or whether you were elderly, across all age groups. This was another study among health workers in Italy across 9 hospitals. They looked at health workers who developed COVID-19, and across the various waves, the prevalence or incidence of long COVID was not the same. So those who had the initial wave had higher likelihood of developing long COVID than those who had the latter waves. And additionally, for people who had COVID vaccine, the risk of developing long COVID was lower than those who did not have COVID vaccine. And this is also probably because they did not have severe infections, because another study looked at those who were admitted for COVID compared to those who did not have admission for COVID. And the long COVID, the prevalence of long COVID was higher in those who had COVID admission, whether hospital or ICU admission, compared to those who had out of hospital management, which also indicates that the severity of the infection also tends to affect the likelihood of developing long COVID. So there are other factors that affect your risk of developing long COVID: the age, the gender, whether you've had vaccination, social demographic factors, and several other factors. I must say that our emphasis today is on the cardiovascular bit of it, but it also affects other systems. It could affect the they may have neuropsychiatric manifestations, respiratory manifestations, renal manifestations, and others. Our emphasis today is on the cardiovascular manifestations, and that is what we are focusing on for today. People have described the link between acute COVID and long COVID, and the main link they have tried to describe is inflammation and cardiac remodeling as a result of the acute effects of the COVID on the heart. So due to maybe acute myocarditis, they think that there is cardiac remodeling, and that eventually will lead to viral cardiomyopathy, and because of inflammation, that may also lead to increased risk of atherosclerosis. Next slide, please. And that is very true as far as inflammation is concerned, because we do know that inflammation is associated with higher rates of atherosclerosis. Not only that, inflammation also tends to lead to destabilization of plaques, and so stable plaques may be converted to unstable plaques and then lead to thrombotic complications. And this was shown, next slide please, in the Cantos trial, where people who have had myocardial infarction, when they were given canakinumab, there was about 39% reduction in the inflammatory cytokine, compared to, no reduction at all in the lipid profile. And this translated into a 15% reduction in MACE. And that sort of shows that tackling inflammation also has some beneficial effect on cardiovascular outcome. Inflammation plays a significant role in cardiovascular conditions. Next slide. We could skip this. It's the same information that is presented here. However, in this small recent publication, which looked at 189 adults who had documented SARS-CoV-2 compared to 120 controls who did not have SARS-CoV-2 infection, the authors did not find any evidence of persistent viral infection or autoimmunity or abnormal immune activation in participants with long COVID. And they took a look at several inflammatory markers, and they were really not different 6 weeks after the COVID infection. So this presupposes that there are other mechanisms that may be contributing to the progression from acute COVID to long COVID, and not just inflammation as the only link. And others are now describing mitochondrial dysfunction and other mechanisms which may be necessary. We could skip this, it's sort of the same thing. So basically, what I've said so far, acute COVID leads to cardiovascular conditions. Acute coronary syndrome, myocardial injury, and myocarditis, pericarditis, and others. We are also noticing that even after recovery from the acute condition, you also are at a higher risk of long-term conditions, even after your recovery from the acute COVID infection. And this could range from increased admission for heart failure, new onset diabetes, new onset hypertension. And I've had several patients after COVID, they did not have hypertension or diabetes, but after COVID, they tend to come up with some of these conditions as well. And this is important for us as cardiologists to take note of. So our care for patients doesn't end with the acute recovery, but also follow them up thereabout. This is one important live study that was done from the United States Department of Veterans Affairs data, about 153,000 patients who had documented COVID. And they compared that with two types of control. Contemporary control, about 5.6 million people who did not have COVID. And also historic control. They also took another 5.8 million people from their records before the coronavirus pandemic began and compared them. They look at 1 year burden of cardiovascular disease, the incidence of cardiovascular, and they realized that those who had COVID 1 year on had a higher incidence of all forms of cardiovascular disease compared to both the contemporary control and the historic control. And this ranged from several conditions: cerebrovascular accident, stroke, TIA, dysrhythmias, atrial fibrillation, ventricular arrhythmias, inflammatory conditions like myocarditis, ischemic heart disease, including acute coronary syndromes, myocardial infarction, angina, and then thrombotic disorders, pulmonary embolism, DVT, and superficial vein thrombosis. So all these parameters were higher in people who had had COVID 1 year on compared to the contemporary and the historic control. So we are not over the wars yet. We don't know what is ahead of us the next 3 years, the next 5 years, the next 10 years. Evidence is showing that there's increased incidence of cardiovascular diseases. Now I turn my attention to its effect on cardiovascular care services as well. And we do realize that during the COVID pandemic, a lot of clinics were shut down and people were not even attending clinics. And after, the workload has become overly burdensome for cardiologists and other cardiovascular care practitioners. And this is also true. This was Duke data, Duke Hospital data. Look, and they reported 33% decline in outpatient cardiology clinics during the pandemic. And the important thing about this is I also see telehealth increasing, and that is also important for us, at least with decreasing attendance to the outpatient. We are also making use of telehealth, which will become important. But for those of us in Africa and other parts where our internet service and things are not very stable, we need to think about these things and how to take advantage of them. Not only with the attendance, but if you take a look at investigations, cardiovascular investigations also dropped dramatically with the emergence of the COVID condition. And this affected especially cardiovascular conditions that needed some long contact with patients. So you take echocardiography and ambulatory blood pressure monitoring, Holter monitoring. These are also dropped significantly. And that will affect our ability to also properly diagnose our patients who have COVID condition. Next slide, please. Looking at cardiovascular rehabilitation, it also affected cardiovascular rehabilitation significantly, and it ranged. Some of them reduced some elements that were offered at the cardiac rehab centers. Others stuck to only old patients, were refusing to admit new patients to their care. Others were not graduating their patients. And this was across the globe. So not only is it affecting the heart directly, but it's also affecting the care. Even rehabilitation care is also affected by the long COVID pandemic. Next slide, please. Cardiovascular procedures as well are also significantly affected. And look at it, I think the worst hit will be DC cardioversion. Doctors were scared when people come with emergency. You don't know whether they have COVID or not, and you want to protect yourself. So, and you can imagine if somebody needs DC cardioversion and it's not done, then what happens to the patient? In addition, coronary angiograms, elective coronary angiograms were worse affected compared to the urgent coronary angiogram, but all of them were affected. Even pacemaker implantations were all affected. So cardiovascular procedures were also affected, and that creates a backlog of patients after the acute phase is over. So we are having to deal with a lot of patients who needed these procedures, and now they have to be added to the long queues to obtain such procedures. And so this was a global study that was done by the International Atomic Energy Agency. They look at data from over 900 institutions from 108 countries. And they concluded that there was 64% reduction in cardiology diagnostic procedures compared to the previous year. And this was the effect of the COVID pandemic. And the worst hit were those that were not very urgent, like the stress tests, either EKG-based stress tests or imaging stress tests. There was about 78% reduction in these procedures. Transesophageal echo was also highly affected, transthoracic echocardiograms, and coronary angiograms. So all these were highly affected. So now, just want to look at how do you evaluate your patients who have had COVID, since we know that it has a great impact on the cardiovascular system. I think the basic thing is that there should be ideally a dedicated interdisciplinary outpatient COVID clinics where people who have recovered from COVID can be followed up and see what is happening. And these clinics, the care there must be targeted to the patient based on the symptoms they have. I will show you one algorithm that has been proposed. As at now, we don't have a dedicated cardiovascular risk assessment tool for people who have suffered COVID. We do have the standard risk assessment scores. So these must be used, bearing in mind that there should be modification of the risk you calculate. So these risks are likely going to underestimate the risks, the true risks of your patient, and that must be considered. You may also make use of other investigative tools that are available to us that are not so expensive, chest X-ray, ECG, serum biomarkers, BMP, troponin, echocardiogram, cardiopulmonary stress testing. All these will be added procedures that will help in the care of your patients. So the point here is that your care of the COVID spans a whole spectrum. It is not just the prevention, the primary prevention, but also after discharge from the patient. Don't forget, after discharge from the hospital, don't forget about the patient. The patient has a higher risk of cardiovascular disease than the ones who were not who didn't have COVID. Next slide, please. So this is the algorithm I was talking about. For majority of patients, if they come to the COVID recovery clinics, emphasis should be on rehabilitation, mental health support, occupational and social therapy. But if they do have cardiovascular symptoms or they have cardiovascular comorbidities, then these patients should be referred to the cardiology clinics for further evaluation, where some of these procedures I've mentioned will be taken advantage of. So Holter monitoring, cardiac MRI, CT, coronary calcium scoring, depending on your overall assessment of the patient and what will benefit the patient. And once you make a diagnosis, standard guideline directed therapy should be followed. Next slide, please. So let's move to the next one. I'm told I have only 1 minute or so left. So in effect, the best way to prevent long COVID or post-COVID condition is to prevent COVID infection in the first place. So let's all stick to the prevention measures: masking, social distancing, hand hygiene. And now with the emergence of vaccine, we do know that vaccine reduces the severity of infection and therefore reduces the likelihood of long COVID. We don't know what is ahead of us in the next 10 years, in the next 5 years. We might have recovered from the acute COVID condition, but what is the long-term effect? We are already seeing 1 year on, 2 year on, that there is increased likelihood of cardiovascular disease. If the person has added risks, there may be benefit of RAS inhibition, statins, and other medications as and when necessary. So my last slide, our knowledge in the long COVID is evolving. We are still learning a lot. The risks and the burden of cardiovascular disease in survivors of acute COVID-19 is substantial, and we do not know what is ahead. In addition, the prolonged COVID-19 pandemic has affected the provision of cardiovascular services across the globe. Care pathways of those surviving the acute episode of COVID-19 should include attention to cardiovascular health and disease. Thank you.
Yeah, thank you for that excellent talk. I think maybe I could ask you experience. I remember I'm from Kenya, and we work in a tertiary facility. And probably you can share experience at the beginning. You'd have people coming with acute myocardial infarction, acute heart failure, yet also COVID could mimic these conditions, and there's a lot of delay of care. So someone comes in acute myocardial infarction, PCR testing, people have to go on, getting the cath lab team ready. And we did see increased mortality, just because where to take you 10 minutes to get to the cath lab, it would probably take you 40 minutes up to an hour just to prepare the team. And also, the logistics of how to have the room prepared for the next patient. What was your experience during that particular time in your country?
Thank you very much. I agree with you totally. We also had a terrible experience with that. I mean, initially we were not even responding. We said that all patients should be managed with thrombolysis if they qualified. If they did not, then just do optimal medical therapy, because we were all scared and afraid. Then with the PPEs available, we started using the PPEs, but we realized that, I mean, you agree with me, it's very uncomfortable gowning all the PPE and going to do your procedures, and it delayed patient care as well. So we had increased mortality from myocardial infarction and other acute coronary syndromes. With time, now what we basically do is we just do the antigen test when patients come with acute coronary syndrome. If most of us are vaccinated anyway, so when they come with acute coronary syndrome, COVID, we don't go any longer to the cath lab. We just do antigen tests. If it's negative, we go ahead and do. If it is positive, then we will go and still go ahead and do it. But I mean, it has affected care in some way. Thank you.
Thank you very much. So as a background information, high blood pressure, hypertension is a very critical syndrome, a disease of development, which is largely asymptomatic, but very devastating issues of end organ damage issues, and very common in Africa, and a very major cause of death the world over. And it is associated with multiple clinical syndromes that are very familiar to you: heart failure, myocardial infarction, aortic aneurysm, and many others. And of course, if you look at the brain syndromes associated with hypertension, then the list just gets longer. Kidney consequences, pregnancy, and all that. So hypertension is not new to you, at least as clinicians, in terms of the clinical consequences. And that's why it is extremely important to us. And that's just the burden. Now very, very common in sub-Saharan Africa and bigger Asia. But we don't do too much in terms of research, so the information flow is much less from where the burden is bigger. So we need to do more research, even surveys, just to tell our communities the burden of the hypertension. Then, of course, it has both rural and urban divide, but as Dr. Mbao showed you, that the boundaries between the rural and urban cardiovascular risk factors is becoming much more blurred because of the transport system, the food system, and the way we approach our lifestyle. So you have significant rural and urban divide. So that is sub-Saharan, and I wanted to stress this prevalence. Those are two countries, Nigeria, Kenya, Tanzania, and Namibia, and you can see the prevalence ranging from 19% to about 40%. And the proportion, as you can see, is of people with the grade 2 hypertension, that is a figure of systolic 160 and above, is getting higher and higher. And those are the ones associated with events. And of course, the level of control in Kenya is 2.6, and the one in Tanzania is about 17.4. So we are doing very badly. This is the message that we have a prevalent disease, but the control is very, very poor, and already a suggestion of controlling health systems to contain the emerging epidemic of cardiovascular disease is the suggestion, and that is going to be an issue towards the end of the. So then there are guidelines that seem to define how we approach this condition, and you find the American Cardiology Group and American Heart Association, then of course the European, and the figures that they talk about. And this is important in terms of what we call net classification of people with the disease, and therefore the thresholds of treatment. And that is critical for an asymptomatic or a largely asymptomatic condition like hypertension, and then how do we approach it in our various health system designs. So, like I said, that hypertension can be detected and treated at the primary care, and when you detect and treat, the rewards are enormous, and we want to advocate for a dual approach. Preventive measures has already had been presented to you earlier by the CEO of the Kenya Cardiac Society, and also then the treatment where the guidelines are extremely critical. The slide doesn't come out very well from this Lancet, but it just shows the hemorrhage that we were talking about. It's so much of the problem, so little in terms of the control, and there is that gender sensitivity that the ladies or the women are not sufficiently controlled, and they're also prone to events. And that same burden, again, the underdiagnosed is the orange there, and it remains. Then the diagnosed, especially in sub-Saharan Africa and other lower income and middle income countries, then the green dwindles in terms of the people who get controlled. GNC 6 is probably the first guideline that brought out a strategy called risk stratification. However, it's easier said in the guidelines than done in practice. That the risk stratification, like hypertension-mediated end organ damage, is rarely looked for in the primary care setting, for one other critical reason I'd alluded to earlier in the first presentation, that the capacity to define them are quite low. So that you risk stratify, and that leaves you, the senior clinicians, who know what to do and how to do it. But when you are going to consider task shifting that has been alluded to here, then the risk strata, which have been defined by hypertension-mediated organ damage and other factors that somebody must know to look for, have not been factored in. Therefore, we just look at the figure, systolic this level, diastolic this level, and decide, do you have symptoms? No or yes. And then people think headache is a major manifestation of hypertension, and the answer is no. The headache is caused by a myriad of other things, and hypertension is not any of them. By the time you're getting headache because of hypertension, then that hypertension is the more severe. And then, of course, that shows the method. You must get it right. Then, this is also stressing the time lapse between the arrival of the patient and when you actually say this is the blood pressure reading in office, ambulatory, and wherever else, and therefore the decision to take that treatment. In primary care setting, do we have the time to tell the patient to have a pressure done, stay out, briefly relax, assuming that the environment is facilitating the same, then you eventually say you have done a proper blood pressure check and evaluation, and then initiate the rest of the appropriate processes. And we shall see that in the coming few slides. Again, that is now stressing these pressures that we talk about. You notice not taking antihypertensives, new arrival, pressures of 140/90 and above, and the rate of cardiovascular disease events is about 22, about almost 23 per 1,000 person years. All-cause mortality is about 33, a third of your patients. They may not be on treatment, but in that which you consider normal range, nothing particularly critical, but you see the rate of events in such individuals not very different, not very different. What does this mean? That they're very asymptomatic with what looks like normal pressures also get as many cardiovascular events as the ones that you think may be much more at risk. And the story is slightly different. If they're already taking treatment and that is the level that you find, then 140 systolic and above, about 34 patients per 34 events per 1,000 person years, and much higher mortality the same. If you think they are well controlled between 130 and 140 of systolic, and they're on treatment, the events still seem to match the ones who are borderline and not on treatment. So these are the intrigues around hypertension that we see literally every day. The events still occur in people who are supposedly normal. The aims of control are, of course, to identify cases and then link them to care, improve their patient-centeredness in approach to care, and of course, you want to individualize those outcomes in that risk stratification fashion, and also you want to improve public health, outcomes as well, because the disabilities associated with hypertension complications are quite high. So these are largely quickly thresholds when there are comorbidities in that risk stratified fashion. Of course, diabetes, when it does coexist, chronic kidney disease, assuming you manage to get it, heart failure, you have identified it or diagnosed it. Features of ischemic heart disease are also noticeable. You have found them, stroke and stroke syndromes. Then, of course, the other the presence of risk factors for that matter. If you calculate that risk, cardiovascular risk using the Framingham and the other SCORE risk engines, then these are the threshold and goals of treatment. Next. Still stressing that when you look at your patients, you need to, in that patient-centeredness, that is the risk stratification strategy, where you get the figure that is undesirable and the other co-existing conditions in such patients. And others are easy to elicit: diabetes, obesity, because you see them on inspection. Others, you have to go for lab tests in terms of kidney, presence of kidney disease, and lipid abnormalities, and of course, other habits that you can pick from the history of smoking, and other sedentary habits. And the slide was meant to tell you that the people in the higher strata by figure are not the commonest. It's just about 20%. They're prone to events. But the people with the lower strata or middle, the moderate risk group, are the highest in proportions. And these are the people who will also get events like we have seen. They are asymptomatic, they are larger in number, they get events, as we have already shown. There are strategies that we need to actually start talking about. This was the public-private partnerships that are important. Healthy Heart Africa and other approaches in other countries are important, but I realize these are very sporadic events that cannot be used for a public health approach, because you do them when pharma is willing, or a foundation or a funding agency is willing, and they do it. The Healthy Heart Africa was done maybe way back 2018, I think, and they are very sporadic, yet hypertension is a daily affair for the patient and for the health systems. Next. Again, I'm still stressing here that the higher you go on the systolic, the more the events, and if you are younger, the events are lower. When you're older, the events are much more frequent. And what was I saying? That even at 120, the ischemic heart disease as a mortality is an issue. And when you get older, maybe about 50, still higher and much more as you get with what looks normal. Again, this stresses the same, that systolic over as low as 119, 120, events still occur, and like I said, that is the largest number in the population. And this is the same, women and men much more involved, and you can see the hazard ratio of events, even with, if this is the comparator, then 120 to 129, you still get a 30% increment. 130, 139, which is supposedly a good control, you get an extra 60% enhancement of risk. Next. And this is largely the same, but what I was stressing here is that additional factor, myocardial infarction and stroke, show much more occurrence, and in people with what is supposedly a normal pressure. Indeed, when you define hypertension, you say above 140 over 90. However, when you look at this, this is within normal, yet you still get events. And that is critical consideration. And then that's really the same, that the people that you leave out, you realize you get a lot of activity events. Next. Benefit ratio, whom do you treat, whom don't you treat? And I've tried to persuade you that the people you may not be persuaded to treat have more events rate. Next. And African situation, the burden is there. The pre-hypertension, the people that we don't treat, are up to about 55%. And the people with hypertension that we are supposed to treat are about 20%. But we are saying the people we leave out have events. They have no symptoms, but they get events. What do you do with them? And this was a Kenyan situation by Healthy Heart Africa, and we are saying screening and control program. and how do we go about it. Next. Again, that is pre-hypertension. We are now saying that hypertension per se should be, in Kenya, about 70%. So 70%, where 55%, 55 of them are pre-hypertension, more events, 20% also getting their own events by virtue of their figure. So we have a burden. Next. And then the awareness is low, and the communication is also very poor regarding hypertension. Next. Again, the awareness about who is controlled, the prevalence, who is treated, who is aware, and who is controlled is worrying in Africa. And this is, you had seen it before, but doesn't come out on this color scheme very well. The guidelines are full of this. But I'm trying to persuade you that implementing this is a challenge. Next. More of the same, that we are very clear what you need to do on that patient or those patients that come to you, but accessing these patients and reaching them out to do all those good things is a challenge. Next. This is still a multiple risk factor. If you calculate their projections and look at their cardiovascular risk in 5 years, 10 years, and approach them in a multiple risk factor approach, then of course benefits are there. As you notice, systolic blood pressure, then of course the risk factor, multiple risk factor reduction approaches. And the same story in terms of the number needed to treat, so the public health considerations is if you need to treat few to get benefits, that is a very cost beneficial approach. Cost effectiveness is a different discussion. Next. We are very clear about the preventive and had been ably presented to you by the CEO of Kenya Cardiac Society, that we have evidence that when you use high fiber diet, reduce sodium, increase potassium, and enhance physical activity, and take less of Jeremiah's waters, then you actually get those benefits. Prevention, very important, but you can see how we perform in restaurants, then that questions what messaging do we need to carry. Now this brings us back to that evaluation in terms of when the patient comes, you say do pre-recording BP measurement according to guidelines, 7 to 8 minutes, then updates another 3 to 4 minutes, a lifestyle review and discussion another 7 to 10 minutes, and the total is about half an hour by the time you do all this. Do we have it? And in private setting, Dr. Eric Njenga from Kenya, Aga Khan, may have it. In fact, he can do 45 minutes because that reflects on the charge that will be. But in primary care setting, do we have that time? And that will also be corroborated or as a challenge in another setting. So if you look at our countries, the orange, our patients see us on average 3 times in a year. In the developed world, you can see they are probably seen 12 times every month, in a calendar year. Yet our patients are seen maybe for 3 minutes, 3 times in a year. That is a challenge in terms of the care programs that we are going to set in place. And I'm saying guidelines are very elaborate, extremely elaborate on what needs to be done. not so visible, but I just want to show you that you have done very elaborate things about what you want to do for patients. And it's a problem all over. The diagnosis, treatment, continuity of care, delivery of that care, and evaluation of what we are doing. People have done that, and in the Americas, as you see the latest publications, still recommendations and more recommendations. Next. And they have even told us that by the cardiology, American College of Cardiology, they identify all patients eligible for management, monitor, increase patient and provider awareness, providing an effective diagnosis, and all that, clarifying roles of providers, and prescription after prescription. Next. In Africa, we now know that the blood pressure control is a challenge for patient reasons, the professional, and the health system. And of course, the health system is defined by public policy of the governments. And the recommendation is improve government commitment, patient awareness, and access to medicines. Some design country-specific screening programs, empower clinicians to follow individualized treatment. Next. So in the review of this, and this is probably one of the most important slides as I end, that what I found is there is no consensus at all in the clinical practice guidelines regarding screening and case finding of hypertension. We start from the case and be elaborate, but there's no consensus how you're going to do that case finding. And there was a review, screening, if you give me 1 minute only, that screening strategies for hypertension. The review question was, what effects do the different ways of screening for hypertension, mass, targeted, or opportunistic have in decreasing illness and death? This is a Cochrane review earlier and later in 2020. There's that high quality evidence for RCTs or programmatic evidence from non-RCTs on effectiveness and cause of harms and different screening strategies for hypertension. Mass, targeted, or opportunistic to reduce hypertension-related movement is lacking. And they say the health system outcomes heavily rely on the context of the country's healthcare ecosystem. And the verdict was that healthcare utilization, time spent in care, duration on medication, linkage to care, that's the ecosystem as it were. Then there was also the question, what is the strategy of case finding? Is it a syndromic approach? After all, hypertension coexists with other conditions. Then, of course, I've talked about risk factor stratification strategy on those who get diagnosed, linked to care, determine to start treatment and frequency of follow-up is a resource-consuming investment for health system to implement, especially human resource for health. And that is also, again, just the continuum and the strategy, very elaborate, difficult to implement. Next. And we are saying that those that have less of the, who don't look like they don't need treatment, actually have underlying risk factors that we cannot establish in a primary care setting. Next. And when you treat hypertension well, then of course you prevent many things. But I wanted to stress albuminuria as a critical, just dipstick thing that you can do in primary care to determine kidney disease, cardiovascular risk, and loading it onto patients who actually need effective treatment. Next. This was a very interesting thing. Again, many assumptions, but implementation is a big challenge. Next. And I hope I persuaded you that we have a lot of information on hypertension, but how to get our patients into therapy pipeline is a challenge. And we need to think as clinicians, public health physicians, to see how we are going to find the cases in a very patient-centered, sensitive manner into treatment and do less harm and more benefit to these patients. And that's why even when we know it's not enough, we must apply, and it's not enough to be willing. We just have to do. Thank you.
So thank you so much for that kind introduction, and I'm going to explore the topic of how we actually try to tailor our therapy in the modern era of type 2 diabetes management. So I'm based in Aga Khan University Hospital, Nairobi, from Kenya. And the outline of the talk will just basically, we'll look at what the global burden of diabetes is and what problem we're actually having in the setting of Africa. We'll look at patient-centered glycemic management and how we actually put the patient at the center with two-way communication with regard to all the members who actually form part of the multidisciplinary care team. Then we'll look at how we actually tailor therapy in the modern era of type 2 diabetes management to improve clinical outcomes, predominantly minimizing both macro and microvascular complications. And also we'll look at now the specific roles of each of the MDT teams that actually play a crucial role in actually minimizing our complications. So just briefly, Kenya is in the East African region. We have a population of around 53 million people. And just to emphasize that even in all our countries, we still have a huge deficit in terms of human resource. So for 53 million people, we only have around 20 endocrinologists, and the sad thing is that around 19 out of these are based in the capital city, Nairobi, and we only have one individual out of the capital city. So we still need to think about how to diversify and spread our human resources outside the capital. So we all know that diabetes is the single largest disease pandemic that we're dealing with in the 21st century, and Africa is at the forefront with an anticipated 143% increase in the actual prevalence of diabetes. So we must be able to adapt our healthcare system to deal with this growing burden, so as to be able to have the adequate human resource, adequate infrastructure to treat these particular individuals, and more so to ensure we have good clinical outcomes in terms of reducing morbidity and mortality that is linked to type 2 diabetes. And you can see there's a huge difference as compared to the other parts of the world where we are going to have a huge increase not only in diabetes, but also in other NCDs such as hypertension, as well as cancer. Next. So the current ADA-ESD consensus as of 2022 now says we should look at a patient-centered glycemic support system. This basically means that we must come up with a care plan where you discuss with the patient. There must be two-way communication. Your patient care plan must be able to have specific measurable objectives. As you've seen, there must be SMART objectives that are here. This care plan must be reviewed periodically, at least twice a year, or at least at the bare minimum once a year. You must take into account specific patient characteristics. What's your patient's lifestyle, behavior, their career option? If you're trying to look for more stringent treatment regimens, is your patient going to be able to adapt to these particular regimens? Are they going to be sustainable? You must look into factors of costs, socioeconomic factors, cultural factors. You must look at language barriers. You must put all this into context with the patient at the center to ensure you have the best treatment outcomes. Also look at other things, patient characteristics, underlying comorbidities. You know that we have a paradigm shift with regard to our guidelines, where we think about key factors such as heart failure and chronic kidney disease at the forefront of how we actually choose certain therapies. For example, SL2 inhibitors, which have now gained a key prominence over the past couple of years. So we must form a care plan, and this must be delivered by a specialized team, a multidisciplinary care team with the patient at the center and two-way communication between the patient and each of these members that play a key role. Next slide. And here are some of the individuals who are involved in this care delivery, and all new diabetes practices or any particular center of excellence must have these particular people on board, or these groups of specialists on board, to be able to ensure that the patient is at the center, we have the appropriate decisions made between the clinicians and the patients, and we have appropriate clinical outcomes in terms of reducing macrovascular complications and microvascular complications, and having the overall objective of having a patient who is well educated and empowered. The patient with the best outcomes is a patient who is empowered, educated, and be able to achieve your long-term goals in terms of this team. Now, to be able to achieve this, you must have complete synergy between all these factors and all these individuals who are taking care of this team. Now, the best or epitome of team synergy is actually seen in the sport I love quite a lot, is Formula One. Now, on average, each Formula One team will have at least 200 members to make a Formula One team run for the year. Now, the average pit crew team of a Formula One team will comprise at least 20 individuals who must work flawlessly in complete synergy to give you the fastest pit stop ever. Now, just by a quick poll, how long do you think it would take to have a Formula One car come into the pit stop? The car is elevated, jacked up, bolt nuts removed, wheels are removed, new tires put in, bolt nuts replaced, aerodynamics checks, and the car goes back out. Give me an estimate. How many? 3 seconds. Okay, you're still a bit far off. Let's see, one more. 5 seconds. Next slide. 1.82 seconds. They say blink and you'll miss it. So this was the time that was set by Max Verstappen. Keep going. The current world champion, blink and you'll miss it, 1.82 seconds to do that. That requires flawless team synergy to get this done, and that's what we really want in the setting of diabetes practice. It was set in 2019 at the Brazilian Grand Prix, and that's the next slide. And that's now the Red Bull team, which is now, as you know, leading the Formula One race. But even Mercedes were also quite good in previous years, but Red Bull took the challenge. Next. So what are the key things that you want in this MDT team? Just keep going, the slides there. One, you want this care delivered in one locality. You don't want your patient moving from point A to point B. There's no need of your patient walking, it has to climb down 4 steps, move to the next building to access the podiatrist, then move to another building to access the ophthalmologist. You want to have a standard uniform pricing model, because remember, if you have fragmented pricing, they come to me, they pay $40. They move to the podiatrist, they pay $20. They move to the nutritionist, they pay $10. It becomes expensive and impractical. You want to ensure the patient is at the center, two-way communication between the patient and each member of the MDT team, which is very, very key. And just like in Formula One, you must work in synergy with common goals, all following guideline-directed medical therapy to ensure the best clinical outcomes for your patient. And like we said, seamless communication is key so that your patient is empowered. Like we said, the patient with the best outcomes is an educated and empowered patient. Let's move. And like we said, all treatment goals must be smart. Next. So this has to be individualized. There's no one size fits all. All our patients are different depending upon their background, depending upon their education status, depending upon their culture. So you must be able to tailor make each treatment plan which will be sustainable with the best outcomes for your patient and must be able to achieve what exactly that you want for your patient. So diabetes, like we said, it's a very heterogeneous condition with regard to, is obesity a concern in your patient? What's the age of onset? Someone with 38 years versus 60 years of age. Genetic factors, comorbidities, heart failure, chronic kidney disease, and also ensuring that you tailor make your patient to ensure that you have good outcomes in this particular multidisciplinary care approach. Next. So let's first think about how we tailor therapy in the modern era of type 2 diabetes management. Next. Key thing, very key aim, cardiovascular disease is the leading cause of death in at least 50 to 80% of all your patients. It's a major cause of end-stage renal disease. As you can see, 44% of all new cases of renal disease are actually due to diabetes. At least 16% of all individuals above the age of 65 stroke is directly attributable to diabetes. Commonest cause of non-traumatic amputations in individuals who are 20 years or more. And also it's a very, very key cause of reversible blindness globally. 0.4 million cases of new onset blindness in the world are directly attributable to diabetes, and it is presentable, as you can see here. So our care plan is to avoid all these particular complications. Next. Cardiovascular disease. And again, that's now, we had a paradigm shift in our guidelines from 2018 to try and avert cardiovascular disease. Acute coronary syndromes, as you can see, are actually threefold increase in this particular setting. They occur 15 years earlier, and you have a twofold increased risk of both short-term and long-term mortality. All complications, reinfarction, cardiogenic stroke, heart failure are commoner in your diabetic individuals as compared to age and sex match non-diabetic controls. So CVD risk reduction is very, very key as you think about your treatment approach in our patients. The other key thing is heart failure. And we know that heart failure is much more common in diabetes. It can be either ischemic or non-ischemic in terms of its etiology. So 15% of your patients will have heart failure. If they have heart failure and chronic kidney disease, and the risk of heart failure actually becomes 3 times higher. And chronic heart failure occurs in 15% of patients across their lifetime. So again, very, very key thing to think about as you think about therapy. Next. Now, what is interesting that even if you have all your guideline recommended targets for cardiovascular risk factors, hypertension, exercise, smoking cessation, lipid management, patients on statin, good blood pressure control, the risk of heart failure hospitalization is still exceptionally high. It's still as high as 45% in your patient, despite all your other cardiovascular risk factors being well managed. So you must really think about heart failure as a very, very key comorbidity in any particular patient who comes in with diabetes. Next. But it's very key. All these risk factors, as Professor C.F. and all our speakers have alluded to, must all be controlled, because if you control them, the benefit that you actually gain approximately 8 years of life in your patients who have type 2 diabetes. We know that on average, anyone who has diabetes above the age of 40, compare them age and sex match controls, they will lose approximately 15 years of their lifespan. If they have a myocardial infarction, they lose 6 years if they, as compared to age and sex match controls, 15 years if they have diabetes and a primary cardiovascular event like a myocardial infarction. So at least ensuring that all these other things are well controlled will give them at least 8 years in terms of benefits. Next. So key priorities when you think about therapy is that number one, you want to ensure your specific A1C targets. You want to think about reduction of cardiovascular risk. Weight loss is actually a key thing, hypoglycemia, cost as well as durability of therapy. And you must think about the evidence to show which drugs are actually safe, efficacious, and are well tolerated in your particular patients. Next. So we'll now quickly review the guidelines of what now, like we said, we had a paradigm shift from 2018. Key thing, metformin, diet exercise is still the backbone of therapy. From there, you want to consider who are those who have established atherosclerotic cardiovascular disease, or those who are high risk, and you must consider the use of drugs such as GLP-1 analogs. And if they have underlying comorbidities, heart failure, chronic kidney disease, you must consider the use of your SGLT2 inhibitors very, very early on in therapy. If hypoglycemia is a concern for your patient, choose therapies that will minimize your risk of hypoglycemia. So DPP-4 inhibitors, GLP-1, TZDs, or SGLT2 inhibitors. Weight loss is a concern, then you're going to use drugs like GLP-1. We know that the increased use of GLP-1, even in the non-diabetic setting, with the drugs such as semaglutide having very robust weight loss trial data. And in Africa, like we said, we must consider cost working in a low-resource setting like in sub-Saharan Africa to ensure that treatment is sustainable for your patient. Next. So let's now look at each of the components in how we actually deliver care in a multidisciplinary care setting. So the first key thing is diabetes self-management education and support, what we call structured diabetes education. This is very key because this is what actually helps your patient to become empowered, develop good self-care skills. And it says that, for example, most of your patients, if they are knowledgeable, they will have good outcomes. They will have established, they will be able to have well-established glycemic targets which are within range. They will have good clinical and physiological outcomes, and of course, you reduce your hospital admissions and all your complications. It can be structured in different ways. We know now with the COVID pandemic, it can either be delivered physically, or you can use a number of virtual platforms, web-based, phone-based platforms. And it's normally given by what are referred to as diabetic nurse educators. And we've also had training programs, even through Merck, which have enabled us to have at least increased access to diabetic nurse educators. And these are actually the key cornerstone individuals in any particular practice. Like we said, first time with a diabetic patient, as a clinician, if you have a very heavy workload, it's very difficult to deal with all those aspects of care. How do you inject? How do you exercise? How do you eat right? But they can spend at least an hour with the patient and be able to empower these self-care skills for improved clinical outcomes. So a key thing that they must focus on: physical activity, weight management, medication taking behavior to also improve medication adherence, improving self-monitoring skills, enabling that patient to have good self-care skills in terms of managing their diabetes every day, coping and problem solving, as well as preventing and recognizing complications very, very early on. And of course, adapting to your day-to-day life. My work, my school, my family balance, all this is key by actually learning what to do in terms of how to take care of my diabetes and how to ensure that I'm taking my medications correctly. So they say that for best support programs, at least you must have a contact time of at least 10 hours for the patient to derive benefit. Proceed, yeah. And like you said, they can be delivered through a number of platforms to ensure that, now that with the COVID pandemic, we had a huge problem with delivering diabetes education, especially for those who are developing diabetes post-COVID. They're in isolation, you're starting insulin, you can't have an educator going into the room, but we're able to use, like in our facility, we made short YouTube videos. How do you use your insulin? How do you inject? How do you monitor? And these were given to the patients on discharge. So remember, we can now exploit technology to try and have the reach of diabetes education to have a much bigger patient profile and even across large geographic zones. Next. Yes, proceed. We've discussed that. Yeah, and proceed. Yes, next slide. So the key thing that you now want to have your patient who is well educated and who can now think about their life in a 24-hour cycle. Number one, they know that they must at least be conscious about improved activity levels. Reduce inactivity, improve their step count. For example, just simply increasing your steps by 500 per day will reduce your cardiovascular risk by 9%. 6 minutes of brisk walking every day improves your life expectancy by at least 4 years. Good sleep pattern, right quantity of sleep, right quality of sleep, and avoiding negative sleep chronotypes, for example, late sleeping and late waking up, which will reduce your overall inactivity. The fact that diabetics are more frail as compared to their age and sex-matched non-diabetic counterparts is something to take into consideration. Correct exercise techniques with combination of aerobic and resistance training are key things to think about. So all this is all factored into your education programs so that in 24 hours your patient can actually live a healthy lifestyle. Most of my Kenyan female colleagues were reaching 15,000 steps shopping yesterday, so good kudos on your life expectancy. Next. Counseling. So very, very key is that depression and diabetes actually share a common pathophysiologic mechanism, and they have a shared model in terms of how they occur. And sometimes you don't know what comes first. Is it depression that will predispose you to diabetes? Lifetime risk of developing diabetes in the setting of depression is around 60%. Some of the treatments used in depression can't predispose to diabetes. If you are diabetic, you can see the risk of diabetes as compared to the general population. 3-fold increased risk in the setting of type 1 diabetes, 2-fold increased risk in the setting of type 2 diabetes. Specific groups tend to be more depressed, and you have to look for it more keenly. Type 1 diabetics, especially in the adolescent age group, pregnancy, elderly patients, and those who have underlying comorbidities. There's a 40% increased risk with regard to anxiety in the setting of diabetes, and all this will complicate your treatment goals. It will worsen your prognosis, increase non-compliance, increase mortality, and also decrease overall quality of life. So you must really, really think about how to screen for diabetes early on, not only at diagnosis, but also periodically in the course of treatment, at least every 6 months, with well-established questionnaires like PHQ-9 or the Beck's questionnaire. And the data is overwhelming in terms of the prevalence of diabetes and anxiety disorders in the setting of diabetes. Next. We've covered that. Next slide. Glycemic monitoring is another key thing, and we know that even in low-resource settings, for example, in Africa, strips are also quite expensive. In my country, an average pack of strips will cost you $25. How do you maximize those 50 strips to at least get adequate information as a clinician to make rational decision-making, to have rational decisions with regard to how to monitor your therapy and how to tailor your therapy? So even in that particular setting, you can also consider the use of CGM. I know it's out of reach for most of us, but you can use CGM in specific patient profiles. For example, those who are high risk for hypoglycemia, your type 1 patients, your CKD patients, very erratic sugars during pregnancy. So at least for those ones, CGM is becoming cheaper even in our country. So we are having increased use of that particular modality with regard to monitoring our sugars. And the world is shifting towards just looking at a normal A1C and focusing more on CGM. Next. Because A1C has its limitations. Even in Africa, we know we have the sickle cell belt, we have hemoglobinopathies, anemia due to helminthic infections, and malaria. So having CGM, if it's available, if it's affordable in your setting, is a much better prognostic marker, because if your sugars are within what is called the timing range, blood sugar between 3.9 to 10, then it has a potential of causing better clinical outcomes in your patients. Reducing all your macrovascular events, but most importantly, minimizing hypoglycemia. Because hypoglycemia is what actually causes complications, such as worsening chronic kidney disease, and worsening retinopathy and nephropathy. And you can minimize all this in your patients if they're able to use CGM if they fit the criteria and if they can afford it. Yeah, next. Let's briefly discuss about weight loss. Next. And again, weight loss has to be taken into context. So we're looking at nutrition, we're looking at exercise regimens to actually tailor to your patients. Simply losing at least 5 to 10% of your weight loss has better metabolic control, and more robust weight loss programs like bariatric surgery, keto diets, low carb diets will actually help in actually causing what is called diabetic remission, where you can actually maintain your A1C at least below 6.5 without any pharmacologic intervention. And also you can think about therapies that also promote weight loss in addition to controlling your glycemia, like GLP-1 analogs and SL2 inhibitors. Next. Yeah, so exercise physiology programs, now you must also consider that programs that also are tailor-made to your patient. And these must have the following characteristics. So whenever you're prescribing exercise, we are not trained very well as clinicians to actually prescribe exercise, but you must think about how they are adaptable to your patient. They fit your specific patient profile. You can have a patient who is elderly with osteoarthritis. How do you advise someone exercise without causing further joint damage? You have someone who is young. How can you tailor-make therapy to that particular patient? Next. Scalability, and also you should be able to have efficacy over a long period of time with regard to how the exercise is performed. And again, exercise also must have its benefits. So let them at least not spend more than 2 days a week without having continued exercise, because those metabolic benefits, if they are to have long-term benefits, they must be sustained not only during that particular week, but through the patient's lifetime, and to enable good glycemic control overall. Next. And this also must be, you can split them between aerobic and resistance training. And the key things that remember that for those who have these particular conditions, for example, proliferative diabetes retinopathy, severe heart failure, recent cardiovascular events, you want to avoid resistance training in these particular patients. And it must be the right frequency, intensity of volume, and it must be able to derive metabolic benefit and be sustained through a patient's lifetime. Next. Nutrition also, like we said, it must be tailor-made to your specific patient. You look at the specific socio-cultural factors which your patient is going to be able to sustain. There's no need of prescribing a diet which your patient can't afford, cannot sustain. So try and make it tailor-make it specific to your patient to ensure that you have weight loss. Nowadays, low-carb diets, like we said, have increased uptake and endorsed by the ADA. So we have a lot of keto diet practitioners who are well-trained, who can be able to offer this for diabetic remission programs, improve glycemic control. But again, you must have measurable components to be able to see that these diets are actually working and they can be sustained by your patients. Next. Bariatric surgery, as we know, has immense benefits in terms of improving your overall metabolic profile, lowering your cardiovascular risk, and also even minimizing all your microvascular complications. And at least we know that it's indicated for all people who have grade 3 obesity, but now most societies are actually endorsing it for low grades of obesity. For example, grade 2 and grade 1, if you can show that they have multiple comorbidities and you have significant hyperglycemia despite optimal medical therapy, we can adopt bariatric surgery. Next. The most efficacious, as we know, is the Roux-en-Y gastric bypass, but you can also have any of these other modalities being used. And even the some which can be used to bridge, for example, saline-filled intergastric balloon devices can be used as actual bridges. So these are now being used in modern-day clinical practice. There's increased uptake amongst most of the endocrinologists for bariatric surgery. So again, if the patient qualifies, please refer them early. Next. And again, as long as you have good post-op care and protocol for your patients, nutritional support, screen for micronutrient deficiency, counseling and psychiatry, which will be done pre and post-op for bariatric surgery, and you have other inputs from the exercise physiologist as well as the endocrinologist. Yeah. So for foot care, we know that diabetic foot is a leading cause of morbidity and mortality. Anyone who's had an amputation, their overall risk of cardiovascular mortality is in excess of 70%. 85% of amputations are preceded by a diabetic foot ulcer. So you really want to ensure you screen appropriately for your patients, pick it up very early, and ensure protocol-driven guidelines are actually instituted to ensure that you prevent amputation in all your patients who have diabetes. Next. So key things. Number one, you want to have four key things that are emphasized here. You want to make a rapid and accurate assessment with regard to the condition of the foot so that you ensure that you institute appropriate management early on. You have adequate imaging to ensure that you can revascularize your patients early if they qualify, diagnose infections so that you can start your antibiotics very early on, and perform an assessment for ischemia to actually know what kind of intervention you'll require in terms of revascularization or any other modalities of treatment that are needed. Next. So ophthalmology services also are very, very key. We said it's commonest cause of preventable blindness. And as you can see there, the global incidence of retinopathy is around 2.2 to 12.7%, with a progression rate of 3.4 to 12.3. And most of your patients can actually have life-threatening edema, with 7.6% of them having 7.6% having macular edema, which can actually portend as a potential threat for sight loss in your patients. So this must be able to be screened early on. Next. And now we have very low-cost ways of actually screening for retinopathy. We now have increased use of technology, where we have artificial intelligence. You now have very good retinal image analysis systems, where you can actually have as non-ophthalmologists trained to screen for retinopathy. Digital photographs are taken, they're sent to a central station where they can be reviewed by an ophthalmologist, who will then determine who is actually going to benefit from early intervention, and they can be classified, and you can make a detailed treatment plan. So again, we can exploit technology in this setting. Let me just wind up on the last. So lastly, vaccinations, as you're aware, people who have diabetes are more predisposed to infections. Next slide. And even in good hospitals, even in good settings or good economies, vaccination uptake is still very low across all vaccines for patients who have diabetes. So either pneumococcal, hepatitis, zoster, or even HPV, we still have suboptimal uptake of vaccines. So these are recommended schedule for all our patients who have diabetes. Next. And at least you want to emphasize that they get the yearly influenza vaccine, SARS-CoV-2 as per your national guidelines, PPSV23 for all people between 19 and 64 with diabetes, and for those who are 65 years and older, at least they get their PCV13 and your PPSV23 thereafter. So in conclusion, you want to ensure that all the individuals involved in this multidisciplinary care team are following guideline-directed medical therapy. We've talked about the need to have national established protocols for both inpatient and outpatient management of diabetes. And we talked about the issue of data collection, having patient registries, which is also very, very key. So in summary, you want to ensure that you have a center now in the modern care diabetes practice, which is employing a multidisciplinary care approach model with at least two-way communication with the patient at the center, which is key, and integrate the use of technology, not only in delivering direct diabetes care, but also in other modalities, for example, ophthalmology, diabetes education, which can all now be scaled up and even be used in a much larger patient population profile. So thank you. Good.
Thank you very much. Good afternoon to all. By now, we understand that the burden of non-communicable diseases are increasing, including in countries that are classified as low-middle income countries, whether in sub-Saharan Africa or Northern Africa or other continents. And the non-communicable diseases, as is named, they are a result of a combination of factors that includes genetics, physiological, environmental, and behavioral factors that we actually had opportunity to listen. So a part of these factors that we discussed, there are also other factors like urbanization and well, we also discussed about unhealthy lifestyles and population aging. So usually when we talk about non-communicable diseases, we tend to talk about demographic transition and epidemiological transition. In our context, but particularly in sub-Saharan Africa, yes, we are observing demographic transition, but we are not at the same stage as developed countries. We still have huge proportion of young population. So we are not at the same stage as developed countries. Regarding epidemiological transition, actually in sub-Saharan Africa, we did not observe as classically classified epidemiological transition. What we are noticing is some change in epidemiological profile, where we still have a considerable burden of non-infectious diseases, as was mentioned by my previous colleagues who talked about this. And also we are observing an increasing proportion of chronic non-transmissible disease. So usually people talk about double burden, because of this coexistence of infectious diseases and non-infectious diseases almost at equal proportion of burden. Okay, we have seen the burden of non-communicable diseases are increasing, particularly cardiovascular disease, cancer, respiratory diseases, and diabetes. The factors, usually, there are many factors, but usually we tend to focus on the factors that we can intervene, we can modify, such as unhealthy eating, tobacco use, physical activity or inactivity, and alcohol use. Okay, next, please. Okay, I will skip this because you have seen the burden of non-communicable diseases. Yes, just to gain some time. This is the burden in Africa. This was published by Lancet Global Health. Perhaps I would say that one of the limitations of our continent, particularly, is a scarcity of data. And many of the data that is presented, they are based on sometimes single measurements or sometimes two measurements, and there are not enough measurements to actually give us an accurate picture. And the measurements for non-communicable diseases are done, as was mentioned by our colleague, through stepwise surveys that are WHO-sponsored surveys that are done periodically. Some countries has done two times, some countries only one, and based on that, this is done to estimate the burden. So please take this as indicator, not as a precise data. A part of this, for example, in my country, Mozambique, the data that are presented is aggregate data. But if you stratify between provinces or districts, you will find huge diversity. Then again, you have to always keep this in mind, that data is just indicator. They are not precise, just to guide us, give us a picture. It's in different sub-Saharan regions. You can see, for some reason, Central Sub-Saharan Africa has a considerable burden of these chronic diseases. I don't know why, but just to show up. The difference between male and female, you can see there is slight difference. Males more affected slightly than females. We have now opportunity to have some data, particularly data that are generated within this context of SDGs, Sustainable Development Goals, where we actually have one target for non-communicable disease, which is to reduce premature mortality by a third by 2030. And this is based on the data that we have for each country for 2015. However, the WHO considers that we are very far from getting to these targets if we keep same pace, same interventions that we had between 2010 and 2016. So if we don't change, we will not attain the target. We have seen our colleague from Kenya presented the WHO strategy for 2015-2025 to reduce 25% of mortality from cardiovascular, cancer, diabetes, chronic respiratory diseases in persons aged 30 to 70. And these targets were presented very nicely in a graphical way. Here it's in the text, much more difficult to follow. But anyway, we have these targets established by WHO, and then again within the Sustainable Development Goals, where actually the targets are there, reduce all of those by 1/3. And as my colleague mentioned, zero increase in diabetes and obesity.
So there is an interesting paper published in Lancet recently, shows that little progress has been made by most countries to attain this goal. There are specific interventions that are in place across the countries and regions. There are policies to reduce the risk of tobacco smoking, harmful use of alcohol or other risk factors. But the discourse around the NCD priorities now, according to the authors of the paper, it's necessary to shift this discourse away from quick wins, like opportunistic screening, etc. We need to have something more consistent or persistent and more sustained and it was mentioned, more political commitment, more different approaches, different strategies, if you want to achieve the 3.4 target of Sustainable Development Goals. Next. Well, there are many interesting frameworks to look at the risk factors and the impact of risk factors on NCDs. They are theoretically very nice in terms of conceptually beautiful, but they are actually, as Professor mentioned before, quite difficult to implement. That's true, because most NCDs, they are silent diseases, okay? So how can we diagnose, how can we know if a person has a disease, if the person is not seen by a health professional, is not screened by a health professional? So it becomes quite difficult. This is one conceptual framework. I will skip this just to show you they're different. There's another way of putting it, another way. Okay, this is perhaps one that I will a little bit talk about, Certainly there are many factors, contextual factors like globalization, including like diet. Our choices of diet are influenced not only locally, but also what we see, particularly now through social media, through TV, etc., which, it's natural. We are humans, we are attracted with these things, and we adopt certain habits, certain styles, certain behaviors because of this influence that is global. We have the issue of urbanization, perhaps the way urban planning was envisioned initially needs to be again reviewed, because most urban places actually, they sacrificed places of leisure, places where encourages you to have less stressful lifestyle, encourages you to practice some exercise, okay? For that, it's very difficult, but the way the urban settings were placed, it doesn't encourage you to think about just having a walk, or, mainly in sub-Saharan context. Okay? Now in developing countries, they are changing. They are trying to combine, green environments, places where people can like open door gymnasiums, if I can call like that, where you have different facilities to practice some exercise, etc., in a nice, beautiful environment. We have the problem of air pollution, which also have a great impact in NCDs, the issue of poverty. I mean, all these factors that were mentioned also by our colleague. When we look at the individual patients, we need to look also to these factors which are social determinants, okay? Because not only medication will change the outcome of the patients, but also intervention in social determinants. Then we have behavioral risk factors, which are mostly individual. Okay. Also, there are influence of peers, whether it's a peer, same group, same social group, etc. And in these risk factors, we include tobacco, unhealthy diet, physical inactivity, etc. Okay. Then we have biological risk factors for NCDs, high blood pressure, high blood glucose, etc. And all of them will impact to developing NCDs afterwards. Okay, I will skip this slide, but this diabetes and hypertension, these are two conditions that are more prevalent, and my talk regarding community awareness will be on this too. Diabetes and hypertension also occur simultaneously in same patient, which we have seen that it worsens the outcome of patients. Okay, apart of occurring separately, when they are together, the complications are greater, particularly at level of cardiovascular disease. Next, please. This slide, I only wanted to highlight the issue that Professor raised about knowing that you have the condition, whether it's high blood pressure or diabetes. Then after knowing, taking medication, being on treatment, adhering to your treatment, and having you control. It's always problematic, okay? Because how someone who has no symptoms know that has a pre-diabetes or pre-hypertension or hypertension or diabetes, if the person is not tested, not screened, is always difficult. How the stepwise surveys have been useful to indicate us, to illuminate us about the prevalence of the condition at population level, okay? But they are not done on regular basis. They are done periodically and after some time. But you can see, perhaps in next slide, that Professor already presented, you can see that the amount of people or the proportion of people who does not know their condition, whether it's hypertension or diabetes, is quite huge. So what we can do to get these people to know that they have the condition, that's the big challenge. And perhaps through community awareness, this is where we want to target, because from a person who knows and who is in care, then the responsibility to treat, to control this person will be within the clinical context, within the health professionals team. Perhaps not that difficult, then this is okay. Controlling, for many reasons, controlling diabetes or controlling, and the clinicians here know how difficult it is. Even if someone knows that he's diabetic, he's hypertension, start medication, interrupts medication, doesn't take medication adequately, doesn't follow other recommendations apart of medication, and always become a challenge to have hypertension or glycemia under control. Yeah. So everyone has this experience. So next slide. So what we can do, we can intervene at different levels. We can intervene at policy level, we can intervene at health system level, and also at clinicians level. Okay, it was mentioned that the issue of policy is important. We have to have policy, and the policies that were put in place, like for tobacco, for alcohol, and for high sugar beverages, like in South Africa, in other developed countries, there is no doubt that it is having impact. Okay, now it is true that we need some time to see the real impact. Okay, but they are important. And this is based on evidence that we have, and it is based on global advocacy. Even if our country has no capacity or power to implement some of these things, WHO and other global actors are putting pressure for us to actually implement this, what they call cost-effective or best buys interventions. Within healthcare systems, there are many challenges, particularly in our context. As Professor mentioned, do we have time to interact with patients, to do the counseling the patient needs, the multidisciplinary approach that we need? This is a big challenge. But anyway, also restructuring our healthcare system from mainly acute, particularly in primary healthcare, where the setting is for acute care, shifting this care, this focus to chronic care, it has been challenged. For example, in chronic care, we need to follow patients. So patients need to have a file. In acute care, we triage, we screen patients, but we not necessarily do a follow-up. With the emergence of HIV epidemic, of course, many primary care took the role of treating and following, providing this continuity of care to patients. But a part of HIV care, the other conditions did not merit, as was mentioned also, for many reasons, not only money, but perhaps also political reasons, political shift of mind. Okay, next slide, please. Okay, so what we need to do according for the non-communicable diseases, particularly to raise awareness. First, we need to talk about this, increase the literacy of everyone, whether at the school level, whether at community level, every level we need to talk about this. So people are aware that what is diabetes, what is hypertension, etc. And we also need to educate patients, because in non-communicable disease is not only health promotion and primary prevention, but we also need to think about secondary and tertiary prevention, because we need to avoid, we need to prevent complications. Otherwise, we'll have a huge problem and burden also to our health system. So raise awareness first, screen, take every opportunity. Health days, they are opportunistic way of screening. Perhaps we'll pick some patients that were not aware of their conditions, and by checking blood pressure, checking sugar levels, perhaps they can be aware, they can be then linked to the healthcare. But we need to think about new strategies. How can we pick up, how can we increase, expand a screening strategy where we can reduce that slide that we saw, the orange proportion, to a minimum. Okay. So the diagnosis, decide about treatment. Here the clinicians have an important role. The follow-up, monitoring, etc. And so we need to think about this continuum of care. Next, please. Okay, we have, regarding promotion, we have different, how could I say, different points of intervention, okay? So population is apparently well, general population. We can do, health promotion activities, raise literacy, increase their knowledge about diseases, etc. Population at risk, we need to target them, screen them. When they come to hospital, if they have characteristics that put them at risk, screen them. They might have come for a headache or for malaria test, but take blood pressure, measure sugar, see if they have this disease. This is also opportunistic way of we have different opportunities within, from before onset to the after the condition is established. We have different opportunities for the prevention. This is, so we have primary prevention, we have primordial prevention, we have secondary prevention, so different strategies. And lifestyle is a major factor, and is the one that is more difficult to change. Everyone knows, if anyone tried to diet, to reduce weight, knows how difficult it is. How difficult a person needs to be aware convinced, start that diet, and then persist, not relapse to old habits, etc. So it's not easy. It's same for tobacco consumption, same for alcohol. It's very difficult to change behaviors. Our colleagues from social sciences have developed different theories about that, what makes people change their behavior in relation to health. And we can learn from these experiences. This is just to show that, and it was mentioned by our colleague also, different sectors need to play a role here. It was emphasized by our colleague, Dr. Linian, so I will skip this. The best buys, also, the previous slide, please, the best buys. It is WHO have encouraged countries to use this strategy. Actually, the strategy to 2025 also mentions this. You know, there are different strategies. They need to be implemented in combination to have impact. Next. So Dr. Linian also mentioned, you know, some of the interventions need to be implemented when the mother or the woman is pregnant, because some of the consequences in later life will start before. This graphic shows adolescent, but it starts when the mother is pregnant. So the diet, lifestyle, etc., will impact and will leave some marks, which will then be very important for, okay? Health literacy is something that now is picking up as very important aspect, and some countries have developed booklets or content to increase the literacy of, and not only for non-communicable diseases, but it's integrated. It's also for infectious diseases, STIs, etc. So it's integrated approach. Okay, just to finish, this is last slide. Perhaps one of the channels that we can use to increase this awareness, okay? Because we have, this is perhaps one of the cost-effective interventions using media to raise the literacy of our populations, okay? So media can produce positive changes to prevent negative changes in health-related behaviors across large populations, because it targets large population. Thanks. This, I think it was the last slide.
Thank you so much. So I'm Sudi Ndikumana, a medical doctor from Burundi, and I've got this scholarship from Merck Foundation. I think we are here to testimony and to show what we've done according to what we've got as a scholarship. This is a Shifa Medical Center. I've created it on 2021. This is the building we are working on. It's not our building, it's a rent building till now. Yeah, we said that we have to go with a social venture, and then we are starting with this building. So we'll try to talk about the overview of the entire country, and then to share the vision of Shifa, and also to see that we have got some sharing experiences moment, and then what has been some results on our center, and we'll finish with a conclusion. Burundi is a country situated in the East African part. We have almost 12 million population, but our history is not so well to know. We have lived 2 decades of war, where the healthcare system is on decay. And then you can see that since 2005, there has been a decree from the President of the Republic that it must be free health care for children under 5 years and pregnant women. But the majority cannot afford health care because they are so poor. More than 90% are poor. And then we can see that there's some social beliefs. They go to social to self-medication, there's social stigma. So non-communicable diseases, when they live with non-communicable diseases, they think that it can be maybe witchcraft or something social. It's not normal. And then we are located in Buyenzi. It's a city. It's a quarter in Buyenzi, in Bujumbura, where the high prevalence diabetes and NCDs case have been reported on 2017. But also I'm among the first batch of Merck Foundation scholarship alumni. That we are thanking a lot the Merck Foundation for this opportunity, like in diabetes and others has been in infertility and oncology. Also, you can see that the non-communicable diseases is a burden on the health system in Burundi. This kind of our work we are doing in Burundi, not only in the cabinet, but also we have to make the community health awareness. We have to talk with them. We have to to give them education. This among the sharing experience in Merck Foundation activities when they run an annual summit in Burundi for Burundi in 2021. So we have been among the participants. So as a result is that we have almost 3,000 families covered by our program. And then we decided to make a medical consultation for free. There we give all first aid and checkups, and then we can see that in all the year past we didn't have any complicated cases. But also we do some charitable support in order to give the well-being sciences in our population. But we've since 8 months now, we didn't got any complicated cases in our center. This is a positive result for us. And then, unfortunately, we've got only 2 cases of death in all the year, because we can see that this is the fact of giving the regular clinical awareness and checkups. Yeah, okay. That's the finish. Thank you so much.
Okay. Okay.
Good afternoon. I work in the central region of Kenya, a place called Gatundu. It's not far from the Nairobi CBD. So I'm normally known in the diabetic circles and cardiac circles as the village doctor, because as you heard, most people, they work in Nairobi town. By myself, I've isolated myself to be a village doctor because I serve the villages within the village of Gatundu. But you can see, let's progress, next slide. It's not as village as it sounds, because it happens to be where our 2 presidents have originated from. So there's some structural development within that village that I work. As you can see up there, that building, the white one, down on the first 2 floors is where I do my medical wards. We have the female and the male medical ward. So down there we have our NCD center, which I opened with my colleagues 5 years ago. Previously we used to do our diabetic clinics on a weekly basis, but we established a daily running diabetic clinic. So by the time I was doing the postgraduate diploma in diabetes and endocrinology, I'd already started the NCD center. And normally we see 20 to 25 diabetic patients per day. That translates to 100 per week and actually 400 to 500 in a month. We have registered more than 4,000 patients who are diabetic. And my team comprises myself as the head of the department. I have a medical officer. I also have a clinical officer. This is a healthcare provider who has just done learning the training at diploma level. I have a nurse who is just passionate but not trained in diabetes, so we do on-job training. And also a health record officer because our files, we're still physical, we don't take them we don't combine them with the other files for the other patients. So we have our own filing system within our unit. What has this training, which I've done through the Merck Foundation, has done to me and to my facility? What I've noted is a better patient care, which there's some improvement. From our records, I went through our records and we saw this improvement of the HB1C, glucose control generally. And since you also see hypertensive patients within the same clinic, even the blood pressure control has been improved. And these, in the wards, you've seen you're admitting less and less patients with the DKA and acute complications, because you're able to do the on-site. Patient comes with a severe dehydration. Instead of admitting high sugars, we have a bed and we're able to rehydrate that patient, institute the insulin and averting readmission for that patient. And since the clinic runs on a daily basis, the patient is able to come back the following day. With this one, hospital admissions have reduced. There's also complications which have reduced, especially the diabetic foot complication. And generally, there's improved care and retention rate and transfer from other referral centers. Other new activities I've done, so I've held some CMEs on diabetes with and without the hospital. I've trained the MOs, online virtual training. I improved bedside teaching, because I also teach some students who from university. Then I've done some presentation in our latest KDSG conference. I was able to present, and also internationally. I was invited by one of my former tutor to present in the Global Diabetes Forum in India. Thank you.
Okay, afternoon everyone. My name is Dr. Amanda. I'm from Zimbabwe. I'm a public health professional. Currently, I'm working in malaria. It's a bit confusing with the NCDs and stuff, but it's really my interest and something I'm very passionate about. So I had the opportunity to enroll in the scholarship, and I chose preventative cardiovascular medicine. So I just want to really appreciate the presentations from this morning. I think as Africans or people coming from African and developing countries, this is a subject that is very, very important. And in my country, before this course, I really didn't have a true understanding or a picture of the burden of cardiovascular illnesses. So some local studies in my country have shown that 1 in every 3 adults above 30 is borderline hypertensive, which to me is really a public health threat. I think much, much worse than HIV. So I really appreciate the presentation by Prof this morning, which was really trying to communicate that HIV is now a problem to us in a different kind of way, because we are also having all these emerging issues with cardiovascular illnesses, risks among those individuals, which is increasing our prevalence of cardiovascular illnesses. So during this course, I really had an interest. I wanted to understand some context-specific treatment regimens in African settings. So I sat down, took out a bit of hypertension treatment guidelines from the different African countries, and really tried to look, are they context specific? Are they comparing their quality with what WHO is recommending and also with what the International Society of Hypertension is recommending? So I really noted that there were gaps in guidelines that really speak to our population. And then I really thought that this is important in this growing epidemic of hypertension as a cardiovascular risk in Southern Africa, and that there's an urgent need for us to really look at our data, to look at our population, and really come up with guidelines that really work for our people. So my plans, I'm really a public health practitioner, and I'm happy that in Zimbabwe we have really published almost finalized our first guideline for diabetes and NCDs management. And I also plan to set up some wellness clinics for hypertension management. And then I think here I was just trying to communicate that other issues that we need to really advocate for in our setting in Africa is to advocate for equitable access to cardiovascular treatment care, and also to really increase human capacity for taking care of our patients, because I think it's really a huge problem. And thanks.
Okay.
My name is Israel Hagbevo, and I'm from Ghana, as Sam has rightly introduced me. So the impact of Merck Foundation program on my practice. Generally, I think Merck has done very well. They've trained about over 100 medical doctors in Ghana, of which a little over 20 of us trained in preventative cardiovascular medicine. I have some of my colleagues over here. And the impact on our practice has been enormous. And personally, being a surgeon, I think I had a very good understanding of the assessment of the preventive or the assessment of cardiovascular risk in the elderly patients who are supposed to undergo any form of surgery. So throughout this program, I've been in a very good capacity to assess patients who are supposed to undergo surgery. And earlier on, I would disagree with my anesthetist on some cases that they disqualify, but from the training, I have actually grasped the concept of cardiovascular risk assessments, and that has actually helped me a lot in actually deciding with them on what cases to proceed with and what cases not to proceed with, and also what to actually do to reduce their risk, both pre, intra-op, and then post-operatively. But invariably, I think the program has been a success in Ghana, in that awareness creation has also increased. Last 2 years when Merck was, or last 3 years when Merck was held in Ghana, there was public awareness on televisions and radio stations as well. And I think that is going very well, to as well as increase awareness and then education on hypertension and diabetes. So I thank you very much for the opportunity, and we are much grateful to Merck. Thank you.
Thank you. I'm working in the provinces, the districts, one of the districts in Sierra Leone. I'm an early career health practitioner, as one of my colleagues said yesterday, like I'm a baby. But Merck Foundation gave me a platform to actually have the confidence as early as 1 year after my training to actually help tackle the high burden of cardiovascular conditions in the place where I was sent to work. Because unfortunately, as a medical officer, I believe all of you will argue with me that at this point you need mentorship, but unfortunately, I didn't meet mentorship where I was sent. There is no specialist, no one to guide me. And when I went through this program, I got the mentorship that I had always needed through the lecturers and through the individuals that was placed to guide me through the program, and it's really helped me a lot. And just this year, we have partners that came into the hospital and have started a non-communicable disease. And I would say this cause placed me in that right position for me to be taken. And now I'm the NCD coordinator for the new NCD that is going to be, that will start operating soon with supervision from a new specialist from Rwanda that will be my direct supervisor. So without this program, I would not have been selected probably, because I wouldn't have the capacity to treat such patients. Personally, my time management skills have improved all through this program. And nationally, I'll go a bit away from this. Nationally, I think we have a lot of areas in Sierra Leone that we lack specialists. Like, for example, cardiovascular medicine, I think we have only one specialist, Dr. Russell, that stays in the capital city for a population of 8 million. And that shows a dire need for such specialists. So I think Merck Foundation have stepped in the right direction to make sure that we have specialists that can mentor and treat patients that need this treatment. Thank you very much.
I am Dr. Anas Amasago, a physician from Ofodo University Teaching Hospital, Sokoto. I want to start by thanking the organizers for the invitation and for the sponsorship to undergo the postgraduate diploma in endocrinology and master's in endocrinology from the University of South Wales. I thank you very much. My institution in Nigeria is an institution that had some challenges. And some of the challenges we have before now, although we have fellowship in endocrinology, and there is no structured postgraduate training, that is academic training, either a master's or a postgraduate diploma in the place. We have guidelines that are worldwide guidelines, but they are not tailored towards our institutions. We have other challenges. The laboratory tests are quite expensive and sometimes not very accurate. By undertaking this postgraduate program sponsored by Merck Foundation, we're able to find solutions in which most of the guidelines now are tailored towards the patients. We have also been trained academically in the endocrinology to the extent that now we focus on the basic requirements for the patient, that is either the test or the management. And then additionally, it has improved my personal skills, which now I'm able to, of course, I'm involved in the training of medical students and other doctors. So the training is now more focused in a simpler way according to the international best practice. So it's something we have really improved, and we are reaching out to stakeholders like the government and other NGOs to see how they can support people with endocrine disorders, and then how they can also be part of the National Health Insurance Scheme and other coverage. So I really thank the Merck Foundation for all the support they have given me throughout this, and the larger nation, Nigeria, that has benefited from this initiative. I thank you very much for what you have done. Thank you.
Thank you so much. Good afternoon, everyone. Thank you for having me today. And I would also like to thank the Merck Foundation for giving me the opportunity to learn about the different things that we can do to improve the healthcare right now. Non-communicable diseases are slowly becoming one of the public health concerns here in Africa and in my country particularly. And we've seen a rise in deaths that come about due to non-communicable diseases, particularly in where I practice, where I lead my team of doctors at the Medical Concierge Group, or Rocket Health. We've seen the community having individuals that are coming into the facility with symptoms of hypertension or diabetes, or just in general symptoms of non-communicable diseases, and doing preventative cardiovascular medicine. Really, what interested me about this course was I was coming from the aspect of what can we do better for our community, what can we do better for people in the community to improve accessibility to quality healthcare. Currently in Uganda, the the doctor to patient ratio is 1 to 25,000, which is quite huge. So we thought of a plan to come up with the concept of telemedicine, delivering remote care to clients, enabling us to meet a wider range. And then as I was going through the course, we were able to learn things that we can do and things that are very important, like the prevention and through patient empowerment, teaching clients how they can monitor at home, how they can be able to take their health into their hands and basically have charge of their health. So the impact that this course has had on us and my team at large were able to implement certain checks within our electronic medical record system, like screening for cardiovascular risk, the 10-year risk. It's something that we did not do in our clinic, something that we did not do in most of the places that we've worked before. So we're able to build a system that has that. So whenever we interface with clients who are at high risk, we are actually able to calculate that for them. In addition to that, we developed programs where clients get information on nutrition. Clients who have been diagnosed as diabetics, they get onto the lifestyle program, which we developed, and they are able to get information on nutrition, get information on what do's and don'ts, get information on how to take their readings at home, what it means when you get what reading, which is really empowering clients. And most of the clients that come back after getting onto these programs within our clinic, they are actually taking better health, taking better care of their health, and we've seen a significant improvement in their healthcare in general, their plan in general. Sorry about that, there was a little glitch. Then another thing that we're able to do is implement the remote lab tests and medicine delivery. So clients who are chronic, sometimes they don't have time to go to a facility to pick their medication or to get their samples removed. So we took it up a notch where we meet them where they are, take off the samples, ensure that they are doing their routine labs, getting their medication on a monthly, and also getting remote follow-ups from the doctors. I've been able to do CMEs for my colleagues here, teaching them about the assessment, but also teaching people outside the Rocket Health on how to do the early assessment and detection, because those are some of the things that are really important, and one of the things that I took a really good learning from during the course. Thank you, everyone, and have a good afternoon.
Thank you. So, so I just wanted to say that it looks like the stories are more or less the same. There's three things. There's professional development, there's our patients getting helped because of the knowledge that we've attained from the diplomas that we've gotten. And I think for most people also, it comes with, you know, maybe some promotion of some sort. Some people have started their own clinics and so forth and so on. So it's extremely impactful. And the story has been the same for me. Since I finished my diploma and then went ahead and did the MSc in diabetes, I've seen a lot of professional development in terms of being able to, you know, initiate clinics in some of the outreach centers in my hospital. My hospital, myself and Dr. Jenga, we work in the same hospital, and Dr. Jenga sits in the main hospital, in the main building. I work in the outreach centers, and where, you know, we don't need to send everyone to him because he's going to be overwhelmed. So some of those patients we're able to see in the outreach and only send the very complicated cases or the people who need inpatient care to him, yeah, and to the other colleagues at the main hospital. Obviously, the other thing has been conducting a lot of continuous medical education seminars to other healthcare cadres like nurses, clinical officers, medical officers, and even fellow physicians, family physicians in my department. And last but not least is the fact that because of the MSc in 2019, when we went to the previous Merck luminary, we were able to meet Professor Steve Davis, who's the founder of the Learner Limited, which is responsible for offering these diplomas, and he graciously was able to offer the post of a tutor at the diploma. So at the diploma. So I'm a tutor there, and all this goes to say that there's a lot of professional development that has come as a result of taking up the diploma. But I think the most important thing is that there's a lot of patients that have benefited. Sometimes, as I've heard many of the colleagues say, you know quite a lot when you're done with medical school or when you're done with your postgraduate training. But then when you do the diploma, then the knowledge gets more. There's always something new to learn, and the patients at the end of the day are the biggest winners from the scholarships by Merck. So I think that's it. That's been the same experience for me.
Good morning, I am Nicola Napoli, and I would like to thank Merck Foundation and for this amazing opportunity. And I would like to thank all of you for your attention in advance. So my talk will be focused on PCOS, on hirsutism and fertility issues, but I'm stressing the importance of bone health and the cardiovascular risk. So I can move on the slides. So if you recognize the importance of insulin resistance, well, this is very important also in terms of pathogenesis of PCOS, and this explains the high risk of cardiovascular diseases and the cardiovascular risk in general in patients with PCOS. So as you know, the insulin resistance is a very common condition now in the western and the east side of the world, with several patients affected with resistance to insulin, with the high risk of developing diabetes. As you know, all these patients have an inability to lose weight, have a constant hunger, have cravings for sugar, headaches, fatigue, and most of these patients have obesity, or at least have an increased visceral adiposity at the abdomen. And if these patients, all these patients are basically at risk of cardiomyopathy, increase of neurological changes, so mostly related to urinary frequency, constipation, have an increased intra-abdominal fat, elevated blood sugar, high blood pressure, elevated triglycerides, and inflammation, sleep apnea, and again, polycystic ovary, atherosclerosis, and risk of clots and low HDL in the serum. But what is very important, again, that is the main trigger of insulin resistance is excess weight, excessive carbohydrate intake, sedentary lifestyle, and of course all these conditions work together when there is a genetic background on the basis. But what I would like to emphasize is that all patients with insulin resistance are at high risk of developing cardiovascular diseases, because all these patients, again, are at high risk of diabetes, hypertension, dyslipidemia, and what is clear from the literature in the last 20 years is that increased abdominal fat is a main industry of inflammation, is a main industry of cytokines, and like TNF-alpha or IL-6 that have a negative impact on any tissues, starting from the vascular system to the brain, to the liver, the bones, to the muscles. So when we work with the patients with the PCOS, we don't need to think just to fertility. We need to be sure that this patient knows the risk of cardiovascular risk that she may develop in the next years, even if she's in young age. It's very important that our work in our clinic is also related not just to fertility, but mostly to prevent cardiovascular risk. So to explain to the patients how lifestyle intervention, how improving the diet, how improving their weight is important to prevent not only problems with fertility, but also to avoid any heart attack or any vascular problem or any stroke in the future. So we are endocrinologists, and we know that many hormones related to PCOS are also important for insulin resistance, are very important for cardiovascular risk, starting from estrogens that increase insulin concentration and insulin binding, progesterone that decrease glucose transport, insulin binding, and suppress hepatic neoglucogenesis. Cortisol is very important. You know, patients with high cortisol have insulin resistance, have high blood pressure, and they have lower insulin receptor substrate 1. And glucagon, that is a main insulin resistance actor. So when we observe patients with insulin resistance, again, we need to really focus on these two topics that are expressed in this slide in gray: obesity and chronic inflammation. So obesity is the trigger of hyperinsulinemia, is the trigger of insulin resistance. But please remember that the chronic inflammation is important also for hyperandrogenemia, so for increasing androgens in the serum. And even Hippocrates, many years ago, many centuries ago, was stating that basically patients women obese and mostly with hirsutism have a lower chance of developing lower chance of pregnancies, and they have many problems with their cycles, with the menstrual cycles. And again, the parameters that have been so far proposed for PCOS are different according to different societies across the years. That the most important one we use is the classification of Rotterdam, and what we observe in these patients is not anymore the condition is not anymore just the cystic pattern of the ovaries, but mostly we look for hirsutism and for hyperandrogenism symptoms, and for basically this, at least two of these factors should be considered to make a diagnosis. And of course, the main driven is the irregulatory ovulation. Now, let's try to figure out what is the pathogenesis of this condition. So now we need to go back to the theory of the double hit. Double hit means that there are at least two factors that we don't know exactly how they interact with each other. For sure, we have a genetic background. So genetic factor is a main, genetic predisposition is the main driven of the disease. And there are two important triggers here that we should consider, but we don't know what is among the two conditions, what is the what we call prime moments. So what is the first factor influencing the other one? So the first factor is insulin resistance. The other factor is a pituitary dysfunction with an increased production of LH. So it may be possible that the insulin resistance, so hyperinsulinemia, basically determines reduction at the liver of production of sex hormone binding globulin. And this increases the availability of androgens. At the meantime, when insulin goes to interact with the ovary, mostly with the theca, we have an increased production of androgen. And we have also overproduction of estrogen. Estrogen go back to the pituitary, reducing the FSH, and we have an increase of LH. LH is the main, basically, is a very important factor produced by pituitary to increase the production of androgen in the ovary. So at the end, we have a dysfunction of the pituitary with increased LH. We have insulin resistance with the hyperinsulinemia, again reducing sex hormone binding globulin, so increasing the number of hormones free from the protein, so active. And importantly, again, the insulin may interfere directly with the ovary, increasing the production of both androgen and estrogen, and estrogen may reduce the production of SH of the pituitary. So all this cycle is basically, it's a cycle that basically determines at the end all the classical symptoms of polycystic ovary, including hyperandrogenism, oligomenorrhea, or amenorrhea, and the typical pattern seen in radiology from the ovaries with the polycystic cyst. If I can go on. Okay, so here to give you a more clear idea, so insulin resistance is at the end is responsible for increasing the free testosterone, is responsible for increasing from the ovary the production of androstenedione and testosterone, and for the production at the adrenal level of DS, that is another androgen. So these again raise the androgens and cause the clinical condition of PCOS. But all risk factors included, again, are abdominal obesity, family history of diabetes, genetics, aging, drugs like steroids, and low lifestyle, so sedentary life. Now, insulin resistance is very common among women with PCOS. Is observed in the 75% of patients who are lean, 62% of overweight, and the 95% of overweight women with the PCOS who are diagnosed with using the hyperinsulinic euglycemic clamps. And the PCOS, of course, is associated with the risk factors for cardiovascular disease, and again, related to obesity, depression, and sleep apnea. Now, when we see patients with the PCOS, what we should ask is just a glucose or a oral glucose tolerance test. We don't need to measure or to test specifically insulin resistance. It's not necessary. What is very important is to have a screening of androgens and a glucose oral test to analyze the possible hyperglycemia, hyperinsulinemia, and eventually after the stress test of glucose tolerance if patients develop already diabetes. Now, what we prescribe to patients with PCOS? The first, and I repeat again, first approach is the lifestyle intervention. Mostly of these women are sedentary, not have a high intake of sugar. So we need to work a lot, and this takes patience and this takes time for the physicians to convince our patients to exercise, to have a regular physical exercise, to decrease carbohydrate intake, mostly reducing the intake of simple sugars like cookies, jam, sweet fruits, any kind of sweets. If we avoid the peak of insulin using carbohydrates, mostly again all the sweets, we have a higher chance that these patients decreasing insulin peaks have a lower androgen production. And then, of course, we use medications like metformin or the obesity drugs, and in terms of severe obesity, when necessary, we can advise patients to have bariatric surgery. And in case this approach is insufficient, of course, the endocrinologist or the gynecologist will prescribe clomiphene and metformin, or in case assisted reproduction treatment in order to achieve a pregnancy. Now, when we target insulin sensitivity, we need to strongly believe on the use of metformin. Metformin is the medication that in diabetes has been studied and used for decades, since the middle 50s. And it's a very safe medication, approved in many clinical trials to be effective and to be very well tolerated and without any specific long-term side effects or long-term consequences. So I would say that metformin is the main clinical pharmaceutical medication that we should use in patients with PCOS, together with the hormonal medication that the gynecologist and endocrinologist should prescribe together or should decide together. And another option is to use also pioglitazone, that is still a very common medication in patients with insulin resistance, but is low. The use of pioglitazone is not very common in young women, although there is a substrate, scientific substrate to start the treatment in case metformin is not effective. But we should remember also that the pioglitazone may increase body weight, and this doesn't help in the patients with the PCOS. And then there is the chiroinositol, that is another factor that has been largely used, but there is a strong lack of scientific data, scientific evidence for this agent. So metformin is an old medication, but still new fashion in patients with PCOS, considering the effect on insulin resistance. But also, we believe there is a direct ovarian action of metformin on the TECA and the granulose of the ovaries, with the lowering CYP17 gene, but also the HSD3B and the CYP11A1, that all the cytochromes enzymes that increase the production of androgens. And metformin may have also an improvement in production of ovarian antioxidants. So the final effect is an attenuation of androgen excess, restoration of ovulation, and improvement of fertility. So metformin works at the liver, works at the pancreas level, skeletal muscle, works at the adipose tissue, at the endothelium, and at the ovary level. So the final effect is an improvement in insulin resistance, glucose tolerance, ovulation, menstrual cycle regulation, and weight loss. I will go on because we are a little bit late. So there is no dose finding study. There are wide ranges in the trials for the use of metformin. I would say that between 1.5 grams and 2.5 grams is the correct dosage, although again, there is not a specific dosage recommended. And we don't know for how long metformin should be used. We believe that we should regularly check blood glucose, we should check the fertility of these patients, and it's a clinical decision, patient by patient, and according also to the opinion of the treating physician for how long using metformin. And I would like to give one more slide, if I can move on. Sorry, it's very slow here, but I'm going to move on because I have the last slide I would like to show you, and that is related to the bone health. So there are a few studies showing basically the effect of PCOS on bone health. There are really few data, but we believe that patients with PCOS having a high androgen level should not be at risk of fractures. And I would like to repeat, should not, because the evidence available is really limited. Although we proved a few years ago, publishing on JCM, that the patients with insulin resistance, at least in elderly age, have an increased risk of fractures. So we believe that patients with PCOS in young age may be more protected, maybe not a risk of fracture. They should not have bone health problems, but this may change completely when these girls becomes ladies and becomes women when are in older age, and insulin resistance, if not treated, if not improved, well, in that case, becomes a risk factor for fractures. And what we strongly recommend in these patients is the use of vitamin D. Please be generous giving vitamin D to patients with PCOS, and we usually prescribe at least 1,000 units per day in order to achieve a blood level of vitamin D of at least 30 nanograms per ml. I would like to thank all of you for your attention, and I will be available at the end of the session for any questions.
Thank you very much. I'd like to make my talk very clinical today to make it highly relevant to the audience. And what I'd like to discuss is the diagnosis and management of pituitary tumors. Thanks very much indeed to Merck Foundation for inviting me along today. It's a great pleasure to speak at this event, which I've done now for a number of years. Okay, this is the first case, and it's a 33-year-old female who presents with a 1-year history, secondary amenorrhea, some galactorrhea. There's very little else of note. And of relevance, you know, you're already beginning to formulate a diagnosis here, but you find that the estradiol is low, prolactin concentration is somewhat high at above 1,000. And with the normal LH and FSH, but inappropriately normal LH and FSH, that's indicative of hypogonadotrophic hypogonadism. If I can have I can't really control these slides here, unfortunately. So what is the next investigation you would request? Well, clearly it's pituitary imaging for this patient. And I'm going to now press the next button. It's slightly slow, so please forgive me. But as you see on this MRI scan, there is a right-sided lesion in the pituitary gland that is highly suggestive of a microadenoma. Go to the next slide. And you can see that there. Okay. This is a little slow. So the treatment of this patient with a microprolactinoma is dopamine agonist therapy. And one can consider, depending upon the approach to the management of this patient. Were this infertility, then the only drug that's licensed for fertility is bromocriptine, but other agents include cabergoline and quinagalide. Very effective treatment, as they have a prolactin inhibitory effect released by the hypothalamus. So we commenced this patient on 0.25 milligrams twice weekly, and this is derived really from our data, which was published in the New England Journal. We were the first to establish the value of cabergoline in the treatment of microprolactinomas as well as macroprolactinomas. Following treatment, 3 months, the prolactin was suppressed, the menses had returned, and the galactorrhea had resolved. Now, the important thing is here, when you have this, there really is no other indication. You don't need to repeat a scan on this patient. So we'll go to the next slide. So this, as I said, this is a microprolactinoma. The duration of treatment, 2 years, and stop and reassess. This is the important thing now. We've treated the patient, but the next stage is what we do next. Well, the evidence is that, as we published in Clinical Endocrinology, is you treat these patients for 2 years and you stop and reassess. Approximately 40% of individuals with microprolactinomas will achieve long-term remission, i.e. cure associated with this strategy. So stop and reassess. So this patient, slightly delayed in terms of their follow-up, came after 3 years. We stopped treatment. There was no recurrence of her symptoms, and she had normal prolactinemia. So good success story, indicative of what you should be doing with these patients. The next slide. There's a slight delay, unfortunately, in terms of the control here. So next case is a 40-year-old male that presented to the endocrine clinic. The patient presented with erectile dysfunction, a common problem that I see in my men's health clinic. Fatigue, reduced shaving frequency. And the GP, he presented to primary care, and the GP found that the testosterone concentration was low at 3.2. On examination, he was obese, grade 1 obesity with a BMI of 31, and hypogonadal appearance. Importantly, and this is where people don't check, is looking for galactorrhea. So he had some galactorrhea to expression that he'd not volunteered. The testosterone was 2.8, LH and FSH normal, as we said, but that is inappropriately normal in this context, indicating hypogonadotrophic hypogonadism, indicating a pituitary cause. And of course, with the galactorrhea as well, prolactin of 88,000 was found. The diagnosis, therefore, is likely to be that of a pituitary macroprolactinoma. And we go on to the next slide now in a moment. So macroprolactinoma, as you see in the right panel, there's a large mass that's now occupying the pituitary fossa, with extension downwards rather than upwards. And you'll see the bar at the top of that pituitary is in fact the optic chiasm. And there's some distance between, well, a modest amount of distance between the macroprolactinoma and the optic chiasm. Further investigations, therefore, along the lines of potential pituitary involvement include the short-actin test. And in this case, the short-actin test demonstrated an adequate cortisol response with a cortisol of 502. Treatment for this patient, again, being dopamine agonist therapy. Patient treated with cabergoline 0.25 milligrams twice weekly. This was increased then because of the inadequate suppression of cortisol. The inadequate suppression of prolactin. This was increased to 0.5 milligrams twice weekly. And importantly, the key message here is that even with large prolactinomas, and even those that compress the optic chiasm, in fact, there can be really swift resolution with dopamine agonist therapy, such that surgery is really required in these patients. So there you can see, as indicated by the arrow, this large macroprolactinoma as I've described. So dose was increased to 0.5 milligrams twice weekly, prolactin 330. The testosterone then began to rise. So we're looking at good suppression. And he continues on 0.5 milligrams twice weekly with testosterone supplementation because that's still quite inadequate. Importantly, 16% of macroprolactinomas will go into long-term remission. Even these sizable ones will go into long-term remission following adequate 2 years dopamine agonist therapy. So it reflects back on that former case that I showed, case 1, where there was an adequate suppression and potential offering of long-term cure without surgical intervention. And that's the key take-home message here. And you'll see in the right panel, there's considerable reduction in the size of this macroprolactinoma with further imaging. So the next case, and in our whistle-stop tour, is this 56-year-old man who presented with a 6 months history of reduced libido and erectile dysfunction. The GP noted testosterone that was low as 3.5. He had type 2 diabetes associated with weight gain, treated with metformin, dapagliflozin, and sildenafil was unsuccessful. So he got referred to secondary care where he's got obesity. Now, importantly here, visual fields to confrontation were actually normal as reported by my registrar. Testosterone was 2.6, prolactin was modestly elevated at 800 with, again, inappropriately normal LH and FSH indicating hypogonadotrophic hypogonadism. The cortisol, the 9am cortisol, slightly low. That merits further investigation when it's 201. We've demonstrated that anything above 300 nanomoles per liter at a 9am level indicates an adequate response to short-actin. So this is a little bit low, suggestive maybe of further investigation. And the IGF-1 was on the lowest side at only 14.6. So going on to the next slide, the differential diagnosis here could be weight-related metabolic hypogonadotrophic hypogonadism, i.e. the syndrome of low testosterone with normal LH and FSH, hypogonadotrophic hypogonadism associated with obesity and type 2 diabetes. Or we're looking at but the odd thing here is that slight elevation of prolactin. And that makes me think that there's a problem with the pituitary. So could this be, in fact, hypopituitarism? Further investigations have demonstrated an inadequate cortisol response to short-actin at 376. And so we started him on hydrocortisone. But clearly what we needed was imaging of the pituitary. And here we see a very large, bright signal of the pituitary. And just above it, there should be the optic chiasm. Well, clearly you can't make that out. So there's compression of the optic chiasm. And therefore, one would think that that's going to be associated with visual field impairment. And indeed, whilst confrontation was normal, what we see is this classical bitemporal quadrantanopia. So as demonstrated with the black squares, this patient couldn't see the superior quadrants. There was visual field defect, which correlates really with what you see on the MRI scan. And so what we're dealing with here is a likely non-functional pituitary tumor with the raised prolactin associated with stalk compression. No need to treat with cabergoline in this case because it's not going to be effective. The key treatment here is pituitary surgery. And I'd like to show you a video which kindly has been passed over to me by my surgical colleague, Miss Caroline Hayhurst, a fantastic neurosurgeon that does all our pituitary work in Cardiff. So if we can have the video, please, to show everyone. So there's the MRI, as I've already showed you. And next, this is where the surgeon has exposed the pituitary itself. And on either side, you can see the pulsation of the cavernous carotids. She's now cutting through it. This now exposes the tumor, which she's using the correct to open up. It's a thick, cheesy material and is already beginning to come down. And it's a thick, cheesy material which is coming down and can be curetted or scooped out. And the more that's scooped out, the more that comes down really from the superior region. This really indicates the total clearance of the pituitary. And you've just got the dura now that has fallen down. We can't see the optic chiasm on that. So let's have a look and see what the consequences of that surgery was like. You recall the original MRI scan where there was this really large tumor that was pressing on the optic chiasm. This is the post-operative scan, which we do about 6 weeks to a month or so following a successful pituitary surgery. The patient developed transient DI. There was no requirement for DDAVP, however, and that swiftly resolved. Visual fields then repeated were full to confrontation, indicating that this pressure that had been applied by a large pituitary tumor, which is successfully removed, has now resolved the visual field defect. Patient was then commenced on testosterone 1 gram every 8 weeks as adequate testosterone replacement, hydrocortisone 10 milligram BD, together with thyroxine 100 micrograms daily. The histology, which is important because Ki-67 index is important with regard to the potential proliferative rate of these tumors. This was low, suggesting in the context of what we're dealing with a low-grade non-functioning pituitary tumor, that the chances of recurrent are low, particularly when we've had pretty good success in removing it. And this is total resection. And what we need to do, however, is not be blasé about this. We still need to follow this patient up with annual, then going to every 2 years, then potentially going to 3 years for at least 10 years. 1 year of symptoms, tidiness persists, IGF-1 was 9.8. We may wish to consider growth hormone therapy in this patient. So let's go on to the next case. As you see, a 35-year-old guy that's presented with headaches, erectile dysfunction, sweats, and you can clearly see that he's acromegalic with a large hand. Really nice illustration of an acromegalic patient. The next slide reveals this right-sided pituitary adenoma with a modestly elevated prolactin, because you often have the co-secretion of growth hormone with prolactin as well. You see the right-sided macroadenoma. The next is surgery, other options, somatostatic analogs, but really the primary treatment for this patient is surgery. Ms. Hayhurst has cleared the pituitary, as you see on the right-sided MRI panel. The IGF-1, importantly, has fallen to 21. And in conjunction with the oral glucose tolerance test, indicating a nadir growth hormone of 0.5, this would be regarded as surgical cure, but we still undertake annual assessment with IGF-1 concentration measurement. The next slide is a really interesting, my last patient, because I want to present the entire spectrum of pituitary disease. This is a patient with Cushing's disease, as you see there, raised blood pressure, diabetes, relatively long history, and the diagnosis, as anybody can see, and it's really rewarding to make this diagnosis, is Cushing's disease. But as is often the case, the MRI, the results as shown on the right panel are suggestive, indicative, diagnostic of Cushing's with an overnight dexamethasone suppression test and other screening tests like urine-free cortisol indicating hypercortisolism, and with the ACTH indicating that it's central, most likely pituitary. Now you can see that little blue arrow points to something that may be an adenoma, but we're not quite sure. So what we need really is inferior petrosal sinus sampling, where we sample ACTH and can determine that it is from the pituitary gland. And the inferior petrosal sinus sampling, it needs to be done in a tertiary center, and it needs to be done by a very skilled radiologist. But this has shown that the peripheral ACTH concentrations are much lower in comparison to the samples taken from the drainage of the pituitary, indicating that this is central and that the origin of the ACTH is from the pituitary gland. So this is Cushing's disease. Operatively, there was central left-sided pituitary lesion indicated. That was, and the hemihypophysectomy was undertaken by the neurosurgeon, and the ACTH staining indicated this was an ACTH secreting pituitary tumor. And I want to show you the next slide because that really is important, more so than most of the other investigation. You see the resolution of symptoms and the resolution of Cushing's features over the period of a year. And that's typically what we see. So in summary, I always say to people, a primary care practice is about 10,000 population in it. So you're likely to have 8 patients with pituitary disease, and that's important to know. So it's a relatively, once it's considered rare, it's actually quite a common disorder. Commonest is microprolactinomas and prolactinomas, and they can be invariably treated with dopamine agonist therapy, do not require surgery. The next most common is non-functioning pituitary tumors, and it's important really when you're dealing with these to consider surgery or not. And if there's site involvement, then surgery is absolutely indicated, but you need a really good surgeon. And then we're dealing with functional tumors like acromegaly and Cushing's. These are rather rare, but it's so enjoyable to make that diagnosis and refer on potentially. Consider long-term follow-up of these patients and adequate hormonal replacement. And as I said earlier, the dedicated pituitary surgeons are essential for good outcomes. Thank you very much indeed.
Good morning to you from the United Kingdom, where I am, and I'm pleased to join this august forum again to talk to you about modern trends in the management of type 1 diabetes. And it is fair to say that type 1 diabetes, although the type of diabetes that is minimal in terms of risk factor, in terms of incidence and prevalence, is by no means a very, very important to us as healthcare professionals with regards to addressing the problems that our patients tend to come with. If I'm just going to share my slides now. So in relation to this, I'm going to talk about the epidemiology of type 1 diabetes. And in terms of the epidemiology, we will be talking about basically what is happening in terms of incidence, in terms of prevalence, and then also more importantly as well, in terms of what is happening with new approaches to tight control. We'll talk about traditional therapies with regards to managing type 1 diabetes, and also we will talk about newer insulins and then also new therapies. So with regards to epidemiology, this is very interesting piece of work that comes looking at the epidemiology of type 1 diabetes across a variety of countries. And we are looking at, if you look at the top blue bars there, then we can see that there's progression of incidence. So the incidence of type 1 diabetes has increased over the years. So on the very top, we have Scandinavia. So Scandinavia represented by Finland, and we can see that the incidence of diabetes, type 1 diabetes in Scandinavia has almost trebled in the last. Also, quite interestingly as well, the incidence in Scandinavia is much higher than a country like, for example, the United States, which are in these purple bars over here. Now, that is quite surprising because normally one might think that obviously with genotypes being similar, then one would expect that these the incidence would be quite similar across because it's more driven by genotype. But this particular trend gives clear indication to the premise that environmental factors are particularly key in the diagnosis or in the etiology of type 1 diabetes. So that is very important for us indeed. The important thing that we've had recently really with type 1 diabetes is the identification now, the ability to determine very almost accurately now the different antibodies within the islet cell. So now we have technologies that enable us to identify, more importantly, fragments such as glutamic acid decarboxylase, insulin antigen 2, and then also zinc transporter 8 antibodies. Now, what's the benefit of this? The benefit for me is that it enables us then for us to be able to not only clearly determine who has type 1 diabetes and manage them appropriately, but also more importantly as well, to be able to conduct very, very good research with regards to identifying the right cohorts. The holy grail being that if you're able to identify people with antibodies before they develop disease, then you're going to be able to mitigate against the risk of or the prevent complications of diabetes in the long run. So this is quite interesting, and this is really the central plank of what research is going on. And this cartoon here just indicates that even before people become, from utero, there's the risk of developing diabetes, and there's a number of modifiable environmental factors and also genetic factors that are in play with regards to who develops diabetes or not. So right from the word go, I mean, from about 6 months in utero, then there's a certain seroconversion for those who are going to develop type 1 diabetes. So you get antibodies against, initially one antibody of diabetes is identified. Now, over the time, if you have one antibody, then the risk of going on to develop full type 1 diabetes is reduced. It takes a bit longer. However, people with 2 antibodies, the risk goes up to about 84%. So you can see that actually any form of research or any form of intervention that enables society then to reduce that risk or to prevent antibody formation is good. This slide here, many will recognize, and it reminds us about the DCCT trial, and following that, the EDIC follow-up trial from the DCCT. So DCCT 1983 multi-center trial first showed us tight control, so having multiple dose insulin therapy compared to conventional 2 injections a day, and then following them from 1983 into the early 90s and reporting. First most important trial, randomized control trial, that demonstrated clearly that tight control reduced the risk of complications, in particular microvascular complications. And this was quite exciting with regards to what it identified for us. It showed us that something like retinopathy was reduced by almost 47%, and then also nephropathy by 54%. So quite a very exciting study. And then also crucially after that, in the follow-up period, the EDIC shows that although the glycemic control markers come together, they certainly, the control group, the intensive therapy group continue to derive benefits from this. Slide to show you, we all have this, the traditional multiple dose insulin therapy, putting there to remind us is that actually this is how most patients with type 1 diabetes, particularly across the world, would be in other parts of the world be treated. 3 or 4 injections a day. Having said that, there's also a place, especially in resource challenged environments, to probably use fewer doses of insulin. Also importantly as well, it may be the case particularly where people need carers. So intensive diabetes control, unfortunately, has a problem. And we all know this. We know that as diabetes control gets tight, so you're improving the HbA1c, but it's against the downside of increasing the risk of hypoglycemia. So to date had been a very difficult challenge for diabetologists and people interested in managing diabetes, and how best they would be able to help their patients with regards to achieving good control, but then reducing the risk of hypoglycemia. So this slide here shows the study, a program that we have in the United Kingdom, and I suppose maybe elsewhere. Germany introduced this before, but it is essentially a program where a strategy where patients vary their insulin requirements based on the carbohydrate content of their meals. And the advantage of this is that it gives flexibility. So there's flexibility with regards to insulin regimens. There's flexibility in regards to lifestyle. There's flexibility also with regards to in relation to occupation, so that those doing shift work, for example, are able to vary their insulin doses. And the way this is done very much centers around being able to calculate the carbohydrate content of the meals, and then using that then to determine the insulin doses. There are different strategies, not only this, but other strategies that are in operation worldwide. In terms of that, I mean, I think the benefit of it is very much giving the patient control and enabling them having that well-being, and the fact that they are able to understand what is happening really to their glucose control. The downside of it, we find, is that it is rather complicated for those who are not very adept with mathematical calculations. And perhaps going forward, an opportunity is available for these to be provided in pictorial form. But certainly, there is a role for achieving this with regards to varying the insulin content of the meals based on the carbohydrate content. And the reason why this is important is that we see how it plays particularly into those who have are being managed with insulin pump therapy. So just to go on from there, we obviously we've had traditional human insulins for a while. I put this slide in very much to talk about where we are right now with regards to faster acting, short acting insulin. So we have newer insulins now, which make the life of the patient a little bit easier. Now, although in the main, if you look at this study that comes from Diabetes Care 2017, it doesn't really show us a significant improvement in HbA1c between faster aspart on the top versus insulin aspart below. But the reason for that, but the important thing is that although there is no difference or non-inferiority, patients who have faster acting insulin are able to administer their insulin doses up to 20 minutes after they've had a meal, and it has the same effect as administering the insulin before meals, or traditionally as we know it. So newer insulins now available, and this is just one example of them, which obviously enable patients to do that. Of course, downside of it is, again, it comes at a cost, but I suppose over time, one will find that as these become more commonplace, then the costs will go down and they become readily available in all across the world. And again, similar, I show you here again, two longer acting insulin. So we've got insulin degludec and then also insulin glargine 300, longer acting insulin. And the advantage of that, as we see in local practice, is that it enables a little bit more flexibility. So those patients who are not necessarily, who find it difficult to administer injections, or who are likely to miss their injections, or they cannot time their insulin, the long-acting insulin injection, they have about 2 or 3 extra hours in which to do that. The other huge benefit is the fact that these reduce nocturnal hypoglycemia. Again, the application is very much around knowing how to basically apply the doses and also managing it with regards to the individual patient situation. The downside, again, comes very much down to cost. And I think that, again, as I said, we should see costs coming down over time. So we've talked about insulins, and there's no doubt that we have newer acting insulins, both long-acting and short-acting, available on the market. But we have other agents available to us. And this one I showed because obviously, I think many now use that, but it's important to recognize the position of metformin, because metformin, no doubt that many of our patients that we look after have marked insulin resistance, have problems, they are challenged with weight, and with type 1 diabetes, a combination of metformin with insulin clearly improves glycemic control. And in this series of studies that are shown here, so those without treatments that included metformin and insulin to the left, and then treatments without insulin to the right. And we can see that metformin actually provides better overall glycemic control when added to insulin. Other therapies, and I put this in because although we, particularly in the United Kingdom, don't use this product, I know it's quite, probably better recognized in the United States and in other countries. So pramlintide, in combination with insulin, it's an amylin receptor agonist. Amylin from the pancreas, shed off from basically pancreatic cells, endocrine cell secretion, and basically in combination with insulin, then it does very similar to what metformin does, again, enabling patients to have better glycemic control. I'm surprised that it hasn't really taken off. I think basically because perhaps the gains from that are probably modest. Now, I haven't shown that on this slide, but really for us, the big player now is very much using GLP-1 agonists in combination with insulin, and particularly the long-acting GLP-1 agonists in combination with insulin with type 1 diabetes. And I think that there's no doubt that that has been quite exemplary. So basically looking at, for example, agents such as semaglutide once weekly and liraglutide, and the newer ones that are going to come on the market. So GLP-1 agonists. And I think it's very much around the issue about the fact that insulin resistance, so patients have with type 1 diabetes also have a degree of insulin resistance, but we see marked improvement in patients with overall control, especially where BMI is raised when we combine insulin with GLP-1 agonists, especially in those whose BMI is, like I said, BMI is raised. And the important thing there is that apart from improving this, there's a significant improvement in patient well-being. So that, I suppose, is going to be one of the important areas that will certainly be developed. I won't be surprised many of you use that already. So I'll turn my attention now to glucose monitoring. And again, right on the bottom there, we have urine testing developed by Ames in roughly about 1841. Started off by looking at acid hydrolysis of sugar in the urine, and then testing for that with the dextrose test, going back for over many decades or centuries ago, but now very much, particularly in areas such as where I work now, not very used at all. But still, perhaps in places where there is absolutely nothing, may still be of benefit. And then later on, where we had blood glucose testing coming into market roughly in about 1965. So over this period, we've seen blood glucose testing machines develop significantly, become more accurate. And then also the exciting thing about glucose meters recently is the fact that they have been able to be linked up with very good software, which means that patients are able to receive their blood glucose profiles. And with that, there is significant improvement in glycemic control. Patients seeing their blood glucose profiles, many of them tend to then become well informed, and there's no doubt, as we'll see, especially when we come to other newer forms of glucose monitoring, it makes a huge difference. So is there a role for blood glucose testing going forward? Who knows? I mean, I think that the downside of it is finger pricking. The downside of it is cost. I suppose that with newer options now becoming available, then it's questionable, or it is going to be interesting to see how blood glucose monitoring is going to evolve over time. So I'm conscious of time, so I'm going to move on now. And this is really just to show you this interesting slide about flash blood glucose monitoring. Also, these are intermittently scanned glucose monitors, and there's a sensor that is placed on the arm, and the patient carries a monitor, and they are able to scan their blood glucose readings at 5-minute intervals, or as many times as they want to. They can do that up to about 8 times a day. So that is where it started initially from, and we've had newer versions of these devices come into play. What are the advantages of that? One of the important advantages that, thank goodness, finger pricking is gone for these patients. But also, importantly as well, as we'll see in newer versions, patients now become informed by the profiles, and they can discuss that with their healthcare professionals. But also, there are inherent alarm systems as well that warn patients about impending hypoglycemia or if high blood glucose readings. I put this one into basically to just herald insulin pump therapy that we'll be talking about. So insulin pump therapy now commonplace, and we move really between pumps that were initially traditional threaded pumps that were basically delivered insulin in small drops or small aliquots, and also where it took the place of insulin injections. They've done extremely well to the point where now these pumps are connected to glucose monitoring systems or sensors, so the patient wears both of them. And we are now moving into a situation from where they are beginning to regulate not only the basal insulin, but also importantly as well, in this particular study that we are looking at, they do everything, including the meal insulins as well. These open source systems are systems that patients themselves have picked up from the internet, or they are not regulated. So these are not unregulated systems. And even with those, the control was much better than the control group of those who were just on regulated pumps. Continuous blood glucose monitoring is also important as well, and has been revolutionized the care of managing patients with type 1 diabetes, particularly those on pump therapy. And the benefit of these is very much around the patients do not have to scan. So with these, the blood glucose monitor readings are collected every 5 minutes, and then they are available to be profiled on a software that is available through manufacturers. So there's different types now. I've shown you this again: intermittently scanned and continuous blood glucose monitors. These are quite expensive. That's also the downside of that. But they both have the alarm systems that are available and quite easy to use, particularly both devices now. But I think we are now getting into a place where they're intermittently scanned. So now with intermittently scanned, we have those who are the patients as scans now that would continue to record blood glucose reading regardless. I'm conscious of time, so I'm going to skip over this slide. We've spoken about that already. And then we talked about this. So this is really, with regards to diabetic ketoacidosis now, fixed rate insulin administration as against the sliding scale or basal or variable rate insulin administration is really now available. And then our next slide really is around islet cell transplants. Islet cell transplants really really becoming the next port of call, because the key point really is trying to stop insulin injections if possible. So in terms of secondary prevention, then in patients who have severe hypoglycemia or hypoglycemia unawareness who cannot be managed elsewhere, then this is an option for them. The cons, or what it goes against, the fact that then of course they are bound to immunosuppression for the rest of their life. And very similar again for kidney pancreas transplants as well, which is an option, but again, very much around the fact that it is still very much in its experimental phases. This is what is quite exciting, preventing type 1 diabetes. So preventing type 1 diabetes, if you can stop these patients with antibodies from going on to develop type 1 diabetes, then that is quite exemplary. And this is one study here that uses a monoclonal antibody that blocks the T lymphocytes and the effect on and their effect on beta cells. And here, this particular agent has been shown to delay the onset of type 1 diabetes for up to 48 months. Thank you very much.
Thank you very much. It's a real pleasure and privilege to be able to speak to you all. Sorry it's online rather than in person. So I'm going to be talking about thyrotoxicosis in pregnancy, and there'll be a couple of questions for you all as we work our way through, just to keep you on your toes. So we know that thyroid hormone is essential for maintaining a pregnancy and optimal fetal development, and also fetal loss remains unacceptably high, particularly in the UK. About 1 to 2% of pregnancies end between 12 and 24 weeks gestation. So these are sort of late miscarriages, and some of these may be linked to poor thyroid status. All endocrine research societies recommend treating overt thyroid disease in pregnancy, and the counterbalance to thyrotoxicosis, about 1% of pregnant women are on levothyroxine. Little plea, you can't have thyroid without iodine. And this is a map showing in blue, particularly those countries which have got insufficient iodine during pregnancy. The good thing is Africa is doing extremely well, and that's basically because you've done very well at mandatory salt iodization as well. So you do much better than your European counterparts in getting a good iodine status, which is good for optimal fetal development. So just to a bit of a reminder, perhaps, there's quite a few complex things that happen during pregnancy and how it influences your thyroid function. So the pregnancy hormone HCG has a stimulatory effect on the thyroid. It's less apparent in women who've got thyroid antibody positivity, but as a result of this kick in HCG, you may find some women will develop a slight abnormality of thyroid function levels, and that's called gestational thyrotoxicosis. That's very benign and doesn't usually need any treatment at all. And the trick is to be able to diagnose that, and therefore you're not missing Graves' disease, which will be your other main diagnosis. To give you an idea about the prevalence of thyroid dysfunction, so just looking at hyperthyroidism, in Graves' disease or transient thyrotoxicosis or a toxic nodule, that's about 0.2% of all pregnancies. Slightly more common is Graves' disease in remission. So women who've had antithyroid drugs and have either had a relapse or they've still got pregnant while they're on Graves'. But more common, 3% of all pregnancies, is gestational transient thyrotoxicosis. We may see a little bit of subclinical hyperthyroidism as well. In the UK, we tend to use carbimazole, but I think most of the world uses methimazole. So I'll tend to use carbimazole when I'm talking because I'll forget. But carbimazole is basically the same as methimazole. So a case for yourselves, 34-year-old lady who's been trying to get pregnant for 1 year. She presents with symptoms of hyperthyroidism, and she's got a small diffuse goiter, but no evidence of any thyroid eye disease. These are her bloods. So she's got a TSH of less than 0.02, which is low. She's got a T4 that's about double the upper limit of normal, and a T3 that's about 3 times the upper limit of normal as well. She's thyroid receptor antibody positive as well. So in terms of this, the options people might want to consider, I've got an argument of which I think is the most correct answer here, but these are things some people may consider in their treatment. So I was wondering what, if anyone had any thoughts about what they would do? Okay, well, we'll go through and have a look at a little bit of the evidence. So the key thing is think about what crosses the placenta. So maternal TSH does not cross the placenta. T4 and levothyroxine do cross the placenta very well. They'll stimulate fetal development. But remember, you can have too much or too little of a good thing. So too high is bad and too low is bad as well. It's important to remember that thyroid receptor antibodies also cross the placenta, and they can cause fetal and neonatal thyrotoxicosis. Iodine is necessary for fetal thyroid hormone production. Too low production leads to too low iodine leads to sort of low thyroid hormone levels, and high can cause too high thyroid levels. Radioactive iodine is not recommended or is contraindicated in pregnancy because it can destroy the fetal thyroid gland and it's a high radiation exposure. Both PTU and methimazole and carbimazole do cross the placenta and will have an effect on fetal thyroid function. And propanol used to reduce some of the symptoms of thyrotoxicosis, they also pass the placental barrier, but that is thought to have a relatively low risk of adverse fetal outcomes, though we still try and avoid it unless absolutely necessary. So one thing worth bearing in mind that even minor changes in thyroid status might have quite a significant impact for the individual. So this is really nice data from the Dutch group, and this shows that child IQ at age 6 to 8 is dependent on maternal thyroid hormone levels during pregnancy. So you've got too low thyroid hormone levels, they're not quite as bright, but actually too high, it's the same thing. So we've got a U-shaped curve, and you've got optimal thyroid hormone levels kind of in the middle of the reference range. We steer even within the normal population when we've excluded overt disease. So getting your thyroid hormone levels right and not too high and not too low will improve offspring IQ. And one of the things we do see is fetal thyroid hormone levels being a problem. So one of the things, if you're on anti-thyroid drugs, if you've got women who's got a T4 level towards the end of pregnancy that's less than normal, so after 24 weeks, they will all, the fetuses and neonates will then have low thyroid hormone level at birth. If it's in the lower 2/3 of the normal range, almost a third will have a low thyroid hormone level. Given how critical thyroid hormone level is for early development, that's something to try and avoid. So what we're aiming for really is to get maternal free T4, particularly towards the end of pregnancy, in the upper third of the normal range. So in terms of picking your drug, PTU and carbimazole, methimazole cross placenta with equal efficiency. Graves' disease remission rates are not better with block and replace in the leading and during pregnancy, and the placenta is more permeable to anti-thyroid drugs than levothyroxine. So for that reason, we don't recommend block and replace in pregnancy. And the fetal thyroid is very sensitive to anti-thyroid drugs. So whatever you're giving the mother, the fetus is probably having a slightly higher impact. It's worth bearing in mind that Graves' disease can often settle down in the last 20 weeks of pregnancy, so that might be a chance to be able to stop the anti-thyroid drugs altogether. So the key issue when deciding about which anti-thyroid drug to use during pregnancy is the issues of side effects. So propylthiouracil, the worry here is liver damage to the mum. The large study based on transplant, people requiring liver transplant, showed that actually 661 subjects required a liver transplant for acute drug-induced liver failure. In America, it's the fourth leading cause of requiring a liver transplant, paracetamol being the first. It's idiosyncratic. It's very difficult to predict. We do see a very high female preponderance for PTU-induced liver disease, but we think that's because it's a reflection of the high underlying disease prevalence of thyroid disease in women. But you might put a risk of some hepatotoxicity, not the level requiring a transplant, but some upset to the liver in between about 1 in 1,000 and 1 in 10,000, where you'd have to stop the drug. In terms of the outcomes in pregnancy, if it does go wrong with PTU and you get a liver upset, it is not good outcomes. So the first one reported was Canada. The mum did okay. The propylthiouracil was discontinued, treated with methimazole and propranolol, and things seemed to go okay. No, that was 20 weeks exposure. In the USA, there was another case where actually, unfortunately, the PTU wasn't stopped immediately. After the woman became jaundiced, they hadn't realised, I don't think they twigged it was a propylthiouracil. And as a result of that, I'm afraid there was a fetal death and the mum required a liver transplant. In Greece was fairly uneventful, but they hadn't been on PTU for very long, so we're not sure whether or not that was actually due to the propylthiouracil. In Chile, we've got both the mum and the fetus dying as well. And again, the one from Kenya in the USA, that required maternal liver transplant and some developmental delay. My own case from the UK, we got away with it. We were quite lucky. She presented the first day she was jaundiced, so we were able to take her off the PTU and put her onto carbimazole, and mum and baby did very well. In terms of the other risks, so there's liver toxicity with PTU, we worry about teratogenicity. And what we know is that if you're on antithyroid drugs, your risk of teratogenicity goes up, but equally, if you're hyperthyroid, there's also teratogenic in its own right. So you're damned if you do and damned if you don't. But basically, our approach is to use the lowest amount of antithyroid drugs possible. It does seem to be you get greater teratogenic effects with carbimazole and methimazole than with PTU. So a very nice study from Denmark showing a register that, in fact, actually, in women who are exposed to methimazole or carbimazole, they had a 66% increase in the risk of having teratogenic effects, which I'll go into more detail. And propylthiouracil is definitely there, but it's less. Interestingly, in women who switch, it's actually higher. Although this is a smaller amount of individuals. So if people switch, you seem to get the worst of both worlds. So there's a growing trend to avoid switching antithyroid drugs in pregnancy. In terms of the effects you get with carbimazole and methimazole, you can get scalp defects such as aplasia cutis, and you can also get problems with choanal atresia and omphalocele as well. As you can see, it's largely musculoskeletal and also digestive, but you can also get it affecting other organ systems, particularly the urinary tract as well. PTU, it does seem to be a little bit milder. You can get some preauricular sinus and cyst changes in the ears and can get some urinary tract effects as well, but it's generally felt to be a much more milder effect. Agranulocytosis is a risk factor, as we know, with antithyroid drugs. It's no particularly more or less likely to happen in pregnancy. We see it more commonly in pregnancy in women who are on PTU, because in the UK and other centres we use PTU throughout pregnancy. One thing to bear in mind is the effects of iodine 131 on TRAb concentration. So what we find is, because the thyroid has been destroyed by radioactive iodine, but it still is present, your antibody levels go up. So women who have had previous radioactive iodine, we advise them they shouldn't get pregnant for at least 6 months. My policy is they shouldn't get pregnant for at least a year afterwards, because the TRAb levels can be still quite high at that point. It takes a little bit longer to get them down, and I want to reduce the risk of fetal and neonatal thyrotoxicosis. One advantage of thyroid surgery is it brings the TRAb levels down, which is pretty effective. And that's why in the UK we tend to use surgery quite often in our patients with particularly bad thyroid eye disease, or those also planning a later pregnancy as well. In terms of the medication, their antithyroid drugs will tend to get control of thyroid status, and also, like surgery, the antibody levels do tend to drift down over time. So the American Thyroid Association guidelines are extremely good. The key thing is women who of gestational, women of childbearing age, they should be advised to the fact that there is an association risk of birth defects with antithyroid drugs, so they need preconception counselling and advising not to get pregnant, ideally, while they're on these medications. And also, if you're wanting to be euthyroid before pregnancy, you've got different options, so radioactive iodine, surgical thyroidectomy, or antithyroid drug therapy, and hope that it's all settled down when they get pregnant again. So it's just important to have that conversation with them. So in terms of one of the arguments, pre-pregnancy, if a woman is saying they want to get pregnant, I'll tend to keep them on PTU. The first trimester, I will keep them on the same drug, PTU starting on carbimazole. And we used to say in the second and third trimester, put them on carbimazole, but quite a few of us are now continuing propylthiouracil throughout pregnancy because of the effects of the switching. In terms of our approach now with antithyroid drugs, I'd like to keep the dose as low as possible, and often I can stop medication from the middle of the second trimester, and I try and maintain the thyroid hormone levels, the free T4, in the upper half of the normal range, and we like to have our TFTs checked every 2 to 6 weeks. So in case one for that woman who presented in pregnancy, I would recommend propylthiouracil monotherapy and using it as titration because she's planning to get pregnant. Those are 2 other options, treat with radioactive iodine or total thyroidectomy, but that will depend on patient preference. I think most people would go for propylthiouracil monotherapy, and that's what I would recommend. So this is another case you may see. This is a 32-year-old lady. She's 10 weeks pregnant and she's got twins. She was admitted with severe vomiting and dehydration, and she's got tachycardia, tremor, and recent weight loss. Thyroid function shows a low TSH and a T4 that's just over double the upper limit of normal on your lab. So in terms of what you would advise, your options are to start carbimazole, start PTU, start beta blockers, or rehydrate and give anti-sickness. So have a think what you would choose. I'll take you through now what I would do. So the key thing is causes of thyrotoxicosis during pregnancy. If you've got previous hypothyroidism in pregnancy, that's 0.5 to 1.3% of women who are pregnant who've got thyrotoxicosis, may well have pre-existing Graves' disease that can relapse. It's quite rare to get new diagnosis of Graves' disease in pregnancy, and it's fairly rare as well to have a solitary toxic nodule. But gestational thyrotoxicosis can be as high as 3%, so it's much more likely to be any of those things, particularly in women with no history of thyroid disease. So what the key thing is ask the woman in the history, ever had a thyroid problem, any family history of a thyroid problem. If that's not the case, no family history, no, she's never had it before, it makes it much less likely it's going to be Graves. So you might be able to get away without antithyroid drugs, because the most likely diagnosis will be gestational transient thyrotoxicosis. That's self-limiting with normalization of thyroid function. There's no clear adverse outcomes. There are a few suggestions it may affect birth weight, but it's not worth the side effects of antithyroid drugs. And as I say, very strongly associated with vomiting in pregnancy. You won't find any history of any thyroid disease usually, and they'll have no goiter or ISIDES either. And there's normally a normal free T3 in 85% of pregnant in these women. Thyroid antibodies are also negative as well. So just moving on, Graves' disease, you will find the symptoms may predate the pregnancy, there's a positive family history, and you use antibodies as well. So outcomes of hypothyroidism in pregnancy, pointing out that a particular risk is preeclampsia, and there's an argument potentially that we should be giving these women aspirin to reduce the risk of preeclampsia. And there's also a risk of preterm birth and maternal ICU admission as well. If you don't treat, and some women don't like to take drugs, so won't take it, pregnancy loss is about 45% without treatment. So although you've got the worries of antithyroid drugs, it is much, much better to take it. And there's even reports of maternal death during pregnancy, so not just the fetal loss as well. And just showing that even if you are uncontrolled, if you're uncontrolled, things aren't really good at all. Very high risk of prematurity and preeclampsia. If you're controlled only by delivery, you get some improvement, but what you really want is good control from the very beginning, just to improve your obstetric outcomes. So management of Graves' disease in pregnancy, regardless of control or previous curative treatment, remember that there may be the issue that the antibodies are still present and will cross the placentas, causing fetal hyperthyroidism. Hypothyroidism can also occur for the fetus if you're using antithyroid drugs. So remember, use the lowest dose possible. Signs of a thyrotoxicosis for the fetus are fetal tachycardia, growth restriction, death, and you can even now see goiters with the high resolution ultrasound scanning. So I'll skip ahead on the next couple of slides because time is over. So the answer to that case is I'll give supportive treatment with rehydration antiemetics in that lady that I've just discussed, the one with twins and the vomiting. There's no great compunction to give her antithyroid drugs with no thyroid history. I'll skip over this case as it's a little bit, as time is a bit limited. It's worth bearing in mind that a lot of women will have a relapse of thyrotoxicosis after pregnancy. So in the 1 year after pregnancy, it's quite a high chance they'll have a relapse of their Graves' disease, even if they were fine throughout pregnancy. It seems to be the changes in autoimmune profile. If they are thyrotoxic and they're breastfeeding, principles are treating the same as in non-lactating women. I don't mind switching to carbimazole at that point, and you can use quite high doses, up to 30 milligrams of carbimazole, and carbimazole up to 450 milligrams a day. They're very little excreted in breast milk, so you don't need to check thyroid function in the offspring, and you just need to keep an eye on their growth. So just to summarize, hypothyroidism in pregnancy, there's a lot of physiological changes in thyroid function which you need to consider when you're interpreting thyroid function. Antithyroid drugs may have significant adverse effects, and the lowest possible dose should be used. The differential diagnosis between transient gestational thyrotoxicosis and Graves should be established, and the best help you've got is there a family history or a previous history? And do remember that antibodies, even in women who've had surgery or radioactive iodine, they can cross the placenta, so keep an eye out for that. And remember that moderate doses of antithyroid drugs are safe during breastfeeding, but there's a growing trend for using PTU now throughout pregnancy because of the reducing risk of birth defects. So thank you very much for your attention. It was lovely seeing a bit of the talk just before mine, and then the little bit of the extra talk afterwards. And if anyone's got any questions, there's my email, and I'm on Twitter at Dr. Pete Taylor. So if anyone's interested in any further questions or any collaboration, we're very happy to hear from you all. And that's all from me. Thank you very much.
Maybe you can comment on indications for surgery in the setting of thyrotoxicosis in pregnancy and timing during pregnancy. And I saw you had a comment on radiiodine. Maybe you can expound on radiiodine use in pregnancy.
So the first one is surgery. So I try and avoid it at all costs. When you've got a woman who antithyroid drugs are failing, and that's either because of side effects, are usually derangement in liver function, or you just can't get on top of it, you can consider surgery, but we'd only do that in the second trimester. I've done a thyroid clinic in Cardiff for now 10 years as a consultant, and I've only used it once. So it's quite rare that we'd have to do it. We really try and avoid it. Radioactive iodine, sorry if I didn't make that clear, we don't recommend radioactive iodine anytime near pregnancy. So the guidance in the UK is at least 6 months, and ideally a year. I like to be at least a year before pregnancy, simply because the antibody levels are still quite high. I don't always trust my patients, so I don't want them getting pregnant too quickly afterwards. So I really don't want radioactive iodine in any woman who is remotely planning a pregnancy. I'd rather get it settled with antithyroid drugs first. But occasionally I've used surgery when women who've got bad thyroid eye disease, so we're a bit generally reluctant to give radioiodine. We've got bad TRAbs, bad thyroid. We're not getting on top of it, but is quite keen to get pregnant relatively soon. I think surgery, if you've got a good surgeon, is a reasonable option. The problem is you need a high volume surgeon, otherwise your risks of complications go up. And the surgeons in Cardiff generally just do a lot of endocrine surgeons. So they do a lot of cases, so I'm quite happy. I would be less happy if my surgeon wasn't doing quite so many cases.
Okay, thank you for that. Any other question from the audience? Oh, yeah.
I'm Dr. Amal from Sudan. Just I want to ask if ever we can use anti-thyroid treatment for severe hyperemesis or transient thyrotoxicosis, and when we can decide for that. How?
Yeah, so it's a really tricky one. There are a few small studies showing that the thyrotoxicosis with severe hyperemesis are associated with slight issues with premature birth. But the problem is the data that is looking really harmful is lacking. So if you are very confident it's not Graves and it is gestational transient thyrotoxicosis, the advice would be not to treat, because you've got the risk of the drugs, and it's probably safest just to do rehydration. I'm not aware of any evidence that treating the thyroid toxicosis improves the vomiting, so the advice would be not to treat. I appreciate it's always a bit easier if you've got a good assay for thyroid receptor antibodies and you can be very confident. But I think if you've got any doubt, it's probably, and you're not sure, it's probably worth having a bit of an MDT to discuss it. I would be a bit reluctant just doing it off my own back personally, treating for something I thought was most likely GTT. But we did have one case I can remember where the woman had extremely high thyroid hormone levels and it wasn't coming down. So I did treat at that point because I was just nervous we were missing something else. But try and avoid it.
Thank you.
Okay, so just one last question.
Thank you for that wonderful presentation. My name is Dr. Ann. I have a question concerning a baby born from a mother who is thyrotoxic. How do you handle the TFTs? And in case you find they're already having the hypothyroidism, how is the baby handled? Although you're going to call the pediatrician, but I'm curious of how the child born from that situation should be handled.
So in the UK, we try and detect it early by doing additional growth scans throughout pregnancy. And looking at fetal heart rate. We really try and get those thyroid hormone levels down before the second trimester. And I let the pediatricians know early. The key thing really is we're quite aggressive in our clinic, so we don't tend to have too many problems with fetal hyperthyroidism. The very rare cases, and I'm afraid I leave that for the pediatricians to manage. I've got no experience of that. I'm an adult doctor, so I've passed that back on. In terms of the one thing I will say is there is this, when some of my junior colleagues have seen patients sort of around about week 30, the thyroid hormone levels are normal, but they've been a bit reluctant to stop the PTU. I would encourage actually to try and stop the PTU or carbimazole, whichever they're on, if the thyroid hormone levels are good and you're getting towards the end of pregnancy, just to reduce the risk of having fetal hypothyroidism. But there's always that little bit of nervousness. That's fine, just stop it and then make sure you're checking the bloods again regularly. But I don't have much experience, I'm afraid, of neonatal thyrotoxicosis.
Good, so thanks for having me back on stage. Now we're going to tackle a huge topic, and has been quite topical during the COVID pandemic. And this is now COVID and diabetes, and we look at the associations between COVID and type 1 and type 2 diabetes. So that will be the outline of our talk, brief introduction. We'll look at the risk profiles for COVID-19, not only with regard to diabetes, but also other cardiovascular diseases. Then we'll look at why exactly is diabetes a significant risk factor for increased morbidity and mortality and adverse cardiovascular outcomes in the setting of COVID-19. Then we'll look at the treatment with regard to mild, moderate, severe COVID with concomitant diabetes. Then we'll just briefly talk about how we've switched our practice in the post-COVID pandemic with regard to diabetes care. So as you're aware, we know the vulnerable classification as per the CDC, and those individuals who have COVID-19, you must look out for hypertension, diabetes, obesity, underlying cardiovascular disease, as well as all these other comorbidities. And these are individuals who will definitely have adverse clinical outcomes in terms of having COVID-19, longer hospital stays, likely a higher risk for having invasive mechanical ventilation. So you must actually screen your patients at the outset for any of these particular conditions and consider any of these high-risk groups. Now, it's a bidirectional relationship between COVID-19 and diabetes, and at times we don't know what has come first. You can have the issue about diabetes causing adverse outcomes. We'll discuss about that and we'll review the data. Or you can also have significant metabolic derangements in people who have diabetes and now contract COVID-19. Then you have the issue of new onset COVID, which you're well aware, and we'll look at the pathophysiology of how COVID-19 can actually trigger diabetes in patients, and we've seen that in clinical practice. We do know that in Africa, for example, we may not know the exact reason, because sometimes you have people, we have a huge background of pre-diabetes in our population. We also have a huge burden of undiagnosed diabetes, so people develop COVID-19, come into a hospital facility, you pick up hyperglycemia, but it could have been either undiagnosed type 2 diabetes or pre-diabetes, which has now been pushed over into overt type 2 diabetes through COVID-19. So at times it could be difficult in our setting. You're aware that our undiagnosed burden in Africa is as high as 70%, and hence why you must be able to have diabetes screening programs being carried out all across the continent, try and avoid people now being picked up late with complications. So let's look at the risk factors and let's review the data. So this is the largest systematic review from China. And as you can see that in that patient data set of almost 46,000 patients, hypertension and diabetes were seen as very, very common comorbidities in the setting of COVID-19 with significant adverse outcomes, meaning that you have either prolonged ICU stay, mechanical ventilation, prolonged ICU stays, and eventual morbidity, plus cardiovascular events. This particular series by Meng et al. Showed that hypertension was actually the commonest comorbidity seen in the Chinese data set, with around 3,000 patients at 53% of all patients having COVID-19 being hospitalized. Also, with this, Guan et al. Showed in around 1,600 patients that people who have diabetes fare significantly, they have worse outcomes in terms of their cardiovascular outcomes, in terms of hospital stay. As you can see, they are 34.6% as compared to age and sex-matched non-diabetic controls. So it's very, very clear that hypertension and diabetes are very, very common comorbidities in the setting of people who have complications in the setting of COVID-19. And most, as you can see there, there's almost more than double the risk of adverse cardiovascular outcomes or even death or mortality if you have diabetes and COVID-19. The risk of contracting COVID-19 is fairly balanced across the two gender sets, but as you can see, there's a twofold increased risk of males faring worse as compared to your females. Also, you have any pre-existing cardiovascular event, then your outcomes are also worse if you have COVID-19. And that definitely was shown in all this data that we're looking at here. So let's now look at data in Africa. And this was the first data set came from South Africa, from the Western Cape. And it showed they were looking at causes of mortality across patients in the Western Cape who contracted COVID-19. So 52% of them, the direct cause of death was attributable to diabetes, 19% to hypertension, and as you can see, 9 to chronic kidney disease, HIV only 12. So we thought that HIV would be a more significant risk factor for morbidity and mortality in the setting of COVID-19 as compared to hypertension and diabetes. But clearly you can see here up to at least 70% of all-cause mortality in these patients is directly attributable to hypertension and diabetes. Now, interestingly, if you look at TB, having previous TB portends a higher risk for complications as compared to having, previous TB is higher risk complications compared to current TB, and is likely because of post-TB bronchiectasis. So again, that now gives these patients lower lung reserve and they're more likely to develop complications as compared to those who have active TB and are on treatment. So that's the key take-home message there. Now that's in South Africa. Now let's go to my country, Kenya. And this is where I work, the Aga Khan University Hospital in Nairobi. And we had a very comprehensive retrospective data set from our hospital from 2020, just looking at the cardiovascular outcomes, patient characteristics in all these people who are hospitalized with COVID-19 in our facility. So let's compare the data with what we are seeing in other areas. So for all these patients at baseline coming into hospital, 27% of them were diagnosed with diabetes. And then there are those who had diabetes diagnosed during the course of the admission, which could be due to effects of steroid use, for example. But as you can see, close to 50% of individuals after admission and through the course of the admission were diagnosed with diabetes. Hypertension, close to 37%, if you compare those at baseline who are diagnosed to be hypertensive and are being admitted with COVID-19, and those who develop it during the course of the admission. So the key take-home message, we've seen the data, both from the West and in Africa, hypertension and diabetes are the two significant causes of adverse outcomes in the setting of COVID-19. For all outcomes, if you're looking at admission, if you're looking at invasive mechanical ventilation, prolonged length of stay, and eventual morbidity and mortality in these patients. So what's the link? Why exactly does diabetes cause this particular increased risk? One is that we know, apart from just the immune dysregulation that happens in diabetes, if you look at the lung parenchyma of all these patients, and if you look at lung mechanics, diabetics are actually more predisposed to developing lung infections. This is because of, one, you have an overall decrease in their lung capacity and function. FEV1 and forced vital capacity are significantly reduced in these patients. They have peripheral airway obstruction. They have reduced mucociliary clearance, so their ability to actually clear infections and also the high likelihood of them having increased viral shedding is quite high in these particular patients. increased lung fibrosis and inflammation because of hyperglycemia, which causes increase in their production of free radicals, oxidative stress, and other mechanisms, and just simply the respiratory mechanics. So you have decreased respiratory muscle strength because of autonomic neuropathy in these particular patients, and defective muscle metabolism. Now, looking at previous pandemics, we know that this is not new. We already had the SARS-CoV-1 pandemic in 2001, 2004. We had the H1N1 pandemic back in 2009, and also the MERS pandemic in 2012. And in all these particular pandemics, we've seen patients who had diabetes fared fairly worse as compared to their age and sex-matched non-diabetic counterparts. So we already know this data from previous pandemics with a very good, robust evidence. And we look at even these particular registries with follow-up, what exactly happens to these patients who have diabetes. So what do we know? There's no increased risk of contracting COVID-19 if you compare diabetics and their age and sex-matched counterparts. No difference in contraction rates between type 1 and type 2 diabetes, so they are fairly equal. But the risk of complications is much higher and is 5-fold greater in those who have type 1 diabetes as compared to a 4-fold increased risk in those who have type 2 diabetes if you compare them to the general population. So people who have type 1 diabetes, we have to be much more cautious. We'll discuss about their management plan shortly. And also another key group we must consider are those mothers who have gestational diabetes or pre-existing diabetes in pregnancy. Risk of complications are much higher. They require much close observation, tighter glycemic control, and if they go on mechanical ventilation, again, you remember that the fetus will also impair the respiratory mechanics. So you're going to have a much harder time to wean off the vent, and you may have to make a very crucial decision about early intervention in terms of cesarean section, as long as the baby has crossed 28 weeks and you can have viability and maturity within an incubator. So you must make that difficult decision with an obstetrician. So let's now see, why exactly is diabetes linked to higher complications? And we'll look at data with regard to glycemic control, and also with regard to the data sets across different countries. So in China, you can see the case fatality rate is much higher, 7.3 versus 2.3% general population. If you look at the US, for example, those who have diabetes, 14.8% if you have diabetes. If you have diabetes and poorly controlled blood sugars, diabetes with hyperglycemia, it goes up to 28.8%, as compared to 6.2% in the general population. Those who are from the UK registry, if you look at the retrospective data, the case mortality rate is as high as 260 per 100,000 versus 27 per 100,000. So it's very clear, diabetes across various data sets does portend a higher risk of complication and worse morbidity and mortality. And like I said, it's cumulative. So if you're diabetic with additional risk factors and you're more than 55 years of age, then you're more likely to succumb to these complications. So hypertension, obesity, smoking, chronic kidney disease, underlying lung conditions like COPD will definitely have a higher risk of adverse cardiovascular outcomes. And you must ensure that for all these particular patients, screen them appropriately. There are those who will want to even manage them in a critical care setting and watch very closely for the development of complications in these patients. And remember, these risk factors are cumulative in terms of your likelihood of developing an adverse outcome in the setting of COVID-19. Again, the likelihood of having deranged metabolic impairment, DKHHS in this particular patient, significant hyperglycemia is much higher. So closely monitor your blood sugars, especially in those who are admitted, those in a critical care setting, to avoid them actually getting complications, either hyperglycemia with DKHHS or even hypoglycemia because of poor monitoring during your critical care setting or treatment. So the key thing that you have inflammation and insulin resistance driven by COVID-19. And these individuals tend to have impaired interferon-1 alpha responses and low interferon, so impaired type 1 interferon and low interferon alpha responses, causing increased viral entry and increased viral replication in the setting of SARS-CoV-2 infection. Interleukin-6 and lactate dehydrogenase go up, and they're independent markers of disease severity and adverse cardiovascular outcomes in your patients. And again, you have increased level of furin, which is a type 1 membrane-bound protease, and will increase the ability of the virus to enter and also increase cell replication. So you have COVID-19 viral-induced inflammation, which causes increased insulin resistance. And also, you can also have the other pathway happening in terms of the reverse. So worsening hyperglycemia, causing increased oxidative stress with inflammation, endothelial dysfunction, and thrombosis, eventually causing worsening dysglycemia in your patient. So this was also discussed in the morning. So the key things to remember that you have now the SARS-CoV-2 infection, causing increase in your inflammatory cytokines, increase in your natural killer cell so increased natural killer cell which will produce more interferon gamma, increase in your reactive oxygen species and interleukin-6, increase in your RAS activation, you get a procoagulant state with increased thrombosis, and all these factors eventually lead to increased insulin resistance, hyperglycemia, which also worsens cardiovascular events and increased thromboembolism, and this will lead to cardiovascular mortality and direct damage within the lungs itself, as well as increase in your endothelial dysfunction and vascular damage. And this, as we saw in the morning, is mostly through activation, direct entry of the SARS-CoV-2 onto your cells and activating the AT1 receptor pathway, which predominantly causes an increase in tissue injury and downregulation of your protective pathways, which include your MAS1/R receptor pathway, which actually are anti-inflammatory and anti-fibrotic. So downregulation of this pathway, increase in this particular pathway, thereby potentiating destruction in both all cells, pancreatic beta cells, cardiac myocytes, lung parenchyma, and thus causing the complications. The likelihood of a cytokine storm in diabetes also is much more common because you tend to have immune dysregulation, which now brings about a feedback loop that will now cause increase in cytokine production and also activation of your coagulation system with increased thrombotic events. And this is mostly driven by increased monocyte production with subsequent interferon alpha, interferon gamma, T-cell recruitment, and these are all driven by hyperglycemia, increased pro-inflammatory M1 macrophages, imbalance between TLP1 and TLP2, and a reduced natural killer cell activity. With regard to obesity specifically and COVID-19, we know that there's a higher risk of complications in terms of the risk of pneumonia, the risk of mechanical ventilation, and prolonged hospital stay. And these again are due to impaired or immune dysregulation, which can occur again because of impaired clearance mechanism, for example, antibody-dependent cellular cytotoxicity, reduction in your natural killer cells, reduced CD4, CD8 cells, and also leptin adiponectin balance. So again, they have a decreased lung reserve, they have impairment of their diaphragm contractility, cardiorenal stress, increase in blood pressure thrombogenicity, immune dysregulation on this end, which all lead to a reduction in cardiorespiratory fitness, increased cardiovascular events, and eventually causing increased severity and increased mortality in the setting of COVID-19. With regard to new onset diabetes, we know that this article came out around June 2021 in the Lancet. And we now know that there is a precise link between viral infections and increased autoimmunity. So the virus itself can gain direct entry into the pancreatic beta cell and activate the AT1 receptor pathway, and thereby leading to beta cell destruction. We know from previous studies that there is an increased connection between autoimmunity and viral infections, for example, mumps and Coxsackie, which can lead directly to beta cell damage. There is a large data set from the US called the TEDdy study, which shows that there's an increased activation of autocell autoimmunity following winter months and viral infections. And also in previous pandemics, we saw that SARS-CoV-1 as well in 2001 did actually show an increased incidence of diabetes in this particular patient, directly attributable to the virus. And from this registry, 10-year follow-up data showed that most of the disease resolved in the patients for around after 3 years, but 10% did have persistent diabetes, which has remained. So again, we'll let to see whether we'll see the same pattern with SARS-CoV-2. And to be able to follow this, the COVID DIAB registry has been set up, and these are the criteria for patients to be recruited into this particular study. So a confirmed COVID PCR, documented hyperglycemia, negative history of diabetes, the normal A1C previously, and then from there the patients are being followed up. So there's 1 year now into this registry data, and we'll see whether we'll have resolution of diabetes or whether it'll be persistent after a certain time period. So let's now look at the care, and these are the key things that we'll just highlight in terms of how we care for patients who have COVID-19 and diabetes. So in general, for those who are being managed on home-based care, ensure their glycemic targets are ranging between 5 to 7 millimoles per liter, and their 2-hour postprandial sugars are between 5 to 10 millimoles per liter. Those who have type 1 diabetes, a bit more caution. If you have significant hyperglycemia, check for plasma ketones. If they're more than 0.6, they should contact their healthcare practitioners. Use of steroids, we know that they're very key in the setting of moderate severe COVID-19. The key thing that we learned is that those who don't require oxygen, who have mild COVID, if you give them steroids, then their worst cardiovascular outcomes are shown by the recovery trial. As you can see here, those who do not require oxygen and you give them dexamethasone in addition to usual care, the outcomes are worse in terms of their mortality. Those who derive benefit from the use of steroids are those who require oxygen, moderate COVID, or those who have severe COVID requiring mechanical ventilation. So please use your steroids where it's mandated. And as soon as you don't require your steroids, you don't require oxygen, withdraw the steroids immediately. That will give you better outcomes in your patients. For those who are hospitalized, again, you target a blood glucose reading of around 7.8 to 10. In the setting of moderate severe COVID, withdraw certain drugs, for example, SL2 inhibitors as well as metformin, because metformin can cause an increased risk of lactic acidosis, and you can get an increased incidence of euglycemic decay with SL2 inhibitors. So withdraw these drugs and preferentially use insulin. TZDs as well, because they can cause fluid retention, can actually precipitate ARDS with fluid retention. So again, withdraw most of your oral drugs in the setting of moderate severe COVID, and please use insulin as your key drug of choice. Now, there's significant hyperglycemia, so we do prefer to use basal bolus regimens or insulin infusion pumps, and you ensure your blood glucose targets range between 7.8 to 10, and this is what is required for all your patients with moderate COVID in the wards or those who are critically ill in the ICU. Thrombosis is another key thing, so remember that those who have high D-dimer values, which are normally done at the point of admission, you can consider to put them on full dose anticoagulation, but you stop the anticoagulation at the point of discharge, and now we don't routinely recommend the use of full dose anticoagulation post-discharge, which was previously the case as per the new guidelines. And you can use low molecular heparin or unfractionated heparin with APTT monitoring in the inpatient setting. Again, like we said, you can consider the use of DIP4 inhibitors or GLP-1 in mild to moderate, but for those who are having significant hyperglycemia, then insulin will be the drug of choice. And like we said, we always withdraw SL2 inhibitors and metformin in the setting of moderate to severe COVID. Now, if you have DKA, what happens? So the fluid regimen will actually vary, because we normally have a use of a lot of fluids in the setting of DKA as per the usual protocol, but you want to have your patients on the drier side to avoid ARDS. So now the regimen that we use, that you only give them a small bolus of 500 mils of normal saline, then 1 liter slowly over a 24-hour period at 42 mils per minute to avoid fluid overload and ARDS in these particular patients. Manage them in the intensive care setting with a multidisciplinary care team. So have your intensivists, your ICU critical nurses, your nephrologist, and your endocrinologist all working together to ensure adequate fluid balance in your patient while ensuring good frequent glycemic monitoring to avoid hypoglycemia as well. Also in the setting where you have to withdraw steroids, so you gradually titrate your dose regimens. If the steroids are withdrawn, come down on your insulin dose as well. And again, also look out for development of decay in all your patients who may have significant hyperglycemia. So for infusions, we normally begin at 0.1 units per kg. We target a drop of 4 millimoles per hour, but at times, if you have significant hyperglycemia, you may actually use much bigger doses and anticipate much bigger drops. Once your sugar is below 14, come down to half that rate, 0.05 units per kg. Like I said, restrict your fluids to maximum 1.5 per 24 hours. Keep in mind the fluid balance with regard to other things, feeds, your vasopressors and other things, so you work with your critical care team very closely. Introduce your basal insulins early on, and this should be at least 30 to 50% of your total dose. As you're weaning off the pump, you reduce your insulin dose to keep your target of sugars within this range, 7.8 to 10. For those who are staying in the ICU with prolonged hyperglycemia, you can keep them on a low-dose infusion continuously, and you train your nurses not to stop the pumps immediately, because that will cause rebound hyperglycemia. And also you can also give prandial dose of insulin if they are on TDS feeding, for example, through NG feeds, or if they're able to, if they're not intubated, then you can also use, in addition to your insulin dose, you can use prandial short-acting doses of insulin together with the pump. Once out of the critical care setting, review their sugar charts, review their knowledge about the injection technique, pen devices, monitoring. Let them have a diabetes education session. How to recognize hypoglycemia is also very, very key. And when they come to the clinic, you assess what support they have and also check their sugar readings and wean off insulin in the outpatient setting, especially if steroids are withdrawn, if they require them during the course of their treatment. So thank you for that, and that's an overview with regard to COVID-19 and diabetes. Thanks.
Thanks a lot. You know, the title is a bit intriguing to begin with. My presentation is very simple. I'll have a quiz, I'll give you a real-life clinical scenario, and then there'll be a single slide with take-home messages. Okay, so very easy question to begin with. Which of the following is the most important hormone sans which life will cease to exist? As I said, this is a A-level GCSE question, not something which I expect from people who are subspecialists in endocrinology. Yeah, brilliant, thank you. As I said, if I was just going to give you this message, it would have been very, very simple talk. Let's keep pushing the boundaries at the moment. Next question. How much cortisol are you producing? So let's see, show of hand. Anyone for A? You can raise your hand, you know.
There is one person for A.
A.
Yeah.
Anyone for B? No one. One for B.
Yeah.
Anyone for C? Anyone for D? It seems there is no answer, isn't it? Anyone for E? So.
E, there is one.
Right.
Yeah.
So will one of you volunteer to give me the answer here? You know.
I go for A.
Right. So in physiological conditions, we just need around 8 to 10 would have been a bit more precise answer for equivalent of cortisol, right? I'll give you a reference as I finish my slide deck, but this is a very important point you have to keep in mind, right? So our daily physiological requirement for cortisol is relatively low. Keep this number in mind as I go to the question number 3. So, sorry. Which one of the following is recommended replacement dose for prednisolone in secondary adrenal insufficiency? For example, if somebody goes through a pituitary surgery, post-surgery, how much prednisolone dose is required? And anyone who wants to volunteer, who is confident enough?
Okay, anyone?
So I'm talking about secondary adrenal insufficiency, and I'm talking about prednisolone here. So it's not hydrocortisone in primary adrenal insufficiency I'm talking about. Make my day, you know, be brave.
Somebody's saying A.
Yeah, it looks like there's one person for A.
All right, okay.
To 1 milligram.
Right, at least, you know, whoever it is, it's he or she's brave enough to say these things.
Congratulations.
No, it's not the right. The right answer is B, 4 to 6 milligram per day of prednisolone is needed for secondary adrenal insufficiency, right?
Yeah.
As I said, if anyone gets all the right answers, they'll get a, you know, gift hamper from the host. So it doesn't look like the case. That's why I've committed to it. So the last question I've got is, which one of the following is correct equivalent dose for prednisolone? So for prednisolone 5 milligram, which one of the following is the correct equivalent dose? If you've got access to Google, you can in fact put it in, do a Google search and give me an answer, in fact.
Yeah. 0.25, the answer is A.
it would have been a bit higher for dexamethasone. I would have said 0.75. Correct answer is hydrocortisone 20 milligram. So all I can say, I've shown you 4 questions with, the key message. If you can remember it, it will make your life very easy whenever dealing with anything steroid related. Cortisol is the key hormone, absolute essential for life. Sans it, our existence ceases. Our daily cortisol requirement is relatively low, 8 to 10 milligram per day under physiological circumstances. In primary adrenal insufficiency, we give around 15 to 25 milligram of hydrocortisone. And maybe for secondary adrenal insufficiency, we give 4 to 6 milligram of prednisolone. And I just heard a very interesting lecture prior to joining you guys on COVID and diabetes. Which medication, was the most effective in COVID-19 severe infections with hypoxia? If there is one answer, it would have been dexamethasone. So the dexamethasone 6 milligram was used in COVID after the recovery trial. If we do the equivalent dose for dexamethasone 6 milligram, it will be around 8 to 10 times the normal physiological dose we were giving in COVID patients. And it was having such severe metabolic implications also, right? So I just wanted to reinforce these things. I'll use it as part of my take-home message also. Let's come back to a simple case presentation. This is from a lady who was under my follow-up in October 2018. 62-year-old woman came in with change in personality, very short history, from someone who was very sensible, mature. Within 4 weeks, the husband has noticed that she was quite euphoric, difficult to control. And one of the days she walked around 100,000 steps. I don't know how many of you do long distance running and all. I'll probably not cover this number of steps, even if I'm doing a marathon. So prior to admission, she was well in herself. She was not on any medication. So when she was referred to us it's been 4 years now, October 2018, she was referred to the psychiatrist colleagues who started her on an antipsychotic medication. But the only reason they contacted the endocrinologist was that she had high blood pressure, right? So when we examined her, BMI was very modest. It was 28 kilogram per meter square. There were no hypercortisolism related signs then, proximal myopathy, facial plethora, thinning of skin, but she was definitely hypertensive. So as endocrinologist, obviously we were a bit interested in it because apart from hypertension, she was hypokalemic also. So as you know, combination of hypertension and hypokalemia excites an endocrinologist. We think about Conn syndrome, Cushing syndrome, and these are the 2 primary diagnoses which come to our mind. So we did a renin-aldosterone ratio for her, which was normal, but just because the symptoms were so aggressive kind of, and her the personality had changed so drastically kind of, we thought there is something which is more paraneoplastic or neoplastic rather than some simple benign lesion. So we did a urinary free cortisol measurement, which was extremely high. Midnight salivary cortisol was high. Low dose dexamethasone, the cortisol was not suppressed. And we carried out a ACTH measurement for her. ACTH levels were extremely high. So in a sense, this woman with only 4-week history of alteration in personality, hypertension and hypokalemia, had a ACTH-driven hypercortisolemia. And this is what my title of the talk was. There is a method in the madness. So this, we were lucky that our psychiatrist colleagues referred her to us. And so initial diagnosis, we thought there is a ACTH secreting tumor somewhere, which is leading to a rapidly progressive Cushing syndrome. The witch hunt started about where is the site of the tumor. While we were investigating her, we started her on what is known as block and replacement therapy of metaropon and dexamethasone. Happy with everything so far? Yeah, idly speaking, I would have liked to see the audience and waited for the response also. So the witch hunt for the tumor started. We carried out a MRI pitch tree for her, which was normal. We did inferior petrosal sinus sampling for her, which was normal. A somatostatin scintigraphy was normal. A whole body CT was normal, which led us to do a gallium PET scan for her. And if you remember the date, there was a delay afterwards in getting the gallium PET, and within the next few months, while we were investigating her radiologically, her appearance changed. She started to put on weight. She started to have more mood swings. There were overt signs of hypercortisolism, which were not there before. She had pigmentation of skin, and which was very ACTH-driven kind of, and thinning of scalp hair, which was driven by adrenal androgens. And her blood glucose readings, she was not known to have diabetes, remember, started to go up. And repeat CT, we saw the impact of ACTH. There were bilateral adrenal glands which were enlarged. And she was getting, all the clinical signs of hypercortisolism. She was getting the wedge fracture in the spine also. So steroids, as I said, is very potent hormone, has impact on metabolism and bone, mood. Finally, we managed to get a gallium PET for her in July 2019, and we found out that she's got a pancreatic body, 2.5 centimeter, well-defined lesion. So think about ACTH, which is normally secreted by the corticotrophs in anterior pituitary gland. In this lady, there was an ectopic ACTH production from the pancreatic body from this well-defined 2.5 centimeter lesion. So we twice the surgery was planned. One reason or the other, it was cancelled. Finally, she got her surgery. It was a long delay because system got paralyzed from March 2020 with COVID-19 pandemic. She underwent distal pancreatectomy with regional lymph node removal. The histology of the sample confirmed a well-differentiated neuroendocrine tumor with a low Ki67 score. So the final diagnosis for our lady was that her euphoria, her hypertension, hypokalemia, diabetes was linked with ectopic ACTH secretion from pancreatic ACTH secreting neuroendocrine tumor. And I've shown the two pictures here. This is before surgery, and I took permission from her to share the pictures. And you can see post-surgery on a follow-up visit, her skin seems to have normalized, color and the hair are back. Diabetes is in remission. Blood pressure is under control without need for any medication. And she's feeling much calmer, much stable, much happier. So in a sense, I don't want to take too long a time for you. I wanted to keep my presentation very simple and informative if I can. Cushing syndrome may present with mania, hypomania, or neuropsychiatric disturbance. The key thing you have to remember, and I'll reinforce, the amount of cortisol we produce on a daily basis is very small. As I had mentioned to you in one of my earlier slides, we only require around 4 to 6 milligram equivalent of prednisolone, 15 to 25 milligram of hydrocortisone, around 0.75 to 1 milligram at the most of dexamethasone, if I take the bioavailable or biologically equivalent doses. Iatrogenic Cushing and pseudo Cushing is far more common in clinical practice than the rare case I've shared with you. Hypercortisolism affects your blood pressure, can lead to hypokalemia, not always, but in small proportion of patients, can lead to metabolic mayhem as far as impaired glycemic control and type 2 diabetes is concerned. It leads to hypercortisolemia, leads to insulin resistance acting at GLUT4 receptors. So lastly, ectopic ACTH excreting tumors can present with rapidly progressive clinical features of hypercortisolism. So I wanted to keep my slide deck very simple. This is another ectopic ACTH excreting metastatic parotid tumor case we had published in clinical case reports in endocrinology. It's been 6 or 7 years. Hopefully the one I've presented to you should be published in coming months. Take home message, just to reinforce to you again, cortisol production under physiological state is small, 9.5 to 9.9 milligram per day. There is increased risk of vascular, bone, psychiatric, and metabolic complication with long-term, what is deemed as low-dose steroid use. So please be aware of iatrogenic Cushing as well as adrenal suppression in patients on long-term steroid therapy. And one of the papers, we carried out a systematic review which was published in Dubai Diabetes Endocrine Journal in 2020, was done by one of the students in University of South Wales MSc course, Dr. Nadu Kukiko. So excellent work she had done as part of her MSc project. So I just want to finish here. Don't want to waste too much of your time. All I can say that every day we are learning more. I'm learning more on every single day. If there is anything you want to ask, discuss, feel free to ask. Thank you.
Thank you, Prof. Atul, for that interesting presentation this afternoon. My name is Khadija and I work in Nairobi, Kenya. I just wanted to ask, why did the patient possibly develop overt signs of hypercortisolism after you initiated the therapy?
Right. So the thing was that if it was a slow brewing hypercortisolemia, which normally is seen with the pituitary-based lesion or adrenal-based cortisol-secreting lesion, it may have taken time for her to develop the overt signs at presentation. But because her presentation was dramatic, she didn't have those signs to begin with, and it took us some months to get on top of it. So the signs developed, she presented in around October 2018. We noticed the signs by, end of November, early December, but we controlled them. So what we thought was that the onset of her ACTH-driven hypercortisolemia is relatively very quick. So we got the hypertension and hypokalemia, which are more vascular and metabolic effect of hypercortisolemia, but the rest of the soft tissue signs and all took time to develop. And probably one reason is that, the suddenness of everything.
Thanks, Professor Atul, for that excellent talk. In our setting in Africa, we normally struggle with imaging in the setting of neuroendocrine tumors. So what would be, we don't have access to gallium scanning. What other modalities of imaging would you consider in this patient? And probably, what about brain imaging in this patient? Would it be
we carried out an MRI. The first thing when you think about ACTH-driven hypercortisolemia is it has to be in the pituitary gland. But MRI pituitary came back as all clear. The Endocrine Society guidelines again reinforce that even if it's normal, you should think about doing IPSS, inferior petrosal sampling, which again was normal in this case, because we still thought, is this a microscopic lesion which is not picked up on MRI, which we have missed. Eventually, I was quite convinced when she presented that it has to be a neuroendocrine tumor or a malignant NET, because the way, or paraneoplastic ACTH secreting lesion, because her onset of symptom was very quick, very rapid. Normally in a pituitary, I would have assumed it would have been relatively slow brewing kind of. In here, from somebody who was previously fit and well, within 4 to 6 weeks, personality changes. So a CT thorax would have been a good modality. I think you need a good radiologist support in here. And ACTH being secreted by pancreas again is only defined in a limited number of case reports. My focus initially was more looking at the bronchogenic NET rather than, pancreatic NET. But again, you just need to focus on those areas and discuss it with your own radiologist. Can they have more dedicated image, more, focused on potential NET sources?
Okay, thank you. We have one more question.
Thank you, Prof. My name is Eugene. I'm Prof from Ghana. I noticed after the low dose dexamethasone suppression test, you went ahead to do the sampling, but I didn't see the high dose dexamethasone suppression. Is it that it's not part of your protocol in your institution? You go straight to the sampling.
We don't do high dose dexamethasone suppression tests. There is, as the things stand, the bar for distinction between pituitary versus ectopic ACTH secretion with high dose is not as sensitive or specific. So in our institute, we don't do high doses at all. As I said, the protocol from the Endocrine Society is to go for MRI PET, whole body CT, if and IPSS, and then go for whole body. But high dose DEXA suppression tests we don't do any longer now.
Okay, that's interesting. Eric.
Maybe to follow up with that question, what about comment on late night salivary cortisol?
Salivary cortisol we did. I probably didn't read it, but midnight salivary cortisol was high. The 3 steps in hypercortisolemia, your pre-test clinical probability was high. He had strong biochemical evidence, urinary free cortisol, midnight salivary cortisol, and low dose DEXA suppression test. We didn't need all of this evidence because, it was a barn door ectopic ACTH secreting lesion, which such significant signs of hypercortisolemia, but we did midnight salivary cortisol for her. I showed it in one of my slides.